This is our early morning interactive ECG session. It's always interactive and it is fun. And we'll go quickly. We have half an hour. We'll try to cover as many ECGs as possible. This is a very interesting problem, and I keep seeing these cases every once in a while, and I keep showing these cases. 48-year-old lady, she had a fall at home and was in severe pain. But after that, she went into severe dyspnea and was in florid heart failure. She was brought into the emergency room, and this ECG was recorded at that time. As you can see, she is in sinus rhythm, and what is remarkable has been marked here. There is ST elevation, right? And troponin was done. Troponin was borderline positive. Echo showed a LV function of 25%. And this was a peculiar pattern of echo LV contractility, where the basal segments were contracting well, but the apical region, anterior region, was not contracting. And the LV seemed almost ballooned out. And after a few hours, this ECG was seen. So it is the same patient, severe dyspnea, LV failure, EF of 25, and this remarkable ECG ST elevation in AVL and in some precaudal leads. Now it has become deep T inversions in the anterior lead. We talk about Valence sign, isn't it? Proximal LAD occlusion. When during the pain, the ECG seems unremarkable, but when the pain subsides, the patient has deep ST elevation, deep ST inversions. So in this patient, then because of the borderline positive troponin and this kind of pattern, obviously the first thing you are looking at is whether there is any LAD occlusion. And this is the patient's angiogram. Right coronary is normal, and what do you think will happen here? This is also totally normal. Left coronary system also totally normal. And the LVF then subsides with diuretics, and the patient improved. What she had is this. I keep showing these cases every once in a while. Takotsubo cardiomyopathy. Have you heard of this? Takotsubo is Japanese octopus trap. And this is just like our LV here. The basal segments contract very well. So the basal segments are contracting. Come, Shailesh bhai. Whereas the apical anterior segment is all ballooned out. And the way to treat this is we just need to be conservative here. We have ruled out a myocardial infarction, ACS. We need to treat the failure. We need to anticoagulate if necessary, because this part is totally hypocontractile. Patient might get clot formation, and that can embolize. Patient can get a stroke. And do supportive management. And in a few days, this will happen. The T wave inversions, which were very prominent, are now becoming less prominent. And this is the next day. They are becoming even less prominent. And the LV function gradually improves over a period of time. In some patients, it will become totally normal. In some patients, it takes a few more days for it to become normal. But we need to understand, in Bollywood movies, it used to be shown that somebody's died and the wife also gets severe heart attack, or I would put it this way. The daughter's marriage is there, और समधी आके बोलते हैं कि हमको दहेज में ये चाहिए, and then the daughter's father gets a heart attack. Probably they are getting something of that kind. It's intense catecholamine release at that point of time. Adrenaline and NORAD released by the body. And that has direct effect on the myocardium, and that causes intense stimulation of the catecholine stimulation of the myocardium. There is severe LV dysfunction. Patient goes into failure, and this happens. They need to be managed well. Patient can even get ventricular arrhythmias at that point of time and cause sudden cardiac death. So what they used to show in Bollywood movies was oral is right. So this is Takotsubo cardiomyopathy. In fact, just a week back, I had a 60-year-old lady who had severe food poisoning, vomiting, loose motions, and then went failure. And again, same, troponin borderline positive. STs were not very impressively elevated like in this patient, but there was some ST elevation across inferior and anterior leads. LV function of 20%. But coronary is normal and she gradually improved. Her heart is now, LV function is now 45%. But very similar pattern, Takotsubo cardiomyopathy. This is something you should all be aware of, and we do see that. Sorry. It is probably due to the intense catecholamine secretion. There is an ionic imbalance between the epicardium, myocardium cells, and that gives rise to these ST elevations. Just like what you get in Brugada syndrome, there is a difference in the epicardial and myocardial ionic channel fluxes, and that causes slight ST elevation. Yeah, in most of these patients, generally it improves within a few days. And you more or less see the pattern, what is happening in this patient. In a couple of days, you know that the LV function is improving, heart failure is becoming lesser. So, you know, you are hopeful that the patient will improve. But in these patients, we always have a caution, like in this patient, I had informed, she has narrow QRS. I have told them that if the LV function doesn't improve, then there may be requirement of defibrillator down the line. And similar, if the QRS is wide, of course, we are more in favor of this being a chronic disease rather than Takotsubo. Then we would advise a CRT for this patient. A wider QRS with this kind of pattern has different connotations compared to a patient who was otherwise totally normal and ECG has is narrow QRS. This is more likely to be acute event at this point of time. Yes. You had a follow-up question? You had a follow-up question, sir? Generally a few days. Typically we would, like in this patient, I had informed that she may need a defibrillator or something down the line. And family was saying, yes, do whatever is necessary. But the guidelines say that in a patient with failure, wait for 3 months of optimal pharmacological therapy before you advise for a device implant. So for this patient, we say at least for a month, let us see what is happening. And then unfortunately, she improved in a few days. So that is why the guidelines are based on experience and we don't implant a device right away. We are waiting for things to change or things to improve. So this is something we should be aware of. No, not required. If the LV function is improved and the patient is otherwise fine, we should be okay. Okay. This is again familiar ECG. 20-year-old gentleman, palpitations, pre-syncope. This is the ECG recorded during the episode. Very common ECG, I show it all the time. Wide complex tachycardia, Dr. Chandelkar Sahib. And this is fast, broad, irregular, FBI. Fast, broad, irregular. Atrial fibrillation with WPW syndrome. And the way you treat it, how do you treat this kind of tachycardia? It's very fast. The patient has come to the emergency room and you want to terminate this arrhythmia. What will you do? Say that again. Excellent. So the safest thing to do is just cardiovert the patient. Okay. You can try amiodarone like you said, but always have a defibrillator standby because if the patient deteriorates, you should be able to shock the patient. What you would not use in these patients is drugs like adenosine because that will cause AV node block and you can make matters worse. So digoxin, adenosine, verapamil, diltiazem, not very good drugs to give for this kind of problem. You can make matters worse. So sure enough in this patient, shock was delivered and the patient now has this ECG in sinus rhythm and your diagnosis is vindicated here. What does it show? Perfect. This is delta wave and it is positive in lead V1 to V6, and that means the pathway is likely to be which side, on the right side or on the left side. This is delta wave positive in V1, so it's RBBB like pattern, so it's left sided pathway. Or in the old days it used to be called WPW type A. Right sided pathways were called WPW type B. We don't use that terminology anymore. But this is left sided pathway, and the delta wave is positive in 2, 3 AVF. So it's more anteriorly placed. Okay, so left anterior. And you have a delta wave which is probably biphasic in AVL. So it's more laterally. So anterolateral. So left anterolateral accessory pathway would be amiodarone in the acute stage for the atrial fibrillation, pre-exercise tachycardia and shock. And down the line till the patient comes to the EP lab, because these patients you need to take care of right away. You need to ablate and get rid of the pathway, because this time the patient reached the hospital, you are able to treat. Next time he may have a sudden cardiac death, because AFib, WPW with this pre-excited very rapid tachycardia, it can degenerate to ventricular fibrillation and cause sudden cardiac death. The treatment for these patients while the patient is waiting for ablation is, you can give beta blockers plus minus. There is a drug called procainamide which could be given but generally not available. Third thing is amiodarone, but you don't want the patient to be on amiodarone, especially a 20-year-old, for a longer time. You would not give these patients digoxin or verapamil on a chronic basis. So if the patient has this kind of arrhythmia, send for a ablation as quickly as possible. But for the interim period, you can try beta blocker and amiodarone. So sure enough, this patient came to the EP lab and you have the same pattern. And this is what we see in the EP study. We are looking at intracardiac electrograms of the corresponding QRS here. And we stimulate the heart in various ways. Here I am doing atrial stimulation, and you can see the pre-excitation becomes more and more prominent. Okay. We do various manners. This is ventricular pacing, and on ventricular pacing what we peculiarly see here in this patient is the retrograde conduction from the ventricle to the atrium is via AV node. Generally what we see is an accessory pathway. This is sinus node, AV node, normal conduction system. This patient we said had a left-sided accessory pathway. And general type of arrhythmia that you see in routine patients is the orthodromic AVRT. The impulse comes down the AV node and goes up the accessory pathway. Since it comes down the AV node and conducts and stimulates the heart normally, you get a narrow QRS tachycardia, right? But when we did ventricular pacing in this patient, there was no conduction, retrograde conduction from ventricle to atrium via the accessory pathway. It was all via the AV node. It's a slightly complex concept, but I am sure you'll understand. So like I said, normally this accessory pathway generally would conduct retrogradely, and when the patient gets tachycardia, orthodromic AVRT, it's a narrow QRS tachycardia. But in this patient peculiarly, when we stimulated the ventricle, there was no conduction from the ventricle to the atrium via accessory pathway. The pathway could conduct only from atrium to the ventricle. So it could only come from top to down. So if the patient gets atrial fibrillation, the patient will get pre-excited tachycardia, which we all diagnosed. Fast, broad, irregular arrhythmia. The other type of arrhythmia this patient could get was a antidromic AVRT. The impulse comes down the pathway and goes up the AV node. And this gives rise to a wide complex tachycardia, because the ventricle is now stimulated via the accessory pathway and not via the routine conduction system. And in the EP lab again, we could induce this antidromic AVRT. This pre-excitation pattern would corresponding exactly to your pre-excited tachycardia or your sinus rhythm ECG. So delta wave is positive from V1 to V6, positive in 2, 3 and AVF, negative in 1 and AVL. So exactly like your sinus rhythm ECG. In the EP lab, we look at the various electrical signals I delivered the energy over the X-ray pathway, and you can see this is the pre-excited pattern here. Delta wave is positive, and at this point of time, the delta wave is gone, and the patient has a narrow QRS. Does everybody appreciate this? The ECG pattern has changed. This is delta wave positive V1. In V1 you can see, and at this point of time, the patient has, the delta has gone, and this is narrow QRS. So I ablated, and the patient doesn't have this problem anymore. Intracardiac, we see this pattern. Pre-excited A and V are fused. When I ablate, the A and V are separated. So here you have short PR, delta wave. Here the delta wave is gone. There is abrupt change of QRS from here to here. And patient now has a narrow QRS, normal ECG, and has never need to bother about arrhythmias anymore. So you saved this patient from a possible another episode of AFib, pre-excited tachycardia, and a risk of sudden cardiac death. So these patients, like I said, you temporarily you can give beta blockers, amiodarone, procainamide, but will require ablation. AF pre-excited tachycardia. Does everybody is everybody with me? Yes? Oh, fantastic, fantastic. Okay, 15-year-old boy, palpitations, and ECG looks near normal, isn't it? It looks near normal. And he had multiple episodes of tachycardia, 15-year-old boy, and this type of arrhythmia has also been recorded on during his palpitations. This is in the EP lab, but what has been recorded clinically in everyday life is also something similar. So here I am actually stimulating the atrium, and he has this kind of pattern. You have wide QRS, V1, it is negative, QRS is negative in V1 to V4, and then transition from V4, V5. As I am stimulating the atrium, the QRS becomes wider, and the QRS is positive in 2, negative in 3, positive in AVF. This is a peculiar kind of problem which is called MAHAM accessory pathway mediated tachycardia. What is MAHAM? It is basically rudimentary in frogs and all. That is duplicated AV nodal conduction system. So in the frog heart, you have dual AV nodes. In the humans also, sometimes this remains rudimentary. So you have your normal sinus node, AV node, normal conduction system, but some of these rudimentary transitional cells also remain, and they are able to conduct at some point of time. And that is generally typically in the free wall region of the tricuspid annulus. We see it even more in patients with Ebstein's anomaly, etc. Now this is a very peculiar type of accessory pathway which only conducts from the atrium to the ventricle. So only antegrade conduction happens. There is no retrograde conduction which we see in usual WPW pathways. So again, just like in the previous case, even in this patient, when you get arrhythmias, it is an antidromic AVRT. Impulse can go down from the atrium via accessory pathway to the ventricle and come up via the AV node. So it will always give rise to a wide complex tachycardia, and since it's a right-sided pathway, it gives rise to a LBBB pattern on the ECG. You can see this is LBBB pattern, and depending on where the pathway is, you may get positivity in 2-3 AVF, then it is a more right anterior free wall pathway, or it could be more negative in the inferior leads, so it's a more right posterior pathway. So we put in catheters. This is the heart in the LAO view. The right atrium is here. This is the tricuspid annulus. This is the mitral annulus. And one of my catheters is all around the tricuspid annulus. I get electrical signals from each of these places. I am putting the ablation catheter very across, and we map this area. Like I said, this is the free wall region. We can map where the pathway is coming from. And just like in the normal conduction system, you have his signal, atrial signal, his signal, ventricular signal. Because these are rudimentary conduction system tissue, we also get something called M potential, that is MAHAM potential. So we know we are sitting right on the top of the pathway. So this is very complicated slide. I'm doing atrial stimulation, but this is the potential I'm looking for. And when I put the catheter, stabilize there, ablate, at this point of time, you can see the QRS from wide QRS is become narrow QRS. So the MAHAM accessory pathway has been ablated and the patient has now a normal looking ECG. Now when I do atrial stimulation, there is no evidence of pathway, there is no pre-excitation. Okay. So MAHAM accessory pathway, it is seen more in adolescents, we see it fairly often, and it can be very vexing. Difficult to control this problem. We treat it with beta blockers, verapamil, diltiazem. Since it's like AV nodal like tissue, it works really well. Okay, let's come to this one. 24-year-old gentleman, this is number 4. Dyspnea on exertion, echo LV function was 35%, so some LV dysfunction. And this is the ECG seen. Anything remarkable on the ECG that you see? What is the heart rate like? Heart rate is just about 100 or so, isn't it? Somebody said it. P wave looks abnormal. It is inverted in 2, 3 and AVF. So it doesn't look like a sinus rhythm ECG. What do you think it is? Could you say it loudly? Junctional, yes. So it is coming from somewhere in the junctional region. The atrium is getting activated retrogradely. So you get negative P waves in 2, 3 and AVF. So it could be an ectopic atrial tachycardia where P wave is negative 2, 3 AVF. It's coming from the coronary sinus ostial region or from the junctional region like you said. If it were junctional tachycardia, generally we see P waves after the QRS or buried within the QRS. An ectopic atrial tachycardia would give peculiarly this type of arrhythmia, a long RP tachycardia. The RP interval is longer than the PR interval, so it's a long RP tachycardia. Now this patient you would treat with medications like heart rate is 100, EF is 35. So this patient was treated with beta blockers, with verapamil, with diltiazem at different points of time, but didn't work very well. And finally patient was put on our Brahmastra, amiodarone. Okay. So patient was on amiodarone for a few months, but still the heart rate continued to be like this and the patient started getting more exertional dyspnea. So what do you think is happening here? This on a Holter, the heart rate has been on the higher side all the time. He never comes down to 60s or even in sleep, his heart rate is more than in the 80s. What do you think is, this is a tachycardia which is going on all the time and now patient has heart failure like symptoms and EF is 35. So it's chicken and egg story. It could be tachycardia all the time giving rise to tachycardiomyopathy, right? And the other thing we always think is LV dysfunction, heart failure, these patients are likely to get tachycardia, isn't it? Those patients have sinus tachycardia. But that is sinus tachycardia. If a patient with heart failure, LV dysfunction, has a always fast heart rate and an abnormal looking P wave or some kind of arrhythmia going on, always think that there is possibility that this could be a tachycardiomyopathy. Okay, so many drugs have been tried for this patient and it never worked. He has been on them for months and years and as you can see, the LV is quite dilated. So tachycardiomyopathy could be due to irregular rhythm like atrial fibrillation, atrial ectopics, ventricular ectopics, more than 20% of the time if they are there, they can give rise to it. Left bundle branch block, RV pacing induced cardiomyopathy, or problems like this, atrial fibrillation or an ongoing SVT. An atrial tachycardia or what we say atypical permanent junctional reciprocating tachycardia can give rise to tachycardiomyopathy. So the best way to treat this patient is bring into the EP lab. We can map where it is coming from. So like I said, this is LAO view, this is the tricuspid annulus, mitral annulus, this is a catheter going in the coronary sinus, and like Dr. Chandelkar said, junctional rhythm. It is this AV nodal junctional coronary sinus ostial region. This is my ablation catheter with the thick tip. This is where I have localized. This is what we are doing 3D mapping here to localize the arrhythmia. And tachycardia is going on. You can appreciate negative P waves in inferior leads. And ablation started, and the patient's tachycardia slowed down and now is in sinus rhythm. For the first time in months and years, we could now see sinus rhythm in this patient. P wave positive in 2-3 AVR. And within a couple of days, LV function was 55%. So now you are vindicated. Now you see, okay, retrospectively, now patient was in tachycardiomyopathy, and we are happy that the patient is in sinus rhythm. The heart rate is in the 60s, 70s. In the night, it falls down as it is normally it should, and the patient's LV function has improved. These patients, these kind of patients are prone to getting tachycardiomyopathy again. So if it's atrial fibrillation causing cardiomyopathy, they can go back if there is future episodes of atrial fibrillation. This patient, hopefully we have cured because we've done the ablation and got rid of the problem. So patients with heart failure, LV dysfunction, if they have an abnormal looking ECG, remember, think of tachycardiomyopathy. Okay, couple of interesting cases quickly. 7-year-old boy, seizures, loss of consciousness. This is a 7-year-old boy and this is the ECG. Heart rate is on the slower side. Yeah, for a 7-year-old you expect much faster heart rate. And what is very prominent in this? Long QT syndrome. So the seizures and loss of consciousness. Very impressively prolonged QT. Look at the ST segment, it's so long. And also in the ECG, you can see the T wave pattern changing. You are seeing the T wave pattern changing here. And these patients are at highest risk when they start getting these labile T wave changes or T wave alternance. Then these patients are at the highest risk of getting this problem. What is it? Is it an artifact? It's torsades. Yeah. So in front of the eyes, the patient is getting this. This child used to get episodes every day. Every day he used to get it. And the family was incapacitated. This has started right in the infancy. They had almost given up. But now child was 7-year-old and they said, now we need to do something for him. So patient had been tried on beta blockers, etc. But with beta blockers, the patient was getting bradycardia and many episodes like this. So the best way to treat these patients is put in a pacemaker, and this is a atrial based pacemaker. The lead is in the atrium and we pace the atrium faster, and now we can give these patients beta blockers. Okay, otherwise if we give beta blockers, the patient is going to further bradycardia and cause problems. But here you have atrial pacemaker, you are pacing faster, the QT is still long, but it is much better than the previous looking ECGs, and we give a stiff dose of beta blockers, we increase the dose as much as the child can tolerate. If the patient still gets symptoms, then we may have to do something called carotid cardiac sympathetic denervation, stellate ganglionectomy. And final option in these patients is defibrillator, but defibrillator is not a good option in pediatric population. It's a big problem. So if we can get away with atrial based pacing or dual chamber pacing and high dose of beta blockers, and if required stellate ganglionectomy, we are winning the battle. And this patient in 2 months after the implant has not had a single episode of seizures and LOC. So this child is now really doing well and he's thriving. So this is a problem we have to tackle. So long QT syndrome you should be aware of. Why is this like this? 6-year-old girls who had seizures, I'm making matters worse. 4 years ago, she has undergone VSD surgery and a very rapid tachycardia has been recorded at that point of time. But that is a story in the past. This is a rapid tachycardia rates of almost 150, 180, 200 beats per minute at that point of time. And this time the patient continued to started getting seizures again. And this is the ECG, this is a Holter which was done. This is recorded. Anything remarkable on this? Again, it's a young girl and the rate seems to be slow, but you have to look at it a little more carefully. There is a P wave here, there is a P wave here also, isn't it? Multiple P waves and QRSs are coming only with the alternate P wave. So it is AV block. This is the child is getting 2:1 AV block. And matters, I have just blown up that ECG. You can see it more clearly now. This is P waves here and this is QRS. And at other points of time, there are more P waves and even lesser QRSs. So the patient is getting higher grades of AV block. Now, this patient, ventricular septal defects, as you know, can be at various places. The commonest is in the perimembranous region, and our conduction system goes exactly there. Sinus node, AV node, and Purkinje fibers. Our ventricular septal defect is here, and the patient can get AV block during surgery, after surgery, or down the line with fibrosis occurring over that period of time. So this patient now was given a pacemaker, but this is a ventricular based pacemaker. The lead is coming down into the ventricle and we are giving continuous stimulation of the ventricle. So after this, the patient's problems are gone. Can you see the lead? It has got a loop here. Why do you think we have the loop? There's a 7-year-old child who's going to grow, isn't it? The child is going to grow and the lead is going to get pulled. So we provide a redundant loop to allow for growth. As the child grows, the loop becomes straightened out, and when the child is going for the next replacement, a pacemaker will last typically 8 to 12 years, sometimes longer. Child is now 7-year-old. Hopefully will be able to do with the same lead and same pacemaker till 17, 18, 19 years of age, when the child has achieved full physical growth, and at that point of time we can give a dual chamber pacemaker to the patient. But we don't want to do any interim procedure just because the lead has become shorter. So here we have provided a loop which will allow for the growth of the body, and the loop gets straightened out over a period of time. So this patient has now a ventricular pacemaker and it's regular ventricular capture happening, and the patient's problem of syncope and seizures is gone. This is a case where I had shown last year. This is a 24-year-old lady with syncope, and all you can see here is sinus rhythm and occasional PVCs. Now this patient had a very malignant family history of sudden cardiac death. 4 uncles had sudden cardiac death, 1 uncle is on ICD. Patient has had VT, VF, sudden cardiac arrest shock, and I have implanted ICD at 17 years of age for this girl, and she has had appropriate shock therapies on ICD. Unfortunately, the patient got an infection in the defibrillator region, and so we have to take the leads out. Now one of the lead could come out easily, but the other lead is like 7 years in the patient's body, and it is severely fibrosed, impossible to pull out. So we do something called lead extraction. There are special tool. This is called a tight rail. It has a biting edge at the biting teeth in the front. We manipulate from outside and it cuts through all the fibrotic area, sometimes the periosteum of the clavicle, sometimes all the endocardial region fibrosis, and it's a tough procedure. Lead extraction is not for the faint-hearted. We have to be fully prepared for catastrophe like tamponade or perforation. We have to keep our cardiac surgeons on standby, and we prepare the entire place that we should be able to reach the heart within 5 minutes. We keep a balloon in place in case there is a perforation. We can inflate the balloon in this region and prevent severe blood loss. So this is a tight rail system which is going down over the lead. We have to do a lot of manipulation. Here I have reached to, after half an hour of back-breaking work, reached towards the tip, and then we try to unscrew the lead, and fortunately in this lady we were able to pull the lead out, and the entire system is now being pulled out. So entire system is out now, and the patient is without any hardware. So then we allowed the infected area to heal up, and after 6 to 8 weeks implanted the defibrillator from the other side, taking more precautions as needed. So lead extraction is not for the faint-hearted, but we need to do it every once in a while. I'll stop at this point of time. This talk is about, I always give this talk, so you are aware of what is happening. You know that we do conventional EP study, radio frequency ablation. It works very well in the vast majority of patients with routine supraventricular tachycardias or patients with structurally normal heart, idiopathic ventricular tachycardias also, it works well. But when it comes down to complex arrhythmias or patients with structural heart disease, patients who have undergone a previous cardiac surgery, here there is considerable fibrosis, or patients with coronary artery disease, MI, LV dysfunction, ventricular arrhythmias, there's a lot of fibrosis scars and the routine ablation doesn't work well. In these patients we do 3D mapping, and in addition to fluoroscopy, it's of great advantage to visualize the various regions, the fibrotic scarred region, and then we use special forms of energy like irrigation radiofrequency energy, which gives better results. Now routine catheters are like this. They can be inserted generally from the femoral vein or artery, or from an internal jugular or subclavian veins. There are all these EP catheters, electrophysiology catheters, have electrodes from where we get electrical signals like this. They go into various chambers of the heart, in the atrium, coronary sinus, ventricle. We can go transseptally across the septum into the LV. When we deliver radiofrequency energy, it is delivered at the, it's basically surgical cautery energy, which is adapted to be delivered through the tip of the ablation catheter. And that is not only heat of the tip, but more effective, the real thing which works is the resistive heating in the tissue, and that produces these irreversible lesions. Apart from the routine energy, we use irrigation where we infuse saline through the catheter. There are pores here, the saline comes out from here. It cools down the catheter tip, so we are able to deliver more energy to create this resistive heating in the tissue. And irrigation RF energy is more effective. When we put in catheters and we are trying to map, we also need to make sure that we are touching the tissue well. We are not moving away from the tissue when we are delivering energy. So this is a fairly new technology over the past few years we are using. It's called contact force. There are small sensors in the catheter tip which can tell me how much energy, how much force I am applying on the catheter, and which is against the tissue. And I get the figure in grams. So it's 5 grams, 10 grams, 30 grams, 50 grams. The force which you applied, with which you put the catheter against the tissue, should not be too less. At the same time, it should not be too much. We don't want to perforate through the tissue. So typically we have something like 5 to 30 grams of force which we use, which is effective. So to gauge the contact we are making to avoid ineffective lesions, because we are not making sufficient contact, and to minimize complications like perforation, so that we are not having excess force against the wall of the heart. So contact force is becoming very important in complex ablations like atrial fibrillation ablation, or even in ventricular tachycardia. It is a useful tool which tells about how effective we are in delivering energy. So this is 3D mapping, and atrial fibrillation ablation is being done here. The various colors of these tags also tell me how much force has been applied at each point of time. The more redder the tag, higher the force, the lighter the tag, lesser the force. This is something new which is coming, which is called high power short duration RF energy. The routine energies that we give, it's between 20 to 40 watts, and we generally give between 30 to 45 seconds. But this high power short duration energy is like 50 to 90 watts, and the amount of time you need to apply this is just about 10 seconds. So all the procedures get much faster. When we are doing mapping now, especially for complex arrhythmias, we use catheters like this. These are the routine EP catheters, but here you have a catheter which has 5 rays coming out. It's penta-ray, and there are small electrodes on each. And I can map these complex areas. Like this is in the right superior pulmonary vein. I get signals like this. So we are able to map these areas much better. And this is not trash. These are not artifacts. These are real signals in the pulmonary veins. When we do AF ablation, those are what we look for. And here tachycardia is going on with the pen. When tachycardia terminates, patient is in sinus rhythm. So just like penta-ray, you have this special HD grid catheter. This gets folded. It is inserted through the femoral vein or femoral, then we go transeptally, or it could be put anywhere in the heart that we want. And again, there are multiple electrodes on this grid. We get signals from each, and we can map these complex structures better. We deliver radio frequency energy, which produces heat. It denatures the protein, the myocardium. It deactivates the electrically active tissue. We can at the same time use something called cryo. Cryo ablation is cooling down. By cryo ablation also you can do essentially the same job. RF is a little more effective compared to cryo, but this is again very good type of therapy option available in certain people, like for atrial fibrillation ablation. You've heard of Cox maze, where the surgical maze was done, the cut and sew maze was done. In AF ablation, we are mimicking that, and we are isolating the pulmonary veins. So with radio frequency energy, we have to ablate all around the pulmonary veins. When you have a cryo ablation balloon, you can actually put cryo energy or cooling down across the balloon. We put it transeptally from IVC across the IA septum into the left atrium, and this catheter sits at the ostium of the pulmonary vein, and cryo energy is delivered around the pulmonary vein. So this is a much more anatomical way of doing ablation. This is a balloon, cryo balloon. This is a pulmonary vein here. We are getting electrical signals, and cryo energy is being applied. So these are various companies which make it. Metronic, Arctic Front, Cryoballoon. It was not available in India, but now it is available for the last year or so. A little more expensive, I would say a lot more expensive, but this is an option which is available. Just like cryoballoon, we have radio frequency balloons. So these are balloons which are again put in the pulmonary vein, and like your routine radio frequency ablation catheters, radio frequency can be delivered through these electrodes on the balloon. This is Boston Scientific APAMA, multi-electrode ablation balloon to treat atrial fibrillation. And this is another company, Biosense Webster, which also has started making it, and it is recently presented in HRS. You have radio frequency energy, you have cryo, and there is laser also. This is cardio focus heart light laser balloon catheter, all under research at the moment. Not clinical applications are not that prominent, but pulmonary vein ablation again can be done by this kind. With cryo, not only balloons, but we can also do using freezer catheter tip cryo ablation, and this becomes useful especially in pediatric patients where the heart is small. Some of the arrhythmogenic foci are close to the AV node. Radio frequency energy is irreversible, but we do something called cryo mapping with these catheters. When we reduce the temperature, it is still reversible, and when I am certain that I am ablating the arrhythmogenic focus, but not affecting any important structure like the AV node, I can go ahead and do permanent cryoablation with this. So it's a safer form of treating especially pediatric patients where the arrhythmogenic foci are very close to critical structures like AV node. New mapping systems have come up. 3D mapping system we have Carto for last 25 years now. We have something called St. Jude Abbott's Insight system, Navix Insight, and this is Rhythmia from another company. It is much more high density electro mapping is possible with this, and this is something which will be available in many parts of the world and probably coming to India. This is something which we are getting in now. I've used Carto for the last 20 years, but now we are getting this Abbott Insight precision system in Marengo CIMS, and this is something which will enhance the way we map our arrhythmias and treat them. Along with that, now you have ultrasonic mapping techniques. These are small ultrasonic transducers on this basket catheter, and this is something which we are planning for a patient. I've talked about this in the past couple of years. When patients have diffuse disease, multiple arrhythmias which are not ablatable or at a place in the heart where it is not possible to take our catheters to, stereotactic radio ablation can be done. Like we do radiotherapy for cancer patients, we can focus radiation beams into a specific part of the heart and deliver radiotherapy in that region to quieten the arrhythmias. This can be planned for ventricular arrhythmias and sometimes even for atrial fibrillation ablation. This is still presently under research, but some clinical use has been done. We can map the scars by electroanatomical mapping, find the arrhythmogenic foci, and then radio ablation can be done at a specific point in the heart. The effect can be very dramatic. Remember, these patients are very sick. There are no other options. So patient has multiple VT episodes, ventricular tachycardia, storm, ICD shocks are being delivered, or anti-tachy pacing is delivered by the defibrillator. Radio ablation has been done, and after that the arrhythmias have quietened down, does not require shock, and no ATPs were given. So VT episodes pre and post ablation, remarkably they have come down. And finally, this is something which has been around for a few years. Like we have a 12 lead ECG. This is a vest which has 252 electrodes, and it can record the electrical activity from the surface, chest surface of the myocardial electrical activity. And this is called body surface mapping. It is helping in mapping in radio ablation to localize the focus, and in these patients we can use this. So coming to this, which of the following are ablation energies? Radio frequency energy, irrigation RF energy, high power short duration energy, cryoablation, or all of the above. What are balloon based AF ablation options? Cryoballoon, radio frequency balloon, laser balloon ablation, APAMA, RF balloon. Again here, all of the above. These are all options. Thank you very much. I'll wind up here.
So that's what I'm going to teach or discuss, like how should we approach a case of frequent PVCs. So we know that, PVCs can arise from left ventricle, they can arise from right ventricle, they can arise from different part of the ventricle. It may be like outflow tract, it may be inflow, it may be apex, it may be papillary muscle, it may be annulus like mitral annulus or a tricuspid annulus. It can be arise from the fascicles. So there are a lot of places from where the PVCs arise. So, whenever we look at the ECG, the most important part is from where this PVC is coming. Then second most important part is how much number of the PVCs are there, like what is the frequency of PVC. And third number is what is the timing of PVC, when is it coming during the cardiac cycle. So there are multiple points which we need to see whenever we look at the PVCs. That's what I'm going to discuss in the next few slides. So if we see the natural history of the PVC, if you see most common site of origin of PVC is outflow tract. Outflow tract means they are near the pulmonary valves or the aortic valve. So that outflow tracts are the most common site of the PVCs. And age at presentation is usually 30 to 50 years. They are usually benign with excellent prognosis. Sudden cardiac death is rare. A very frequent PVC can lead to LV systolic dysfunction, especially when the PVC burden is more than 10%. Out of 100, 5 to 7% patients will develop LV dysfunction over the years. This has been proved in few studies. And rarely, PVCs can trigger idiopathic polymorphic VT or VF when the heart is structurally normal. So we need to identify those patients who are actually at a risk of getting problem because of the PVCs, and how can we identify them? So whenever we find out a case of PVC, we have to evaluate the case. First, what we do ECG, and reason for doing ECG is to look at the morphology of PVC, to identify that where is the PVC focus. The second thing, we need to identify where the PVC is coming, the coupling interval, after how much millisecond that PVC is coming after the preceding sinus complex. So that decide a short coupling PVC or it is a long coupled PVC. Then, so coupling interval we check. Then we check PVC QRS duration. What is the duration of PVC? We have to look at the duration of sinus QRS. We have to look at the QRS duration of PVC also, because that guides us whether it is structurally abnormal heart or normal heart. What else we do? We do echo. Why we do echo? We do echo to look for the structural heart disease. What else we do? We do Holter. So Holter should be routinely done for all PVCs. And what is the reason for doing Holter? We want to look for PVC burden. What is the burden of PVC? Burden of PVC means that suppose somebody has a 1 lakh heartbeats in a day, how many PVCs are there during that day recording? Like it is 24,000, whether it is 5,000, whether it is 20,000. So that is the percentage of PVC. PVC burden should be assessed in all patients with PVCs. Then PVC morphology also we need to see in the Holter, because ECG may not show all the morphologies because it's a just 10-second recording. ECG is recorded for 10 seconds. Holter we do for 24 hours. So that will give you that how many PVCs are coming actually, whether it is just a single morphology or there are different other morphologies also during the 24-hour recording. Then we have to see, very important, circadian fluctuation. What is circadian fluctuation? Circadian fluctuation is that PVC usually dips down during night time, then that again reappear during the daytime, especially in the early morning hours and the morning hours. So that is known as circadian fluctuation. You need to check this circadian fluctuation in the Holter 24-hour, because this is going to decide our prognosis. I will discuss in next few slides. Then correlation of the symptoms. Sometimes patient tells some symptoms, but we don't know whether it is because of PVC or not. And that is the reason we need to do Holter and do symptomatic correlation. If patient tells that, see, I have symptoms most of the time during 8 p.m. to 9 p.m. And if you do Holter, and if Holter is showing frequent PVCs during 8 to 9, you can tell that, yes, your symptoms is because of PVCs. But suppose there are no PVCs during 8 to 9 p.m. at all during Holter, you can tell that, see, your symptoms are not because of PVCs, because there were no PVCs during that time. So symptomatic correlation is very important, especially in PVC, and that can be done by doing Holter. So what else we can do? We can do loop recorder. We know that Holter we do for maximum 48 hours because it has a capacity of doing maximum for 48 hours. But you should be knowing that these PVCs are very much influenced by autonomic nervous system. And because of that, there is poor day-to-day variability. We should be knowing that our autonomic nervous system does not function equally on each and every day. It is different on Monday, it is different on Tuesday, it is different on Saturday. You know that we have a week, holiday, Saturday, Sunday, your autonomic nervous system get different modes during Friday. You always feel that like Saturday you have something different feeling because you have a holiday on the next day. And again, on Sunday it's a different feeling because you have to go on work on Monday. So because of that, autonomic nervous system usually have somewhat fluctuations throughout the week also. And that's why if you do PVCs on Thursday and Friday, you do Holter, you may not be able to actually pick up all the PVCs. Actually, patient may be having PVCs more on weekend or maybe in the Monday or Tuesday. And that is the reason that Holter is not sufficient always. You need to record it for 7 days, and that is the reason you need to do for a loop recorder, which we can do for 7 days, we can do up to 30 days. Okay. So then what else we can do? We can do TMT. So in fact, I always go for TMT for all PVC patients. And the reason for doing PVC is not to look for inducible ischemia. Here the reason for PVC is to look for inducible arrhythmia. Because PVC focuses, which are sensitive to sympathetic nervous system, will get increased during exercise. So And few PVCs are there, especially those idiopathic PVCs may disappear during exercise. So it is very important to see whether PVCs are increasing during exercise, especially on stage 1, 2, 3, 4, or whether they are getting suppressed during exercise and then reappear during recovery phase. So any PVC which gets suppressed during exercise is having actually a good prognosis. And those PVCs which increases during exercise are having a worse prognosis. And that is the reason we need to do TMT for all our PVC patients. What else we can do? We can go for a cardiac MRI. I will show one case here where I will show the importance of doing cardiac MRI, because we do echo to look for structural heart disease. Echo will rule out most of the time, but not always. I have seen many cases where echo is reportedly normal, or in fact I have seen echo and echo looks normal. But when I go for MRI, and I will show the reason why I go for MRI, and if you go for MRI, MRI will be able to pick up something which echo is not able to pick up, because MRI is the most sensitive to pick up something by doing imaging. So that's why MRI is very important to look for a fibrosis or a edema or a fibrofatty infiltration. Fibrofatty infiltration in mainly ARVC, RV cardiomyopathy. Okay. So what else we can do? The other investigation is FDG PET, cardiac FDG PET. So when I go for cardiac MRI or cardiac FDG PET, see, I do most of the time ECG, echo, Holter and TMT and loop recorder. These are 5 investigations which I go for each and every frequent PVC cases. But then after these 5 investigations, I decide whether this patient's PVC belongs to idiopathic one or it does not seems to be idiopathic. There seems to be something else other than idiopathic. And that is the reason I go for further imaging. And whenever I do cardiac MRI, and if cardiac MRI shows that fibrosis or edema, I want to go for a further imaging. I will show the slide where a case where I need to go through all the investigations, including cardiac FDG PET to look for the myocardial edema. And the main reason to identify this is a inflammatory cardiomyopathy. That is either a tuberculosis or a cardiac sarcoidosis. So this is the battery of investigations which we need to go for our frequent PVC cases. Now we have to decide what all things we need to do essentially, and then after that essential investigation, which further advanced imaging needs to be done for individual patient. Then at last comes an EP study. I have gone through every investigations now, because if patient is having suppose patient is having a syncope, and you are not able to find out any specific reason why this patient is having a syncope. And in that case, we need to go for a EP study also. And EP study means mainly we go for a VT induction study. We try to induce ventricular arrhythmias and see if any VT is getting induced in this patient. And if we are able to induce any VT or VF in this frequent PVC patient, this patient is at a very high risk of getting sudden cardiac death because of VT or VF. And that is the reason we go for a EP study for further risk stratification, especially to sudden cardiac death. Now I will go to the cases. Now this is a case 1. She is a young lady with frequent palpitation. She is not in heart failure. She is sinus rhythm. She is NYHA class 2 and coronaries are normal. Now if we look at this ECG, we need to meticulously see the sinus QRS complexes, and we need to see very meticulously the PVC QRS complex also. Now you can see the lead V1 is having a negative V1 and the transition is in V4. That suggests that this PVC is coming from right ventricle. And if you see the inferior leads, they are tall R wave in the inferior leads. That means that they are coming from the topmost structure of the heart, because inferior leads are downmost. So these PVCs are coming from right ventricular outflow tract. So this is how we need to analyze the ECG. You can see the first slide, which is the routine one, which everybody do. And then you can see the left column, it is a frequent bigeminy to couplets, left bundle morphology, V3 to V4 late transition. We can see tall non-notched QRS in 2-3 AVF, QS in 1 AVR AVL, and QS in AVR is equal to AVL, and there is no significant pseudo-delta pattern. So these are all the parameters we need to look at all the QRS complexes of PVC. And after analyzing these, I could find out that it's an outflow tract PVCs, where there is RV versus LV outflow tract, but looking at the morphology, this looks more likely from right ventricular outflow tract. And where is the focus of the PVC? So after analyzing all these parameters, I can tell that these PVCs are coming from right ventricular outflow tract and from the mid or anterior septum of the RVOT. Now echo was done. Echo was showing LV EF of 45% and no regional wall motion. And MRI was done showing 45 EF and there was no scar, no edema. So that means that here EF has gone down significantly. It is not normal, it is 45% and with a frequent PVC. So what else we need to do? We need to go for a Holter for this patient to look at the burden of the PVC. So when we did a Holter, you can see the Holter recordings, and there are statistical data shown here. You can see total beats analyzed are 1,17,000, and how many PVCs are there? 20,000 PVCs. So he has a daily 20,000 plus PVCs. So we can label that this patient is having a frequent PVC and burden is more than 15 to 20% of the total PVCs. And studies have shown that this much frequent PVCs can lead to LV dysfunction. And that is known as PVC-induced cardiomyopathy. So which PVCs can induce cardiomyopathy? Whenever the PVC burden is more than 15 to 24%, whenever you see the PVC and the QRS duration is more than 140 milliseconds, so the QRS is wide in the PVCs, they are having more pronounced mechanical dysynchrony, and these PVCs can lead to cardiomyopathy after a few years. And then longer PVC coupling interval, interpolated PVCs, and non-outflow-tract site of origin of PVCs, particularly papillary muscle and epicardial foci. So these are the locations which can lead to higher risk of getting a PVC-induced cardiomyopathy. Then constant PVC burden throughout day and night. I told you in Holter that we have to look at the circadian rhythm of the PVC also. And whenever there is no circadian fluctuation, means there is no suppression of PVC during night in Holter, these patients are having a highest risk of getting PVC cardiomyopathy. So, I mean, there are a lot of articles on arrhythmia-induced cardiomyopathy. So, the frequent PVCs can lead to multiple myocardial level and microcellular level mechanism, and that leads to actually electrical and myocyte remodeling and leads to LV dysfunction. And whenever we treat them by either ablation or antiarrhythmic drugs, that leads to normalization of EF and dimensions. So, this has been shown already. So, what we did, I went for the EP study and RF ablation, so it was done under 3D mapping system. And we can see the ECG during 3D mapping. I mean, when we were doing EP study, you can see frequent PVC. In fact, there are runs of NSVT during this. So what we did, I mean, I did a 3D mapping under CARTO system, and we find out the focus exactly into the RVOT. I ablated that focus, and after ablation, there were no PVCs. So at the end of the procedure, patient has get rid of PVCs completely. But this is not the end. We need to follow them also regularly. And when patient came for follow-up, so you can see again we did a Holter and we have analyzed 1,08,600 beats. You can see how many PVCs now throughout there. There are 15 PVCs. So the PVCs which are 20,000 plus has gone down to 15. And when we did an echo, you can see the last slide. The EF for 45% has become 60%. So this patient was actually a tachycardia cardiomyopathy, and if we don't treat them meticulously, these patients' EF will go down from 45 to 40, 35, 30, then again, finally they will end up into heart failure. So that's how the meticulous analysis of this patient can prevent a further progression of cardiomyopathy. And going to the case 2, he's a young boy, sudden onset palpitation and Gabraman. There is no past medical history, no history of cardiac illness also. Echo was done, echo was normal. And this was the ECG. Now you can see the ECG, and if you meticulously analyze the ECG again, which I told on the first case, you can see the PVC is likely coming from the left ventricle and it is coming from the inferior wall. Now you can see that PVCs are very wide. It's a wide QRS. And see the morphology of PVCs, there are multiple morphologies of PVCs. Now this tells me that these are not the routine idiopathic PVCs. There is something wrong. There must be some cardiomyopathy or something. But I have shown you on my first slide that echo was normal. I personally did echo because after looking at this ECG, I thought that her echo should not be normal. But then I also repeated and personally seen the echo, but echo was normal. So I was having suspicious that there is something wrong going on with this patient. So I need to do further analysis. I mean, this is the methodology of identifying the VT focus. And after this, I found out that this is coming from left ventricle mid-inferior wall. So this is not the usual site of getting an idiopathic PVC. So this PVC was not arising from a idiopathic location. This was coming from somewhere else. And that was the reason I went for further analyzing of this patient. And what I did cardiac MRI. And you can see cardiac MRI, it's a short axis and a long, 4-chamber axis. And you can see that there is myocardial edema, significant edema. And you can see in the lower images, there is fibrosis also. Though the echo was normal, MRI picked up so much problem. I mean, we may not have expected. In fact, I also did not expect, but I could find out this thing in the patient. And this was the reason that I need to do further analysis. It's a young boy with this much edema and scar. So what I did a cardiac FDG PET. And a cardiac FDG PET scan was showing, you can see that there are hotspots into the heart. Anterolateral wall is having a myocardial edema and hotspots. In fact, you can see there are big two mediastinal lymph nodes also. This means that this patient is having actually inflammatory cardiomyopathy with a normal echo and with a frequent PVCs which are multiple morphology. And how to do further analysis of this patient to identify whether it is because of TB or whether it is because of sarcoidosis or something. we need to go for a biopsy from that lymph nodes, and we did a EBUS, it's an endobronchial biopsy, ultrasound guided, and that biopsy was showing a non-casseting granulomatous inflammation. So this patient was actually diagnosed to have a sarcoidosis. And this sarcoidosis patient is at a very high risk of getting sudden cardiac death because of that frequent PVCs. And what is the reason for PVCs here? The reason is myocardial inflammation, edema. And that's why, how to treat these patients? We need to give them a steroid therapy, immunosuppression therapy, and antiarrhythmic drugs. And when this patient came for follow-up, his ECG was fine, her ECG was fine, and only showing right bundle branch block morphology. And this is actually a 1-year-old case. We completed 1 year of immunosuppression, and we did a FDG PET just 2 weeks before. There are no hotspots, 0 hotspots, and Holter is completely normal, and she is asymptomatic. So that's how we have to, if we don't do early diagnosis and don't give immunosuppression therapy early, this patient will have a VT, VF, and will have a sudden cardiac death. And we see a lot of sudden cardiac deaths in young patients, and newspaper will label them that this fellow died because of heart attack. Do they die because of heart attack? No, they died because of such problems which have not been diagnosed early and managed. Now I am going to the last slide, last case. It's a 25 male, there is no past medical history, and there is no family history of sudden cardiac arrest or sudden cardiac death or early CAD. And this patient was working just near to the CIMS Hospital in a Hyundai showroom. He had a loss of consciousness while doing his job, and the bystander given a cardiac massage and was brought to the CIMS emergency room. Now I will show the ECG into the next slide, but then we did an echo later on which was showing mild global hypokinesia with EF of 40 to 45%, no RWMA. Now this mild global hypokinesia may be because of actually myocardial stunning because of the massage, and the blood investigations were normal, coronary angiography was also normal, there was nothing significant in this, and when the ECG was done ER, it was showing in fact a ventricular fibrillation. So this patient underwent a CPR and a defibrillation, and this patient finally leads to the sinus rhythm, and you can see the sinus rhythm ECG. What is there in sinus rhythm ECG? It's a 12-channel sinus rhythm, and you can see that it's a trigemini. Every third beat is a PVC. You can see it is a very narrow QRS. If you see the morphology of this PVC, in V1 it's a right bundle morphology, and there are inferior leads which have small r and deep s. So this suggests that this PVC is coming from left ventricle, and looking at the nature of the PVC and the QRS duration, this is very narrow QRS, most likely coming from either a fascicle or a Purkinje fiber. So this is actually a Purkinje PVC from the distal to the posterior fascicle. And this is, you can see now the importance of coupling interval. You can see coupling interval of these PVCs. Coupling interval is very short. In fact, you can see in slide V3, V4, V5, V6 leads, it is almost falling on the T wave. Last 2 minutes I will take. So you can see that it is falling on the T wave. So this patient is having a very short coupled PVCs coming from Purkinje, and these PVCs are almost falling on T wave. So this can lead to R on T phenomenon. And what can happen because of this R on T phenomenon? You can see this, this is not the same patient, this another image from another patient, but you can see a short couple Purkinje PVC can lead to R on T, and this R on T phenomenon can lead to polymorphic VT and ventricular fibrillation, and this can lead to sudden cardiac arrest. So what we extrapolate this, our patient who has this short couple PVC, who had a VF on presentation, must be having this mechanism as a cause of VF. And this is known as an idiopathic VF. There is now entity which is known as idiopathic VF, and the most common mechanism of the idiopathic VF, who died with a structurally normal heart, with a normal angiography, with a middle-aged male most of the time, are having this Purkinje short couple PVCs that can lead to sudden cardiac arrest. And what to do next? We did, what is this known as? This is a PVC trigger. Actually, patient does not have an abnormal heart. These PVCs have actually triggered VF in this patient and lead to death. So we have to ablate this PVC trigger, and we did a 3D mapping, and it was just distal to the posterior fascicle, and this PVC was successfully ablated, and the ECG was not showing any PVCs. So this how we can, prevent the patient from another episode of sudden cardiac death. So I will go to the conclusion. So most form of focal idiopathic PVCs are usually benign with good prognosis. Very frequent PVCs can lead to PVC-induced cardiomyopathy. Malignant form of PVCs should be identified. Which are all malignant form of PVCs? Those PVCs which are short couple, those PVCs which are associated with syncope, those PVCs which can trigger polymorphic VT or VF, these are all malignant form of PVCs, should be meticulously treated. And catheter ablation is indicated for those patients who are significantly symptomatic on drugs, who have high PVC burden of more than 15 to 20%, though they may be asymptomatic at that point of time, but we know that these high frequent PVCs can lead to PVC-induced cardiomyopathy and worsening heart failure. Then malignant form of PVCs, especially those who are short couple PVCs, patients with PVC-induced cardiomyopathy and patients with PVC-worsened cardiomyopathy should have a PVC ablation. I will take 30 seconds for last diagnosis, that is PVC worsened cardiomyopathy. That means that those patients who have a cardiomyopathy, whose EF is something like a 35% or something, but they don't have PVCs. Now, if they start having PVCs, these PVCs lead to this EF of 35% going down to the 25%. And that is known as PVC worsened cardiomyopathy, and that leads to worsening of heart failure. And if we remove that PVCs from the patient by doing catheter ablation, again EF will go back to 35 and patient will reach to the baseline heart failure status and worsening of heart failure will improve. Thank you.
And I'll make my talk short in interest of time. We've talked about advancement in cardiac devices over years, and amongst pacemaker, I've talked about leadless pacemaker. Now, till now we have been using single chamber leadless pacemakers. Whether the time has come for dual chamber leadless pacemakers. So I'll talk a little about that. So unlike traditional pacemakers, leadless pacemakers are implanted directly into the heart through minimally invasive catheter based procedure. Just like TAVR, you are all aware of TAVI. We put a sheath and implant the valve in the aortic place. Same way, these are just capsule shaped pacemakers which are implanted from the femoral vein, IVC, RA into RV. The advantages, the traditional pacemakers have lead related complications, but here those complications are virtually negated and the recovery is much faster. But it's been limited to single chamber pacemakers. This is how the pacemakers have evolved over time. This was the earliest pacemakers and they have become smaller, and this is what we are talking about, leadless pacemakers. The first leadless pacemaker was cleared in 2016 and the other company made it in March 2022. But both were single chamber pacemakers which limited their use. Most of the patients, we want them to have AV synchrony. So dual chamber pacing is desirable. A traditional transvenous pacemaker is like this. One lead goes through the subclavian vein into the SVC, one is into the right atrium, and the other lead goes across the tricuspid valve into the ventricle. For CRT, we have multiple other leads. But there are problems associated with it, and especially when these patients can have lead related issues. This is what we are worried about. Fractures, insulation breaches, venous thrombosis, venous obstruction, tricuspid regurgitation, or infections, hematoma, erosion. These are two major issues. And there are cosmetic, patient-related, experience-related issues. Chest scar, especially young ladies if they need pacemakers. So sometimes we implant it axillary, so the device is inside the axilla. They feel the bump, visible reminder that the pacemaker is always there. And there is some restriction, at least initially, after pacemaker is implanted. So to eliminate all these problems, there is a felt need for leadless pacemakers, and these we can virtually eliminate these lead related problems, and the pocket infections are eliminated because there is no pacemaker pocket. There is no chest scar, no bump, no visible or physical reminder of a pacemaker under the skin. Complications related to these are all negated. And this is what a leadless pacemaker looks like. It is implanted via a sheath system. This is a deflectable sheath, and this is a leadless pacemaker. It's just bigger than a capsule. This one has a tine in front, the other one has screw in the front. It's implanted into the RV apex or RV septum. We can choose where we want to implant this. This is a post-implant X-ray showing this leadless pacemaker. The same company, Metronic, introduced the Micra AV, where it's a single pacemaker, but it is able to sense atrial activity due to the hemodynamic changes. So in patients with heart block, if the atrium is contracting well, it can still give you AV synchrony. But where there is sick sinus disease, sinus node dysfunction, that would start working like a ventricular based pacemaker. So we need a system of something like this, two pacemakers. With the leadless Micra VVIR pacemaker, 63% fewer major complications than traditional pacemakers. The chances of reinterventions are less. Chances of any kind of complications are also much less. When we select a pacemaker for a given patient, this is an algorithm which we go through in our mind, whether the patient requires AV conduction, whether AV synchrony is desired or not. If there is you desire AV synchrony and rate response, this patient will require a dual chamber rate responsive pacemaker. But if AV synchrony is not desired, then a single ventricular based pacemaker is also fine. For AV block also, similar kind of algorithm we go through. If we can just go with a leadless, if the patient has chronic atrial fibrillation and a heart block, then a ventricular based pacemaker is enough. But if you plan to restore sinus rhythm and you desire AV synchrony, then a dual chamber pacemaker is needed. So outside, when you have a transvenous pacemaker, you have a pacemaker here, both leads are going into the pacemaker, you are sensing from each chamber. So it is easy for the pacemaker to look at the atrial activity, ventricular activity, and decide whether to pace in the atrium or not, or pace in the ventricle or not. And the correlation, the interrelation between the atrium and ventricle is well managed, and you have good AV synchrony. But here in a leadless pacemaker, you have one device in the atrium and one device in the ventricle, and there is no way that these two are connected. There is no connection between the two. How do they communicate with each other? How do you decide for a given patient that you get good AV synchrony? So this is done by sub-threshold electrical messages from one device to the other, and this is really amazing technology. This is called eye-to-eye communication, implant-to-implant communication between paired leadless pacemaker for dual chamber pacing. So eye-to-eye communication modality employs sub-threshold electrical signals conducted between the implanted leadless pacemakers through blood and myocardial tissue on a beat-by-beat basis. So for every beat, there is signal sent from this device to this device and from this device to this device. And that will keep the rhythm in what you desire it to be. This has been done in sheep, and it has been shown to work well. I'll just talk you through this. Encoded subthreshold message sent, atrial pacing delivered. And the other device, message received, atrial pacing delivered, initiate AV delay, that is the PR interval, initiate that. Once that is done, the encoded subthreshold message sent, ventricular pacing delivered. So this has given a stimulus now. Initiate 60 beats per minute VA interval, where it's a blanking sort of period. And message received again by this device that ventricular pacing has been delivered, initiate this VA interval, and then deliver the next atrial beat. So every beat, there is communication from this to this and this to this, and it's an amazing system. It's like a walkie-talkie in the heart. For the first time, synchronized dual chamber pacing has been demonstrated in a chronic study by two leadless pacemakers using beat-to-beat wireless communication with a success rate of more than 99%. Isn't this amazing technology? Isn't this just really great what is happening here? And Abbott has been the leader here. Their Avier leadless pacemakers, the atrial pacemaker is just a little smaller than the ventricular. And this has got a screwing, the Metronic had tines, this is as a screwing mechanism. And this thing, the little knob here is actually, if you want to retrieve the pacemaker, take it out, you can snare this part and take it out. So it's a first of its kind leadless pacing system that incorporates implant to implant communication, eye to eye. This is something will become, this terminology will get used to over a period of time. It's a novel fixation, screwing type of fixation. We can do pre-fixation testing, check for dual chamber functionality and make sure everything is working fine before we accept the place, and it is retrievable using that small knob. We can snare that and remove it. So built upon just like the single chamber leadless pacemaker type, So what essentially it's doing is a dual chamber pacemaker. This is a atrial single chamber pacemakers. Previously, single chambers pacemakers were combined to create a dual chamber pacemaker. Here, a dual chamber pacemaker has been split into these two leadless pacemakers which communicate with each other and provide its two devices working together. All these studies are ongoing at various places. The first study, it's planning to enroll about 550 patients. So leadless pacemaker selection consideration, where there are anatomical or vascular issues. There is venous axial occlusion, there is no access from anywhere. There are indwelling lines or ports for chemo or for dialysis. The vessels are thrombosed, hemodialysis patients, risk of congenital heart disease, where there is just no access to the heart, severe kyphoscoliosis. Younger patients, or where very infrequent pacing is expected, in these patients, rather than giving a transvenous device with a permanent reminder, it may be a good idea to put a leadless pacemaker. If a device has been extracted for infection, etc., for pocket erosion, and then you don't want to repeat the same experience elsewhere, like the lady I showed, she had a defibrillator, we cannot give this kind of device to her, but that may become an option in the future. So post-extraction, pocket erosion, pre-existing leads where you don't have any more access. Prior failed implant due to infection, renal diseases, tricuspid valve disease, if there is a mechanical or valve in the tricuspid place, previous endocarditis, immunosuppressed patients, here the infection risk is high, or very elderly patients, dementic patients, or a very young patient, where the patient is getting a pacemaker, say at 4, 5, 10 years of age, and for the next 18 years of age, next 80 years will require pacing. And in these cases, these leadless pacemaker becomes a good option. And patient preference. Cosmetic, you don't have any bump seen, no scar. Occupational lifestyle, there are sports people where post device implant we say avoid contact sports. This would probably not be an issue in these patients with leadless pacemakers. Where psychological twiddler syndrome where patients play with this. Leadless pacemakers are an option in previous device infection, vascular occlusions, young patients for preservation of vasculature, or patient preference. All of the above? Yes. And pacemaker types include single chamber transvenous pacemakers, dual chamber transvenous pacemakers, single chamber leadless pacemakers, dual chamber leadless pacemakers, all of the above. This has been the pacemaker evaluation. This is a evolution. This is an external pacemaker. These are implantable pacemakers. Look at this. This is in the late 50s, 1970. The devices have become smaller and more capable. They are capable of a whole lot of new things, more things. The battery lasts longer. Nowadays, some of these pacemakers actually last almost 15 years. So leadless pacemakers are useful in difficult and unique situations such as previous infections or vascular issues. Single chamber leadless pacemakers have been in use past few years and have proved to be reliable and useful alternative to conventional transvenous pacing. And dual chamber leadless pacemakers that communicate with each other, implant to implant communication, represent an important leap in device therapy. Thank you. I'll stop here.
So it's part 2 actually. So like yesterday, I got audience response questions and I'll keep the result here on this screen. And we'll see whether we have learned something, what we were thinking before the trial presentation and what is the result of the trial and should we change the practice or no. So we'll go. Yesterday we discussed this first column and I'll go, all interesting trials are there. I'll not discuss Vellore HCM because the godfather is here and he is going to speak again, Dr. Milind Desai. So let us start with this. See, pregnancy and hypertension is a big problem, real clinical issue. Most of the guidelines European, American cardiac guidelines or obstetric and gynec guidelines, they all agree that if BP is very high, more than 160, 110, it should be treated. But there is problem for mild to moderate hypertension. If you don't treat, mother gets risk of preeclampsia, eclampsia, placental abruption and premature delivery. If you reduce the BP, fetus suffers. There is fear of placental ischemia, fetal growth retardation and even intrauterine death. So what should be the target of BP during pregnancy? Should it be less than, it is audience response, be ready. It's less than 160, 110, 150, 100, 140, 90 or 130, 80. Your time starts now. So everybody is, or there is only 1% to vote, I don't know. In any case. So basically, CHEP was the trial to assess the treatment target for mild hypertension during pregnancy. It was a multi-center RCT of more than 2,400 pregnant women with mild hypertension, whose systolic BP was 140 to 160 and diastolic BP was 90 to 105. They were included after 23 weeks of gestation. Women with severe hypertension, diabetes, CKD, they all were excluded. Active arm group women had target BP of less than 140/90 and they were treated with labetalol or nifedipine. Standard arm group women were followed without any antihypertensive treatment unless their BP went to more than 160/105. Mean age was 32, majority were obese and BP was kept at target in both the groups. See, primary endpoint of maternal and fetal well-being was in favor of active arm group with target of BP less than 140/90. All parameters like preeclampsia, preterm baby, abruption of placenta or fetal or unit of death, everything was in favor of BP less than 140/90. And superior and maternal outcome was not associated with any fetal growth retardation. So, CHEP trial of treatment of mild chronic hypertension during pregnancy conclusively showed that maternal and fetal safety with active treatment of hypertension with target BP of less than 140/90. So, correct answer is less than 140/90. So, we have learned something. Another trial question, long question, just read carefully. After high risk PCI of a patient who is on optimum guideline directed medical therapy, at 1 year, which screening test is better to assess risk of future cardiac event? So we do PCI or CABG, we do revascularization and we always follow the patient and we try to assess that my stent is getting blocked or no, there is instant restenosis or no. So what should be done? I want the best for my patient, so I do stress myocardial perfusion scan, that is nucleus scan, thallium scan. Another option is nucleus scan is not required. I am good at echo, stress echocardiography is equally good. Third one will say, okay, I prefer stress test, TMT. It is simple, cheap, easily available, widely available. And there may be some cardiologist or physician. I don't do any stress test. My clinical assessment is enough. So, okay, let us see. I'm surprised nobody gave to one. So, this post-PCI was the trial. How to monitor patients after PCI by routine functional stress test or standard clinical care. There is limited data by RCT on this, and post-PCI was the RCT to assess this aspect. It was a multi-center RCT of nearly 1,700 patients who had PCI with high-risk anatomical and high-risk clinical features. If you see the clinical profile, 20% had left main, 44% had bifurcation, multivessel, diffuse, CTO. Clinically also they were diabetic, SCS, chronic renal failure. So all high-risk patients were there. And at 1 year after PCI, all patients were randomly undergone either routine functional stress testing, that is nuclear, or echo or exercise ECG, that is TMT, or they were just followed clinically by standard care alone. Majority of these patients had good PCI. They were done under IVAS guidance or FFR guidance to have optimum result at the end. And note that majority were on optimum guideline-directed medical therapy also, including DAPT and statin. 98% were receiving this at the end of 1 year or even at 2 years. What was the outcome? At 2-year follow-up, primary endpoint of composite of death from any cause, myocardial infarction, hospitalization for unstable angina was not different between patients with standard medical care versus patients who had undergone functional stress testing, including all those three. And even death was similar between the group. If you see myocardial infarction, no difference. Hospitalization for unstable angina, no difference. In fact, need for repeat angiography and need for repeat revascularization was numerically more with the functional stress test. So if you do some functional stress test, you will find some positivity and you will tend to do angiography or even need for revascularization, although this was not statistically significant. So message was, post-PCI trial concluded that even after high-risk PCI, routine screening with functional stress testing compared to standard medical care is not superior to prevent future event if the patient is optimum PCI with image or FFR guidance and is on optimal guideline-directed medical therapy. So that does not mean that you don't do anything. You have to remember two things from this message. So correct answer is last. Nobody has preferred that one. So it is not that I am boasting myself. It is not like that I am a good clinician. What you have to see is that how PCA was done, whether it was done under image guidance or no, whether patient was had FFR or no at the end, where FFR was negative after the stent implant. And more important is that whether he was on guideline-directed medical therapy or not, whether he was following lifestyle measures, whether it's LDL, BP, diabetes, everything was under control or no. If you do this all clinical parameters correctly, you may not need any kind of test. Your clinical judgment is enough. So that is again says that guideline-directed medical therapy, achievement of goal, that is more important than your costly nuclear scan. Third question, again this is long question. Triglyceride and cardiovascular risk, always a hot topic and we don't know what to do. Which statement is true? Increased triglyceride increases CV risk. That is a statement, but it is a hype. It is unnecessarily people are promoting triglyceride or showing fear. Another option is no. In clinical trials, reduction in cardiovascular risk was directly correlated with proportion of triglyceride lowering. Third option is so-called benefit of icosapent ethyl in reduced trial was actually related to harmful effects of placebo. In that trial, if you remember, it was mineral oil which was used as placebo, and that was criticized because mineral oil was like toxic. It increased LDL and some other parameters, and actually so placebo arm actually was worsened. So compared to that, this icosapental ethyl was slightly in favor. So that was the argument. Fourth option is no, icosapental ethyl is good and it causes plaque regression. And in fact, widely available and cheaper good fish oil, which is rich in omega-3 fatty acids, EPA and DHA, is enough and equally good. So actually very few have this audience response. So majority prefer E. So omega-3 fatty acids. Let us see. So prominent was the trial. It is a trial of a new and promising fibrate, that is PEMA fibrate, to assess cardiovascular risk reduction with triglyceride lowering. It was a multi-center RCT of nearly 10,000 patients with diabetes, having typical diabetic dyslipidemia, very common in Indians, triglyceride between 200 and 500, and HDL was less than 45. PEMA fibrate dose was 0.2 milligram, and follow-up was 3.4 years. Majority again were on guideline directed medical therapy. Note that 96% patients were on statin also. There was significant reduction in triglyceride and remnant cholesterol. And in spite of that, primary endpoint of composite of 3-point MACE, that is death, MI, and stroke, and coronary revascularization was not improved by pemafibrate. So again, one more fibrate, very promising fibrate in initial phase 1 and 2 study, did not improve any kind of clinical outcome. So pemafibrate was another disappointment among diabetic with diabetic dyslipidemia. It did not reduce any clinical event in spite of significant lowering of triglyceride and remnant cholesterol. So correct answer actually is icosapent ethyl causes plaque regression. So basically, see, you know Deepak Bhatt, who is godfather for this reduce it trial. So it was so much criticized for mineral oil, and after that so many trials were done with the icosapent ethyl with mineral oil versus with the total placebo like, water like thing. And it was clearly shown that mineral oil is not a harmful placebo. Then they did so many IVAS and OCT guided trials where they showed clear cut plaque regression with icosapent ethyl. So icosapent ethyl, why there is difference between this good oil, fish oil and other kind of omega-3 acids? They all are mixture of EPA and DHA. Actually DHA is not good. Only EPA, and that also icosapent ethyl is it is not fish oil. It is highly purified version of EPA, and that is filled in capsule. So it is not over-the-counter medicine. It is a medicine itself produced in factory. So it is highly purified icosapent ethyl, that is only useful, and now it is available in India also. So I am using it, and it is a good molecule, and that is what data also says. Tirzepatide, yesterday Keubai told about this molecule, which statement is incorrect. It is syncretic mimetic, it is approved by FDA for diabetes, it is useful as anti-obesity medicine in obese diabetic, it is useful as anti-obesity medicine in obese non-diabetic also. Like liraglutide, it needs subcutaneous administration daily, or all are correct. Your time starts. So, okay, let us see. 50-50. So, SURMOUNT was a trial of tirzepatide, a novel dual incretin mimetic for the treatment of obesity. It was again multi-center RCT of nearly 2,500 patients who were obese and non-diabetic, having BMI of 30 or 27 with risk factors. They were randomized to 5, 10 or 15 mg of tirzepatide given subcutaneously weekly, not daily. Remember, weekly, compared to placebo, and they were followed for 72 weeks. Mean body weight was 104, BMI was 38, so really obese patient. And co-primary endpoint of percentage change in body weight from baseline and weight reduction of at least more than 5% was substantially more with tirzepatide, and the effect was dose dependent. So more the dose, more is the weight reduction. So it was a positive trial with substantial and sustained reduction in body weight with weekly subcutaneous tirzepatide. So your correct dose is this. Correct answer is that it is given weekly, not daily. Liraglutide is daily injection. This is weekly. It's a dual incretin mimetic. So very good molecule. I think future is there. And I think this is last trial. Obesity in adolescent. Yesterday we discussed partly about this also. Following drugs are approved for obesity in children more than 12 years of age. Semaglutide 2.4 mg subcutaneously weekly. Liraglutide 3 mg subcutaneously daily. This is for children. Orlistat 120 8 hourly orally. Phentermine, topiramate combination, or all of the above. Which drug is approved for adolescent obesity? So good. So step 10 was the trial. It was a subcutaneous semaglutide in adolescents with obesity. Again, multi-center RCT of around 200 patients with age 12 to 18 who had BMI of 95th percentile or higher. Patients were given weekly 2.4 milligram. In diabetes, we use 1 milligram, 1.2 milligram. Here it is 2.4 milligram, sub-Q semaglutide, and followed for 68 weeks. Mean age was 15 years. Mean body weight was 107 in those small kids. BMI was 37, so real obese patients. Primary endpoint of percentage change in body weight from baseline and weight reduction more than 5% was substantially more with semaglutide, and the efficacy was dose dependent. So trial showed that weekly semaglutide is effective for substantial and sustained weight reduction in adolescents with obesity. So as we discussed yesterday, just day before yesterday, FDA approved this molecule for use in children also. So I think that was the last trial. So all of the above is the correct answer. So if your patient is adolescent and obese, you can give any of these whichever patient can afford or tolerate. Thank you.
Okay, so I have no conflicts of interest. And the slide here talks about there is a group of people who are very actively talking to each other. There is a community, and then there is an ivory tower in the back. And I think what we often see is there is a group of people, the highbrow people, talking about their studies and living in these silos and living in their ivory towers. And then they lose contact with the other part of academia and non-academia. And part of what I want to talk about is give an example of how the medical community lives in these silos, and what we need to do is expand our horizons a little bit so we can actually stay up to date with everything else. More and more in the world, what we know in one domain, the problems that we face can be solved by collaborating with people in other areas. And if we live in our silos and in our domains, we often may not solve problems that have already been solved by others. So staying up to date is going to involve not just staying up to date with one specialty, but also looking at other disciplines. So let's take an example of what happened during COVID. The infectious disease community and the healthcare community forever and ever has lived with this concept of diseases are caused by droplets. And droplets, just to remind everyone, is like a cannonball coming out of a cannon. It has a trajectory and it falls. And they came up with this magic distance of 6 feet, that if you are 6 feet away from someone, you're safe. If you're within 6 feet, things will land on your nose or your mouth, and you will ingest it, inhale it, and get disease. The other concept was aerosols, right? And aerosols are like feathers. I could be speaking here, and the virus particles could be floating and could reach you, right? And any place that has closed ventilation, this could happen. When COVID happened, and this was SARS-CoV-2, right? So with SARS-CoV-2, the WHO came out with this very big statement saying it is not airborne. This is from the WHO Twitter feed. The CDC said the same thing. Even after several months of COVID, they were saying this. This is in spite of knowing that SARS-CoV-1, many years ago, was airborne, proven. If you ever want to look that up, look up the Amity Garden study. One apartment building, people living in one floor were giving COVID to, or not COVID, but SARS, to people living on another floor in the same building without ever coming in contact with each other. It was spreading through the sanitary system because it was dry. There was no water in the system. This was a fantastic study done 12 years ago. Everyone ignored it. Everyone should have known that COVID was airborne before it started. So how did it end up being found out? So this is a great simple read in Wired magazine. Just look it up. For 60 years, healthcare has messed this up. We knew tuberculosis was airborne. Then we found out measles was airborne, but we still kept thinking everything else is not airborne, it's droplets. We kept washing our hands, but never wearing a mask. And we thought we were doing the right things. So look at these researchers. This one is a professor in environmental and water resources. Another one in atmospheric and earth sciences. This is a forensic detective, not a physician. This is another person at Colorado. These are the people, when they saw that the WHO said this is droplet, they knew it was wrong. And it was all based on the WHO continuing to look at data that we have created in the medical community, while in environmental sciences, they knew particles this small will float. They knew that forever. They've done studies with particulate matter, with pollution. They knew this is completely wrong. They met with the WHO and the WHO threw them away. Literally said this is wrong. So all the papers that came out in non-medical journals, and finally it took a year before the CDC and the WHO realized that they were wrong. So read this particular paper. It's free. It is the most fascinating story of how we stick our head in the sand and never learn. And this is very important. So it becomes even more important as we look at the information tsunami. 1 million publications per year in PubMed. How the heck are we going to keep track? So we keep going to conferences. I don't say don't go to conferences. Listening to experts, yes, listen to experts, but broaden the number of experts you listen to, because sometimes the answers are outside that area. So that's part of your strategy. One, when you have so much noise coming at you, create filters. Go deep and remove some of the noise. Secondly, don't get trapped in silos. I just told you what kind of silos there are. And then how can you do this? So we'll look at 3 types of technologies that can help you do this more effectively and efficiently. And finally, there are tools and there are tools, but unless you develop habits to use these tools, it doesn't work. They'll just sit there without being used. So learn to use these tools and create a habit. So the first set of tools are called aggregators. Some of these are familiar to you. I'm going to whiz through them real quick because this is just to let you know what exists. The 2 that I would recommend, one is Medscape, and one actually that I actually use is called Read by QXMD. Both are free. Again, I chose tools that don't cost anything. So we'll take a look at Read by QXMD. So what it lets you do is create a feed. So if you look here, this is your featured feed. This will be different for each person, and you can customize the feed using what you want, the keywords, the collections, the journals, etc. And it sends you trending papers based on what is popular. So you can see the number of views these papers have had based on your areas of interest. You choose your areas of interest by choosing the journals you want to follow. So I see a lot of medicine journals and medical education journals because that's my career. You can also create your keywords based on your interests. So these are some of my interests, as you can tell, and that will generate the feed for you. So try this out. It's free. There is a free app for your phone, and you can whiz through these things and stay up to date. The next group of tools is something called feed readers, and I'm going to show you InnoReader. Again, this is free. The benefit of this over QXMD is you can customize it even more, but it also has tools to help you recall what you have read, and I'll show you what that means in a minute. So this is my feed on InnoReader. At the top, you can see I have various journals, like here are some cardiology journals that I might follow, and they come to me. I don't have to remember to go to NEJM to look up the latest NEJM papers. And it keeps track of which ones I've read, So for example, I created a very custom PubMed feed on COVID. Now, I'm not that interested, so it says I have more than 1,000 articles to read, and I'm not reading as many anymore, right? But I'm also interested in virtual reality, and I created a feed for PCSK9 inhibitors because when they were really coming into vogue, I wanted to stay up to date. And so this is a feed I create on PubMed, and it sends me every new article with specific, I would say, limited to randomized trials, limited to these journals, and it will come to me. So it keeps track of this, and right here, I can put tags on this, star them, and so I can always find the papers that I liked again later. So for example, here are some tags. So I had tags on a COVID tag. So every time I saw a paper that was related to COVID and I thought was useful, I would tag it, and I had 52 tagged articles back in November when I took a screenshot of this. So the point of this is you have to create a habit, use the tools. There are many tools out there. Think about what your interests are, customize the feed, and you will get all the information delivered to you. If all of us spend hours doing stuff that I would call maybe waste time, get on a treadmill, and as you're on the treadmill, just scan through these. You will at least know what is coming up. Tag it, favorite it, and those are the ones you're going to get the full text and read. So that will help you with medicine stuff. But the question is, I talked about the droplets and the aerosol. There were engineers out there who actually knew more than the doctors. We don't read those journals, so how would you keep track of them? What you want to do is have some tool. I'm giving you example of Twitter. And on Twitter, what you can do is create lists. So instead of the garbage 500 posts a minute that are coming through, create a list of people that you follow. These are people who post useful stuff on Twitter. Create the list, and you can see I have a list on COVID. I have a list on politics. I will not share that with you. You may not agree with me. I even had a list on Ukraine. When the Ukraine war started, I had a list of reporters reporting from Ukraine directly. I didn't have to wait till CNN or some TV station picked up the information. They were posting videos from the war, and you could see what was happening 2 days before the news came out. So for COVID, for example, I created a list that has 62 people who post there, and they are people like this. So Greg Gonzalez, for example, he is someone at Yale. He did a lot of work on HIV, and looking at him and what lessons he shared from the HIV epidemic helped us be better informed on how to manage, because US failed during AIDS epidemic, completely failed. It took many years before we got our act together and started doing something constructive. We did the same thing. We failed again during COVID. And the lessons learned, you learn from someone like this. So I have 62 people like this, including the engineers who published those papers. So I'm on being recorded, so I won't say too much, but literally this helped us drive some of the policy changes that were not congruent with the WHO, but we were ahead of the curve, wearing masks, etc., before the recommendations came out, because we knew what the truth was. You can bookmark these, and then you can always find them again, and this becomes your running total of information that you found. You can go back and look at it. So what are the take-home points? You cannot keep up with everything, so you have to rely on others. Rely on aggregators, feeds, and lists. Create filters, so you don't have to see everything. See stuff that is more meaningful, more signal, less noise. Create a habit. So just say Sunday morning, my family is still asleep, make a cup of chai, and I'm going to spend an hour going through my feed. Within a few months, you will know more than everyone that you work with. And then remember to use the tools. So once you read it, if you are like anyone else, you will think you'll know it, but you won't. You will forget what you read, but you want to be able to find it again. So use the tools that will help you find what you have read, And once you read it twice, you're going to remember it even better. So thank you so much for your attention.
Thank you once again for this opportunity. So I don't have any disclosure. So we know the risk stratification of pulmonary embolism very well. Whenever the patient does not have any hypotension, the systolic blood pressure is, patient has a hypotension and systolic blood pressure is less than 90, we consider that as a high risk PE. And when that situation happens, at least the decision making is peaceful, not the patient life is peaceful. But the decision making is peaceful because I think nobody will argue that we should not thrombolize those people, or some form of a revascularization should be achieved if the patient is hemodynamically unstable. Problem is that when the patient does not have a defined hypotension or so-called hemodynamically stable patient, but they have a significant RV dysfunction, which is defined as a RV-LV ratio of more than 0.9, either on the CT or on the echocardiography. And if you have a positive biomarkers, for example, positive troponin or positive BNP, plus they have a increased risk or the increase in a S-PASI score of more than or equal to 1. Again, just to remind you, the S-PASI is a simplified pulmonary embolism index. There are 6 different parameters, and I made a little mnemonic so that you guys can remember, known as a S-PEPSI. So it's SpO2, pulse rate, elderly patient, pulmonary or cardiac disease, systolic blood pressure, and infiltration or a cancer. Any one of these things is positive, so they have a 1 point on or higher on S-PASI, positive RV dysfunction, those patients will be considered to have an intermediate risk pulmonary embolism. And finally, if they don't have hypertension, no RV dysfunction, and S-PASI score is 0, those patients can be considered as a low risk. So today we'll try to focus on this intermediate entity or intermediate risk pulmonary hypertension. Obviously, when the risk is higher, the prevalence rate is lower and the mortality is higher. So I think that's very well understood. But this patient, or at least 55 to 60% of the patients with PE belong to this middle category. That's what we'll try to focus. So I have a case for you. The 55-year-old guy who has a shortness of breath for the last 2 days, has a 20-pack year smoking history, and recently diagnosed to a COPD, took the flight from Italy to Delhi, and of course diagnosed with a saddle pulmonary embolism. On admission, the blood pressure was good, 120/76, heart rate is 114, pulse ox is 91% on a 3 liter, so reasonably maintaining well. RV-LV ratio is 1.2. Remember I told you it's more than 0.9. BNP was higher and troponins were higher. So I think the patient has a positive RV dysfunction. Biomarkers are elevated. So in summary, I will say that the patient has intermediate risk pulmonary embolism with S-PASI score of 3 and the RV dysfunction and the biomarkers are present. So what will you do for this guy? I don't know you guys have a voting pad or not. Will you give them a TPA? Will you give them IV unfractionated heparin? Or will you give them a low molecular weight heparin in a therapeutic dose, not prophylactic dose? Do you guys have a pad, voting pad? Okay, so half and half. Wow. So probably two people voted. I will say we'll probably give a low molecular weight heparin, and I will tell you why. So the first, let's understand why not TPA, or why the TPA is an uncommon or the wrong answer. So this was one of the most important landmark study published in 2014 in New England Journal of Medicine, which is still the largest randomized controlled trial for the field of intermediate risk pulmonary embolism, known as a PYTHO trial. What they did, they randomized the 500 patients on the TPA arm and then another 500 patients on the placebo or the heparin arm. So one group was upfront received the TPA, other group received only IV heparin. And they did not find any difference in the mortality, or the mortality at the 7-day or mortality at 30 days. And so far, this is, as I said, the largest randomized controlled trial, did not show the evidence or the positivity of revascularization early on if they do not have a hypotension. So I think the correct answer is probably no need for the thrombolysis, but between IV heparin and the low molecular weight heparin, why I'm choosing a low molecular weight heparin, I will tell you in a minute. Remember whenever the people had the TPA, they had a more risk of the major bleeding, the 11.2% versus 2%. And they have a significant higher number of the hemorrhagic stroke, which was obvious. that if you give TPA, the risk of the hemorrhagic stroke is more. Even there was a meta-analysis. Actually, there are probably 12 or 13 meta-analysis since the Pythor trial was published, and I don't know why there is a need for a lot of meta-analysis. There is a lot of data flooding, but this meta-analysis was published last year, 2 years ago now, and as you can see, they have approximately 2,000 patients, 992 on the thrombolytic arm and the 1,000 patient on the conventional arm, and the difference or the p-value was not significant for the thrombolysis. So I think the correct answer is there is no need for the upfront thrombolysis on those type of patients. It's not indicated for the garden variety PE patient. Now, why between low molecular weight heparin versus the unfractionated heparin? So remember, the average time to reach the therapeutic range once you start the IV heparin, even if you give a bolus, was ranging anywhere between 87 to 2000 minutes. Approximately the mean value was 594 minutes, or 10 hours. So after 10 hours, patient will reach to the therapeutic heparin level. In the same study, they also found that only 22% of the time with IV heparin drip, patients were in a therapeutic range. 44% of the time they were above, and 33% of the time they were below the therapeutic range. So IV heparin is a good tool, but unfortunately the therapeutic window is not achieved early, and therapeutic window is not maintained in all the patient. So in 2019, ESC guideline mentioned that the low molecular weight heparin or the fondaparinux are preferable compared to the IV heparin, although our 2021 ACCP or American College of Chest guidelines did not mention or did not comment on any of this thing. But I think given the quite a good evidence, the low molecular weight heparin is preferable. The second case, this is a 40-year-old female who is an athletic female, smokes on oral contraceptive pill, has sudden shortness of breath, found to have a saddle embolism. Blood pressure was 120 systolic, heart rate is normal, the pulse ox is 91% on room air, RV-LV ratio is 1.1, echo did show RV strain, and the BNP is 60. So in summary, the patient has this is a hemodynamically stable patient with RV dysfunction and the negative biomarker. So the patient was started on low molecular weight heparin and transferred to the step-down unit. Almost 30 hours down the road, once the therapeutic heparin or the low molecular weight heparin was started, now the patient's blood pressure has gone down to 110, heart rate has increased, the patient has increased shortness of breath, pulse ox has gone down, CT of course is not repeated, echo is not repeated, the BNP was increased from 60 to 200. So still we have a hemodynamically stable patient, but now the S-PASI score is 2, which was 0, and the biomarkers were negative, now the biomarkers are positive. What will you do with this patient? Will you give the IV TPA, continue low molecular heparin at the same dose, increase the dose, or change the low molecular weight heparin to unfractionated heparin with the bolus? Wow, excellent. I think this is a good patient to give a TPA, and why do we say so? So one of the important things that can this be considered a sign of a deterioration when the S-PASI score is going up and up and up. Lisa Mures, who was a lead author of all 3 ACCP guidelines, has done this study back in 2013, and what they have done, they have serially monitored the S-PASI scores on admission at 24 hours, at 36 hours, at 48 hours, and so forth and so on. And what they found that when there is a significant increase in the S-PASI score at 36 to 48 hours, people have a 12.3% mortality. Remember, in a Pythor trial, the overall mortality in both the group, the conventional group and the TPA group, was around 3%, between 2 and 3%. Here now the mortality is in a double digit. Mortality is increased to 12.3%. So of course the risk has been increased. So in a new guideline in 2021, they mentioned that the people who deteriorate, you can consider thrombolysis. I don't think that yet it is a very concrete evidence. So the evidence is still of a low certainty. And this time they have defined what is deterioration for the first time in 2021 guideline. Increasing heart rate, decreasing blood pressure like in my patient, increased JVD, worsening gas exchange again like my patient, or the signs of a shock. For example, patient is in full-blown renal failure or the lactic acid is going up. Those are the things you can consider the sign of the hypoperfusion. Even though the blood pressure is normal, still that's a sign of the organ failure, and those patients can be considered for a for a rescue or the thrombolysis. This is the last case, 65-year-old female, shortness of breath for the last 2 days, history of COPD, heart failure, difficult to control blood pressure. Very important history point, since yesterday I'm telling you the same point, always the money is in a history. Stage 1 lung cancer and now diagnosed to have a saddle PE. Heart rate obviously is very high on admission. Blood pressure is not yet below 90, but lower side, 105 or 65. SpO2 is 88% on room air and 91% on 4 liters, so still difficult to oxygenate. Respiratory rate high, RV-LV ratio is huge, 1.6. You can see that this is RV, this is LV, and significantly high RV-LV ratio. BNP is 550, so profoundly high, and troponins are also profoundly high. Simultaneously, she has a DVT in the left femoral vein. So there is also a residual clot. What will you do with this patient? Will you give the IV TPA, unfractionated heparin, or low molecular weight heparin? Oh wow. I think I will consider TPA in this patient, and I will tell you why. So there are several important points about this particular case. You know, I told you that this was a difficult to control blood pressure. So we want to know what was a baseline blood pressure. If the patient is running around 140, 150, a 40-point decrement in a systolic blood pressure is considered relative or absolute hypotension. So that's a very well defined in the all three guidelines, 2016, 19 and 21, that if you have a decrement in a blood pressure from a baseline blood pressure, I think that is a sign of the hypotension. So if this patient was running in a 140, 150, and now it's a 105 or 110, I think still it is hypotension. So as I mentioned, that this was mentioned clearly in the guideline that this can be considered as the hypotension, and people can be actually thrombolized or known as a rescue thrombolized. Same thing happened again in 2019. The evidence was actually upgraded to the level 1 evidence, and then again in 2021 they kept a level 1 evidence. The second important part, that this patient had a proximal DVT. Remember, I told you femoral, not a popliteal or not the distal. Will it alter our decision? You know, when I ordered actually Doppler in a proven PE patient, they cancel my order. They say there's no need for the Doppler anymore because the patient already has PE. Your management is not going to change. That's what they do in our ultrasound department, and we are trying to convince them that's not true. See, this is one of the Japanese study, and there are so many of this one. This is one of the recent study. That's why I just quoted over here. If the people did not have an additional DVT or a distal DVT versus the people who had a proximal DVT, the mortality was 8.6%. So the people who did not have a DVT or even a distal DVT, mortality was still below 2%, like the Python trial. But when they have a proximal DVT along with a PE, mortality increased to almost 9%. So that's very important part, that we are trying to find out people with a higher possible mortality. The third part, coexisting morbidities. So they did an ad hoc analysis of an original Python trial and published in 2018. Original Python trial was published in 2014. And what they found, that the people had a systolic blood pressure below 110, respiratory rate more than 20, and they have a chronic heart failure or COPD, had actually improvement in a mortality. Say for example, this is outcome in the placebo arm or the heparin arm, 11%, outcome in the thrombolysis arm, 3%. So the p-value was significant. So when the people have additional morbidities, comorbidities, the thrombolysis may help. Of course, this we have to take with a pinch of salt, because this was not the primary intention. This was an ad hoc analysis. So this is not the best study. The best study is probably coming in next year, and hopefully we will have better data. The last point, what about the evidence from meta-analysis? You know, I showed you that meta-analysis, that there is no impact on a mortality. The p-value was 0.06. As I said, there are 12 or 13 different meta-analyses. One of the best meta-analysis was this one, done by the Chatterjee and colleagues and published in JAMA. They have actually almost 1800 patients, if you can see. They did find actually improvement in the mortality by thrombolysis up front. Then why are we not doing it? Because the number needed to treat was very high. You know, to save one life, you need to thrombolize 60 people, and you are putting them at a higher risk of a hemorrhagic stroke and a major bleeding. So the advantage of possible mortality was actually nullified by the possible side effects. So in the meta-analysis itself, they mentioned that this is a neutral and we don't recommend the thrombolysis. But if you look carefully, the only one study out of the all 7 or 8 studies was positive. You know, in a forest plot, whenever the line is crossing from a midline, that means it is bogus, it is not significant. But one trial done by the Fezulo, has a significant improvement in a mortality. And why was that? In a phase trial, the people were very sick. Their BNP levels were more than 500 in both the groups. Their RV-LV ratio is very high. So in a phase trial, they found that the mortality in people who did not get thrombolysis was 17%, very high mortality. So if you are predicting very high mortality in a patient, then I think the thrombolysis will be beneficial. And that's what also found in one of the radiology literature. So I think this patient was super sick, and I think the thrombolysis might be justified. The David Jimenez did this cartoon diagram and said that the PE is a spectrum. You don't have you don't just put the patient on low molecular weight heparin or heparin and forget it. You just have to monitor them forth and back. And based on this particular diagram, what I did, I created something known as a 5D approach. So these are the 5D or a take-home message you are going to keep in mind. The first D is a diameter. If the diameter is more than 0.9, it is RV-LV, it's RV dysfunction. But if a diameter is super high, the RV-LV ratio is 1.4, 1.5, those patients are very sick. DVT, the second D is a DVT. If they have a proximal DVT in addition to the PE, those patients are probably having high mortality. Third is a data. What are the other data you are going to look for? Borderline blood pressure, high lactate, significant hypoxia or worsening hypoxia. Those are the data you are actually looking for. The fourth D is a diseases. If they have a coexisting COPD or CHF, then those people might be at a higher risk. I won't say that every COPD patient should be thrombolized, but those patients should be kept under a higher monitoring situation. And finally, the deterioration. So if you see that there is a progressive deterioration after 6 hours, after 12 hours, after 24 hours, I think those patients probably should be considered for thrombolysis. With that, I will say thank you very much.
This is a big topic to talk in 15 minutes, but I'll try and do as much justice as I can. Here are my conflicts. I'm from the Cleveland Clinic. So I've shown this slide a couple of days ago. Hypertrophic cardiomyopathy, if we do some simple math, it is expected prevalence to be about 1 in 200 or 1 in 500. So depending upon what number you use, in United States, there's about 700,000 to about 1 million patients with HCM. If you extrapolate that for the rest of the world, we are talking millions, 16 to 25 million patients. Unfortunately, even in US, only we know of 100,000 patients. That means about 85 to 90% patients are still undiagnosed, misdiagnosed, or underdiagnosed. So do the math for the rest of the world. So we have a lot of opportunity to improve our understanding of the disease, and I feel we are just getting started. I'm going to divide this in a stepwise approach. How do I think about it? Imaging is key in the diagnosis of HCM. You need to be able to establish diagnosis as well as phenotype, be able to differential diagnosis, ascertain symptoms, connect the dots. Is the symptom due to outflow tract obstruction? Is the outflow tract obstruction a result of septal hypertrophy, a thickening of the LV? Or is there something else going on, mitral valve, papillary muscle? Are there symptoms due to something other than LVOT obstruction, like diastolic dysfunction or mid-cavitary hypertrophy? What is the risk for sudden cardiac death? And what are the familial and genetic implications? An important thing I'm going to talk about is not all HCM is thick walls, and not all thick walls are HCM. This person is your standard, very thick wall, hypertrophic cardiomyopathy with dynamic outflow tract obstruction, was gene negative for HCM. Treatment was a myectomy, did well, but the key word is gene negative. This person has no hypertrophy. The disease is named hypertrophic cardiomyopathy, but this person has no hypertrophy, yet gene positive. His problem was in the subvalvular apparatus, and we had to come up with a new surgical procedure to fix this person's problems. So, you don't want to be walking around dressing like this. You need a tailored approach. You need to look cool, like Anish Chandarana, right? So, you need that. Multimodality imaging is crucial in 2023 and beyond for diagnosis and phenotyping. So echo remains the mainstay, but cardiac MRI does offer complementary value. It is obviously more accurate for wall thickness assessment, but also for fibrosis as well as papillary muscle ascertainment, etc. We will talk about that. But these are 4 different types of hypertrophic cardiomyopathy patients. Standard on the top left, apical variant on the top right, papillary muscle problem on the bottom right, and concentric LVH on the bottom left. Step 2, it is absolutely crucial. If you suspect hypertrophic cardiomyopathy, you have to work to elicit outflow tract obstruction. If you don't look, you won't find. If you won't find, you cannot treat. And presence of obstruction is associated with worse outcomes. If you don't look for it, it is only seen in about 25% cases. If you look for it diligently, you can see that in about 70% patients. So designating somebody as non-obstructive hypertrophic cardiomyopathy without the full extent of provocation is not appropriate. So you as primary care providers or general cardiologists always question an echo report that does not have adequate data. Step 3, recognize typical and atypical variants of obstructive HCM. Not everything. Majority of them is going to look like this, thick walls. But there's a substantial group of patients that have subvalvular pathology, but the symptomatology is very similar. Obviously, managing these patients is going to be different. You cannot do an alcohol ablation in all these patients. You cannot do a myectomy in all these patients. You have to get creative about it. So designating somebody as not being HCM because they do not have LVH is also not appropriate in 2023. Step 4, crucial, sometimes not every thick wall is HCM. You have to be able to differential diagnosis. The images on the left panel are strain measurements on echocardiography. The top left is your standard HCM. Top right is your apical variant HCM with low strain in the apex. The bottom right is somebody with the exactly opposite presentation. That's a patient with a cherry on top we call apical sparing pattern of cardiac amyloidosis. 2 very different diseases, very different prognosis. Often CMR and multimodality imaging is necessary to differential diagnosis for athlete's heart, amyloidosis. 5% of patients in an HCM clinic tend to have Fabry's disease, which is something that has a distinct treatment for it and should be taken into account. Crucial, absolutely important, sudden cardiac death risk stratification. So there are 2 criteria. One is the American criteria, and the other is the European Society of Cardiology criteria. The American criteria is categorical variable, so it requires multiple family members with sudden cardiac death at a young age, severe LVH, unexplained syncope, non-sustained VT, scar formation more than 15% of LV mass, or burnt out end-stage hypertrophic cardiomyopathy or apical aneurysm. ESC criteria, you can plug in, it's a formula, you can plug in various continuous variables, and at the end of this equation gives you what is a perceived risk at 5 years. Less than 4, no ICD. Greater than 6%, you put an ICD. In the American criteria, if you have more than one or more, you put a ICD. So that's what this guideline document recommends. If you had a prior event, no questions asked. Documented event, you get an ICD. Otherwise, if you have one of the following criteria that we talked about, an ICD is reasonable. If not, if you have non-sustained VT and a lot of scar, more than 15%, you go ahead and get, it's reasonable to consider an ICD. So there is method to the madness. There's a stepwise approach how to deal with these patients. Step 6, additional management. This is where general cardiology and primary care become very, very crucial. You have to avoid negative medications that can aggravate outflow tract obstruction, like ACE inhibitors, ARB, nifedipine, nitroglycerin, digoxin. Patients typically benefit from beta blockers, verapamil, diltiazem, disopyramide. But these drugs, as we know, they have never been tested in HCM, they've been used, and there's new therapies we will talk about. Avoiding competitive sports, volume depletion, eating heavy meals, these are some of the things that you can advise these patients. Screening for sleep apnea is important. There is a strong association between these two diseases, so it is important to recognize and take care of that. Septal reduction therapy, so the gold standard way of dealing with these patients is septal reduction therapy. The standard way that we do it in USA more often than not is surgical myectomy. Majority of the patients with a thick wall, basically you can shave the muscle, life goes on. But as I've shown you, there is plenty of patients that have an atypical presentation. We've done a lot of work in this space, and we've developed different surgical techniques at the Cleveland Clinic, including reorienting papillary muscle and doing some innovative mitral valve repair type work to help relieve the obstruction. The key fact here is you need to relieve the obstruction without replacing the mitral valve. It obviously needs an experienced center, experienced surgeon, and experienced team of imagers, clinicians. Using this is our data. We published a few years ago now, almost 2,300 myectomies. Basically, doing this at an experienced center, your outcomes are similar to age and gender. Your life profile switches to similar to an age, gender match normal population. And an earlier operation we have shown is associated with better outcomes. Doing all these creative mitral valve procedures was not associated with any outcomes penalty. Alcohol ablation is also an option at our center. We use it in patients who are high risk for surgery, but it requires appropriate septal perforator anatomy, adequate size septum, and no mitral valve papillary muscle issues. So this is an option if your surgical team is not experienced, if your outcomes are not good, and if you have good criteria, this is also a reasonable option. Guidelines, let's focus on the green class 1 indication. SRT, no matter alcohol or myectomy, should be done by an experienced provider at an experienced center. If you are going for a myectomy, then do a complete job, fix everything that needs to be fixed. If you cannot do that, then alcohol septal ablation is a reasonable option. Class 2B, these are indications that are driven, a lot of this has been driven by research that we published. It is okay to send a patient for an earlier operation if they meet some of these criteria, but experience is needed. And it is not okay to be sending asymptomatic patients or considering mitral valve replacement without trying myectomy. New, we've talked about this a couple of days ago. Mavacamten is a new class of drug, cardiac myosin inhibitor, which directly works. It's a precision medicine which directly works on hypertrophic cardiomyopathy patients to help basically reduce actin-myosin cross bridges and improve compliance and energetics. This has been studied in 2 randomized trials. Explorer trial was in less symptomatic NYHA class 2 type patients where it improved their NYHA class as well as significant improvement in outflow tract gradient without significant worsening of ejection fraction. Valor HCM, this is the study that we've led and published. This was in highly symptomatic patients referred for septal reduction therapy. 92% patients were in NYHA class 3. What we have shown is at 16 weeks, 82% patients no longer met criteria for surgery. At 32 weeks, 89% patients no longer met criteria for either surgery or alcohol septal ablation. So this is potentially a game changer. This drug is now FDA approved in USA, and it is going to be approved in India, I understand, sometime in 2024. It has shown a significant improvement in all the secondary endpoints, including gradients, Kansas City Quality of Life questionnaire, But more importantly, it is also causing mass regression and LA volume improvement. So it is fundamentally changing the disease process at a microscopic level. AFib is a bad actor in this disease, and you have to be very aggressive. I think about dealing with AFib as trying to prevent AFib, but once you have AFib, you need to be aggressive dealing with it. Anticoagulation, CHA2DS2-VASc score does not work in this context. If you document AFib, you need to treat it with anticoagulation. And remember, once you go into AFib, the success rate for ablation, no matter what the surgeon or the electrophysiologist says, the reality is it is less than 50%. So the key here is try to prevent that. Genetic testing is important. However, it is important also to realize that if you take 100 patients that look like HCM, the gene positive rate is only 35 to 40%. So we still have a lot of work to do in this space. But this is something that should be offered to the patients. If you are positive, then your first degree relatives should be screened. If you're negative, you still need imaging screening, which is what this thing talks about. In children, you screen every 1 to 2 years. In adults, you screen every 3 to 5 years. So to conclude, ladies and gentlemen, I think the future is very bright in HCM, and precision medicine has become really a game changer in this. Gene therapy is coming down the pipe. It is definitely not about my pill is better than your catheter. It is going to be this plus minus that, because at the end of the day, we need to provide the best quality of life for your patient. Thank you so much.
Heart failure is a vast topic. I think I just covered overview of current management of heart failure with the recent advances in this management. Heart failure carries very high mortality and morbidity. More than 50% patients, they die within 5 years of heart failure. But with guideline-directed medical therapy, not only we can reduce mortality, but we can decrease recurrent hospitalizations and we can improve quality of life significantly. Now, heart failure, the new definition of heart failure is now, it's a universal definition of heart failure. It's a clinical syndrome with symptoms and signs caused by structural or functional cardiac abnormality, and it is supported by, corroborated by either there is elevated natriuretic peptide levels, either BNP levels or N-terminal pro-BNP levels, or there is objective evidence of pulmonary and systemic congestion is there. So a lot of focus on this definition is on symptoms and signs are very, very important for diagnosing and evaluation of heart failure. Even now the staging of heart failure, the symptomatology and signs are very important. We divide the heart failure in 4 stages, stage A, B, C and D. Stage A, basically it's a patient don't have heart failure, but they are at the risk of heart failure. Like patients have risk factors of heart failure like diabetes, hypertension, obesity, cardiovascular disease, family history of cardiomyopathy is there. Stage B is patient, they have structural heart disease. They may have structural heart disease, like patient may have ejection fraction may be less, they have left ventricular hypertrophy, or they may have valvular heart disease, or even natriuretic peptide levels may be raised. These are the patients, they have structural heart disease or functional abnormalities there, but there are no current or prior symptoms of the heart failure is there. So symptoms are very important. So this stage B we now label as a pre-heart failure. They have structural heart disease, they have functional abnormality, but they don't have the heart failure. The most important stage of heart failure, it is the stage C heart failure, where patients have either current or prior symptoms or signs of heart failure are there. So this is the most important stage of heart failure. The most of the guideline directed medical therapy is directed toward this stage C. Then the last stage of heart failure, stage D, is the advanced heart failures. These are the patients, despite guideline-directed medical therapy or even after device therapy, patient is symptomatic at rest, patient require recurrent hospitalizations. These are the patients who are candidates for palliative therapy or left ventricular assist devices or heart transplant is there. Now, stage C has been further divided into the trajectory of this further divided into various categories, like it can be a new onset heart failure, or it can be heart failure in remission, that the symptoms are improving, even structural heart disease is improving, or patient may have persistent heart failure, same symptoms are continuing for a long time, we call it persistent heart failure, or worsening heart failure is there, where in last 6 to 12 months patient require recurrent hospitalizations or patient require IV diuretics in the emergency department. And the most common way to classify heart failure is according to the left ventricular ejection fractions. There are 3 categories. Left ventricular ejection fraction less than 40%, we call heart failure with the reduced ejection fractions. Then left ventricular ejection fraction between 40 to 49%, we call with heart failure with mildly reduced ejection fraction. Earlier we used to call it mid-range heart failure, now we call it mildly reduced ejection fraction heart failures. Then we have heart failure with the preserved ejection fraction, where heart ejection fraction is normal, it is more than 50%. Almost now 50% of the patients of heart failure, they are heart failure with the preserved ejection fraction is there. And the new category now has been added to this heart failure, the heart failure with the improved ejection fractions, where ejection fraction earlier was 40%, but now it has improved to more than 40%. We call it heart failure with the improved ejection fractions. Now coming to how to diagnose what parameters we take for the diagnosis of heart failures. No doubt, sign and symptoms are very, very important for diagnosing of for heart failure, along with supportive evidence of basic lab investigation, ECG, echocardiography, chest X-ray, and biomarkers like BNP and N-terminal pro-BNP. If we look for the symptoms and signs of heart failure, they can be defined in 2 basic pathophysiology of the heart failure. Either there is an increased filling pressure is there, or there is a poor cardiac output is there. Increased filling pressure of the left ventricular, it leads to pulmonary congestions. Pulmonary congestion leads to the dyspnea, orthopnea, and proximal nocturnal dyspnea. Dyspnea is the most common symptom we see in the heart failure patients. Similarly, this left ventricular increased filling pressure, it leads to signs of S3, murmur of mitral regurgitation, pulmonary rales are there. Then similarly, the right-sided increased ventricular pressures, they lead to symptoms of the peripheral edema is there, abdominal blotting is there, nausea, vomiting, anorexia because of the hepatic congestion is there. Then we have signs of, this is the basic we learn in our medical schools and in our post-graduations. Elevated JVP is there, hepatomegaly, hepatojugular reflux, pitting edema is there. These are the basic you see signs because of the increased filling pressure. Then because of the decreased cardiac output, we see the patients have symptoms of fatigue is there, very important because of the increased blood supply to the muscles leads to fatigue, confusion, dyspnea, again because of the decreased blood supply to the respiratory muscles, we can signs of hypertension, tachycardia, these signs or cold extremities can be there. And these are the basic lab investigations we require in any patient with heart failure for the evaluations, complete blood count, renal function test, serum electrolytes, liver function test, thyroid profile, iron studies. Many patients, they have anemia also and iron deficiency also in these patients. Then lipid profile, fasting blood sugar. These are the basic investigations we require. The next step we should, the 12-lead ECG is very important in heart failure. More than 90% patients of heart failure, there's some or other abnormality in the ECG. We look for the heart rate, we look for the rhythm in these patients, whether it's atrial fibrillation or other rhythm disorders there. We look for the QRS duration also in the ECG, whether it's a wide QRS or it's a narrow QRS. And we also look for the morphology also, type of morphology, whether it's a left bundle branch block or the right bundle branch block is there. And after symptoms, signs, basic investigation, ECG, X-ray, the next step is to look for the natriuretic peptide levels. We can look for either BNP or N-terminal pro-BNP. Both can be used interchangeably, but the cutoff value are different for the both these natriuretic peptides. The N-terminal pro-BNP, the cutoff value is more than 125 picogram per ml, and for the BNP it is more than 35 picogram per ml. The negative predictive value of these natriuretic peptides are very high. Suppose in emergency patients come with the acute dyspnea and these levels are normal. This practically rule out that patients have heart failure. It may be because of some pulmonary cause or other causes. So negative predictive value is quite high, but not only for diagnosis, but for prognosis also, these biomarkers are important. Then comes the next most important investigation is the transthoracic echocardiography. Is the most important investigation for diagnosing heart failure, whether we know about the ejection fraction of the patients, any valvular heart disease, pericardial disease, regional wall motion abnormalities. We know about the pulmonary hypertension. So a lot of information we gain from the transthoracic echocardiography. Then we label patients as patients have heart failure, the reduced ejection fraction or preserved ejection fraction or the mildly reduced ejection fractions. The most common causes of heart failures are, you see, risk factors again are hypertension, obesity, diabetes, and cardiovascular disease. Ischemic heart disease and myocardial infarction are the most common cause of heart failure. These days, more than 50% patients, the etiology is either ischemic heart disease or myocardial infarction is there. And as more and more patients of myocardial infarctions, acute coronary syndrome, they are surviving because of revascularization, either angioplasty or bypass surgery. So we are finding more and more patients heart failure with the CAD. The other causes are hypertensive heart disease can be there. Just we discussed the hypertrophic cardiomyopathy. We can have discussed infiltrative cardio disease like amyloidosis can be there, peripartum cardiomyopathy, substance abuse, endocardial diseases, and autoimmune disease. There are a lot of other causes are there, anti-cancer drugs, but the most common cause is ischemic heart disease and myocardial infarctions. Now coming to how to manage these patients. So in stage A, lifestyle modifications are very important along with management of risk factors like hypertension, diabetes, and optimal management of cardiovascular disease. In diabetes, what we now prefer if patients have diabetes with cardiovascular disease or diabetes with high-risk features like target organ damage is there, we should prefer SGLT2 inhibitors as the first-line therapy in the management of these diabetic populations. Those still don't have heart failure. The risk of heart failure decreases in these patients if we start SGLT2 inhibitors earlier. Similarly, in stage B, where patient is asymptomatic, if ejection fraction is less than 40%, patient don't have any current or prior symptoms of heart failures, then ACE inhibitors and beta blockers can be used in these patients to reduce the incidence of future onset of heart failure and to decrease the mortality also in these patients. We can use in pre-heart failure also ACE inhibitors and beta blockers. Now coming to the most important slide of my presentation, the stage C heart failures, now we have 4 pillars of therapy now we have with us. The 4 pillars of therapies are, the first and most important pillar is either we use RAS blockers, that is ARNI, ACE inhibitors or angiotensin receptor blockers. So ARNI is now preferred over ACE inhibitors or ARBs after the paradigm HF trial. The second pillar is beta blocker, very important. Almost 30 to 40% reduction in total mortality we see with the beta blockers. The minocyte receptor antagonists like spironolactone, alprazolam, this is the third pillar for the management of heart failure. And the latest addition in this pillar of heart failure management is the SGLT2 inhibitors of DAPHF trial and Ampere reduced trial. This has shown to reduce mortality, recurrent hospitalization on top of the ARNI, beta blockers and MRAs. So all these 4 pillars of therapies are very important. We can reduce mortality significantly if we use all these 4 drugs in patients of heart failure with a reduced ejection fraction. I just show you this meta-analysis of 3 trials, that is DAPHF trial, Emphasis HF trial and the Paradigm HF trial. If we compare conventional therapy of heart failure with a reduced ejection fraction with ACE inhibitors and beta blockers, if we compare with these 4 pillars of therapy, we can increase the event-free life almost by 8 years in a 55-year-old male. So almost, you can see in a younger patient, we can increase more life. So we can add 8 years of life, event-free life in these patients if we add 4 pillars of therapy. Now coming to the how to start these medications. Should we start these medications simultaneously? What is the sequence of starting these medications is there. The conventional thinking is, what is the conventional thinking is, we start with the ACE inhibitors, then we go for the beta blockers, then we go for the minocyte receptor antagonist, then we replace ARNI, we replace ARBs with the ARNI, ACE inhibitors with the ARNI, then we add SGLT2 inhibitors. What the conventional school of thought is there, first we reach the target dose, then we add another drug. So it takes 6 months to start these
4 pillars of therapy. So what we have seen that the benefit of these medications, they start within 1 month of starting these medicines. So the new sequence that has been proposed for starting these 4 pillars of therapy, we can start with the beta blocker and SGLT inhibitors first, because both of these drugs, they don't lead to much hypertension or renal dysfunction in these patients. Then we can add ARNI in these patients, and the fourth step is we can add mineralocorticoid receptor antagonist, spironolactone or epinone in these patients. So with this sequencing, we can start all these 3 to 4 drugs almost within 3 to 4 weeks. And after that, we should try to reach the maximum tolerated dose, the target dose of these drugs. Suppose patient doesn't respond to this first 4 pillars, the first line of therapy, we can add ivabradine in those patients where heart rate remains more than 70 despite beta blockers and other drugs. And if patient has sinus rhythm, we can start with the ivabradine. Then the latest addition is this Vericiguat after the Victoria trial. This is soluble guanyl cyclase stimulators. They reduce recurrent hospitalizations, reduce mortality, the composite of hospitalization and mortality in the patients of worsening heart failure. Worsening heart failure where patients have recurrent hospitalization within past 6 to 12 months and requiring IV diuretics. The third second line therapy is the combination of isosorbide and dinitrate that we can use in our patients where patients have renal dysfunction, or despite first line therapy, patients still are symptomatic, patient had class 3 or class 4 symptoms are there. And still, although earlier the digoxin used to be the first line therapy, now it's a second line, and almost in the last we use digoxin. Suppose patient doesn't respond to this first line, other second line therapy, then we can add digoxin in these patients, especially patients who have atrial fibrillation with a fast ventricular rate. Suppose patients after first line and second line therapy still symptomatic, we can consider these patients for biventricular pacemakers, for cardiac resynchronization therapy. The best candidate for cardiac resynchronization therapy are the patients with left middle branch block and having QRS duration more than 150 milliseconds. This is the best candidate, but still patients who have LBB between 120 to 140 milliseconds or non-LBB more than 150 millisecond QRS duration, we can use biventricular pacemakers. So lastly, just a passing remarks of heart failure with mildly reduced ejection fraction. There are no standardized therapy till now for mildly reduced ejection fraction, but this year, as the results of last year only, the results of Emperor Reserve trial, they came out. Now SGL2 inhibitors are now the most preferred drug for heart failure with a mildly reduced ejection fraction. I just want to highlight one point. Those patients where ejection fraction improves from like 35 to more than 40% or 30% to more than 40%, that we call heart failure with an improved ejection fraction. In these patients, we should continue all the first 4 pillar of therapy, all the guideline-directed medical therapy. Those who have improved ejection fractions, but those have don't have improved ejection fraction, just mildly reduced ejection fraction, we should, with SGL2 inhibitors are the preferred drugs. Similarly, for heart failure with a preserved ejection fraction, there are not standardized therapies are there. After loop diuretics, we can use SGL2 inhibitors as a preferred drug. These 4 pillar therapies are now the first line of therapy, and for mildly reduced ejection fraction and preserved ejection fraction, we can use SGL2 inhibitors as a preferred drugs. Thank you very much for kind attention.
The topic of discussion is plant-based diet and intermittent fasting. I have no financial disclosure pertaining to this lecture. The objective is the current evidence and recommendations for non-pharmacological methods for cardiovascular risk reduction. The scope of the problem is heart disease, as we know, is common cause of mortality worldwide, including India. With increased urbanization and sedentary lifestyle and access to cheaper processed foods, with the resultant obesity partly responsible. And as you know, especially in the urban areas like Mumbai, Kerala, it is almost as higher as US or in other global countries. The scope of the problem gets higher. The higher the prevalence, higher the problem. The cardiovascular risk increases with body mass index. As demonstrated here, there's a higher risk of hemorrhagic CVA, ischemic stroke, and ischemic heart disease. And reducing the risk, reducing the weight of the patient definitely improves their risk of these cardiovascular events. The risk of diabetes also increases with body mass index. The higher the body mass index, especially over 40, as you see, there is a 60 to 70% risk of diabetes over lifetime. And this trial looked at 3 different types of diet. One is a low-fat diet, another is a low-fat diet added with a statin, and then the dietary portfolio, which is enriched in plant sterols, soy protein, and viscous fiber and almonds. Overall, when it compared to low-fat diet, both the low-fat and statin and the dietary portfolio improved significantly with respect to lipid parameters and CRP. When you compare it to the statin and low-fat diet, the dietary portfolio, which includes the plant products, it was markedly improved with respect to lipids and CRP. And the nurses' health study and the health professional follow-up study, which looked at over 130,000 patients over 14 years, also showed higher the fruit and vegetable intake on a daily basis, exponentially improved cardiovascular risk. So plant-based diets confers health benefits with reduced risk of cardiovascular disease, especially vegans and vegetarians compared to non-vegetarians have a lower body mass indices and favorable levels of blood pressure and LDL levels. And they also looked at the Pisco Mediterranean diet is a plant-rich diet with seafood as a predominant source of animal protein when you really want to add animal protein, shown to significant benefit with this extra virgin olive oil and the seafood. So intermittent fasting is recommended in conjunction with any part of diet. So the traditional Mediterranean diet has been recommended in the dietary guidelines and also primary prevention guidelines, which is basically plant-based and Mediterranean diets with fruits, nuts, vegetables, legumes, lean vegetables, and if you want animal protein, consider adding fish with 2 to 3 servings per week. The Indian national guidelines on nutrition also looked at a variety of foods, and they talk about plenty of vegetables and fruits, moderate use of edible oils, animal foods, and less use of ghee and vanaspati. And again, there is some controversy on this. And avoid overeating and prevent overeating and obesity, and exercise regularly, physically stay active and maintain ideal body weight, and restrict overall salt intake to the minimum and drink plenty of water and avoid beverages. But obviously, you have to understand when you do plant-based diet, that itself contains a lot of water content, so you have to pay attention to water. Minimize use of processed foods, which is rich in salt, sugar, and fats. The ACC-AHA guidelines do recommend class 1 to consider vegetables, fruits, legumes, nuts, and whole grains, and fish when you would need as an animal protein as a class 1 recommendation to reduce cardiovascular risk. Now come to intermittent fasting. It's a form of time-restricted eating, typically 18 hours fasting and 8 hours eating. It's gained popularity in the recent years and shows promise as a possible paradigm to approach weight loss, reduction in inflammation, and potential long-term health benefits. Cardiovascular disease remains a serious problem in the modern world. As you know, 17.9 million people die every year as per WHO data, and attributes to 1/3 of all the deaths. So when it comes to intermittent fasting, there was one major review article in New England Journal a few years ago that really impacted my personal approach in intermittent fasting and showing you significant benefits. So we'll go through a few things. This recommended is the 3 different types. Fasting, alternate day fasting, periodic fasting, and time-restricted feeding. These are the 3 most popular types of fasting which has been studied in trials. So what is alternate day fasting? It is alternate meaning 24 hours of fast day followed by 20 hours of non-fasting day. There are 2 types, complete and alternate day fasting. That means no calories in the fast day. Modified form is you can allow up to 25% of daily calorie intake. What is periodic fasting? Any type of consecutive fasting more than 24 hours. That is 5 days of eating, 2 days of fasting, or 4 days of eating and 3 days of fasting. And you allow up to 500 to 700 calories or 25% of daily calorie intake in the fasting days. The most popular one is the time-restricted feeding, where eating only a certain number of hours in a day. There are 3 types, 16-8, 18-6, 24. That means 16 hours of fasting, 8 hours of feeding. So it is on a regular basis when you do intermittent fasting is shown to decrease intra-abdominal adipose tissue, reduce free radical production, elicit cellular response that improve glucose metabolism, reduces inflammation, and reduce the risk of diabetes, cardiovascular disease, cancer, and neurodegenerative diseases. So fasting, as you know, is an ancient tradition practiced in many cultures and religions over generations. One of the common ones are called Vrata or the Lent, Ramadan from Muslims, Yom Kippur in Jewish community, and Fast Sunday. And therapeutic effects of treatment of obesity investigated in early as 1915, and more interest came in the 1960s. The intermittent fasting of 5:2 diet was popularized in UK and Australia. So what are the common benefits seen in here? It forces body to burn more fat, increases energy and metabolism, naturally increases human growth hormone, eliminates your hunger and cravings for food, and improves cognitive function and memory retention, and decreases chances of cancer, diabetes, cardiovascular disease, and inflammation. And also there is associated increased lifespan, maybe protection, Alzheimer's and Parkinson's disease. So intermittent metabolic switching is the concept here, with reduction of calorie intake and weight loss. So the intermittent switching means you, from the use of glucose after the meals, the use of fatty acids and ketone bodies during the fasting phase. So basically it's a keto diet. Instead of eating food, your ketones are produced, which is beneficial to the cells and organs. So this chart is busy, but basically it talks about what happens in the periods of fasting. There is systemic and cellular adaptation of bioenergetic challenge, increased ketones, increased mitochondrial stress resistance, increased antioxidant defenses, increased autophagia, increased DNA repair. So cells do repair during fasting phase, decreased insulin and protein synthesis. And when you do the eating phase, obviously everything changes. There is increased glucose, increased insulin, increased protein synthesis, decreased ketones, which can cause remodeling. So over the long term, there is increased insulin sensitivity and heart rate variability, improved lipid metabolism, healthy gut, and reduced abdominal fat, and inflammation and blood pressure. Overall, there is a decreased resistance. So it minimizes anabolic processes, favor metabolism and repair synthesis, and resistance of the stress. Damaged molecules get recycled. They stimulate mitochondrial biogenesis. Overall improvements in health and disease resistance. So energy restriction over the 10 to 14 hours results in depletion of liver glycogen stores and hydrolysis of triglycerides and free fatty acids and adiposities. And free fatty acids released into circulation and transported into hepatocytes produces the ketones, and that is the way it helps the patient. So impact of intermittent fasting on obesity and glycemic profile improves weight loss, reversed insulin resistance in patients with pre-diabetes and type 2 diabetes. I've seen significant improved hemoglobin A1C when the people do intermittent fasting. So it also improves lipid profile but decreases in triglycerides, LDL, and overall total cholesterol. It also impacts in inflammatory markers, decrease in IL-6, leptin, and CRP, decrease atherosclerosis. And also impacts in improvement in the systolic and diastolic blood pressure, and activates parasympathetic nervous system. So overall, intermittent fasting reduces markers of systemic inflammation and oxidative stress that are associated with atherosclerosis, improves multiple indicators by including blood pressure, resting heart rate, levels of HDL, LDL, triglycerides, insulin, and glucose level, and improves heart rate variability also. In calorie study, there is a 12% reduction in calorie intake for 2 years, improved cardiovascular risk. And also, intermittent fasting was shown to improve weight loss in both normal and overweight adults. So overall, improvements were seen as early as 2 to 4 weeks and dissipates after the patient goes back to normal diet. There is also shown to benefit in other disease states like tumor suppression seen in patients with the glioblastoma and survival extension of a patient. In animal studies, that showed tumor regression and also improved sensitivity to chemotherapy and radiation therapy, and also improves symptoms in patients with asthma, multiple sclerosis, and arthritis. There is some new evidence showing that athletic performance may improve, decrease mortality and morbidity in patients with traumatic brain injury and spinal cord injury patients, and clinical evidence shows can delay the onset and progression of Alzheimer's and Parkinson's disease. So what are some of the limitations? It's not for everybody. Fasting may be dangerous and not recommended for people with hormonal imbalance, pregnant and breastfeeding, growing children, adolescents. Not recommended patients with eating disorders like patients who are low body mass index, underweight, and diabetics. There is a risk of hypoglycemia. And also clinical studies have involved only short-term interventions over a period of months, and we don't know what happens when you follow this for years. And clinical studies are focused on overweight, young and middle-aged adults, but we cannot generalize to elderly people. And beneficial effects of fasting involve metabolic switching and cellular stress resistance. Again, the next slide actually basically was incorporate intermittent fasting in education and healthcare practices, like start at the medical school level, try to give them the prescription for students to educate them, and so that they can give it to the community, educate the healthcare providers and the practitioners about of intermittent fasting, and give them a diet protocol about plant-based diet, exercise regimen, and programs. So, take-home points: Southeast Asian descent is an additional non-modifiable risk, as we know in cardiovascular disease. Healthy dietary choices are the single most important modifiable risk for reducing cardiovascular disease. And animal models have shown that intermittent fasting improves health throughout lifespan, but in our studies in humans have shown up to few months and few years only. Preclinical and clinical trials have broad spectrum benefits for both obesity, diabetes, cardiovascular disease, cancers, and neurological disorders. So, pesco-Mediterranean diet is recommended as if you really want to eat an animal protein with fish, vegetarian, abundant legumes and nuts, and obviously fruits. Intermittent fasting, the time-restricted feeding is the most popular one. As the slide shows you, the 16 hours of fasting and 8 hours of feeding is the best, probably the most commonly performed approach. Thank you for your attention.
All right, thank you for the very kind introduction and for the invitation. So in the next 15 minutes, I'm going to share with you how we use vericiguat, a new drug, in the treatment of worsening heart failure. This new molecule has now been, I understand, introduced in India just recently, only in September. So I'm using 3 different case scenarios to illustrate how we make use of this new molecule in the treatment of heart failure, reduced ejection fraction, and the recent worsening event. First, we are going to look at a patient refractory to GDMT, followed by patient at risk of hypotension, and lastly, patient renal impairment. First scenario, those patients that despite using the 4 pillars for HFrEF, they are still having acute symptom, they're still coming for worsening episode. So we know that worsening heart failure is a very critical point in the journey of a heart failure patient. It is not something benign. Worsening heart failure, I take it as a red flag, as a precursor to development of advanced heart failure. So once we allow the patient to advance to very end stage heart failure, we know at that stage, short of a heart transplant or left ventricular assist device, most patients are staring at palliative care. And we do know that heart transplant and left ventricular assist device, even though it is now also available in India, but most patients will not be able to afford to have a heart transplant or a left ventricular assist device. And even with the current therapy that we have, the 4 pillars for HFrEF, we know that in the recent DAPA-HF trial, where they're well treated with the RAS inhibitor, the MRA, and the beta blocker, and we add the dapagliflozin to it, there is still 14.3% of patients on the 4 therapy, they still had a primary event. These are events of worsening heart failure and cardiovascular death over the course of the trial. And this is in the trial setting. So imagine the real world setting when the patients are not so compliant. It make it, probably the figure is going to be worse. So if we are today looking at only a 1 to 2% event rate with a 4 agent, yeah, fair enough. I say we can stop, doing R&D in heart failure. We don't need to be so aggressive heart failure. But despite the 4 agent, we are still having a very high event rate among heart failure patients. So where does vericiguat come in? Whether it's a European guideline or the North American guideline, you can see that vericiguat now has been incorporated into guideline, heart failure guideline, in patients with reduced ejection fraction who are symptomatic and has a recent worsening heart failure event. And the evidence for incorporating the molecule into the guideline came from a Victoria trial, which was not your typical heart failure trial. The typical heart failure trial looking at ARNI and SGLT2, they were concentrating on chronic heart failure patients with symptoms with ejection fraction of less than 40%. But in the Victoria trial, they need to have a worsening heart failure event. All the patient that's recruited cannot be just the stable chronic heart failure patient. So what is the definition of worsening heart failure in the Victoria trial? It is either they have a readmission to the hospital for heart failure within 6 months, or for some patients, they need intravenous diuretic in an outpatient setting within 3 months. So these are definitely a much sicker group of patients. And in the clinical trial, you can see that they were randomized in a 1-to-1 fashion on top of standard of care to either receive vericiguat up titrated from 2.5 milligram within 2 weeks to 5 and eventually to 10 milligram all within 1 month versus placebo. The drug was well tolerated. 90% of the patients in the trial were able to tolerate the highest dose of 10 milligram. And do take note as well in the inclusion criteria, the eGFR cutoff was 15 mils per minute. No other trial, heart failure trials, come down all the way to eGFR 15 mils per minute. The closest one that I can think of is the Emperor trial, the Emperor Reduce and the Emperor Preserve, where the eGFR cutoff was 20. For the DAPA HF, it was 30. For the Predam HF, looking at ARNI, it was 30 as well. And this is important because a lot of our patients with heart failure and concomitant, severe renal impairment, they do have very limited option, and there's not much evidence and data out there for this group of patients. So the primary endpoint of the trial, which was the time to cardiovascular death or first heart failure hospitalization, you can see that there was a 10% relative risk reduction. In terms of the absolute risk reduction, it was 4.2 events per 100 patient year, and the annual number to treat was actually 24, quite comparable with other recent heart failure trials, despite the fact that the relative risk reduction was only 10%. That's because in this trial, these are very sick patients with a recent worsening event. Their event rate was very high in this trial. And let me first share with you a case study. Somebody who failed GDMT. So this is an Asian patient that we saw in Singapore, a 56 years old. Last year in March, he had multiple admissions to a hospital, literally coming in almost every 1 to 2 monthly he's coming in. So I first saw him in March last year, where after admission for 24 to 48 hours, where he was successfully diuresed with intravenous diuretic and he's euvolemic. So just before discharge, I was asked to review this patient. And you can see that he was class 3, poor ejection fraction 17%, looking at the elevated NT-proBNP of more than 3,000 despite IV, despite the cost of intravenous diuretics. In terms of GDMT, there's nothing else we can optimize for this gentleman. Already on maximal dose of ARNI, already on target dose of bisoprolol of 10 milligram, already on MRA, and also SGLT2 inhibitor was also already started. So it's already on the 4 pillars. On top of that, he already had a CRTD put in previously for left bundle branch block as well. So my first question to the audience, if you can poll, is would you continue the same treatment, or will you add a digoxin for this patient, or will anyone here consider the use of vericiguat, or you think this patient is too advanced, too sick, let's just offer him a heart transplant of a left ventricular assist device? So I think majority of you chose to add the vericiguat. Let me just go on. So that's what we did, because you know that for a heart transplant or left ventricular assist device, it is still a very major operation, costs us a lot, and that's what we told the patient, let's try vericiguat. If it doesn't work, then we do consider heart transplant or left ventricular assist device. So the drug was started inpatient just pre-discharge. 2 weeks later, we got our heart failure pharmacist to call him up. He took his own blood pressure at home, it was stable, and he up titrated 5 milligram. And subsequent, another 2 weeks later, he got a call from a heart failure pharmacist again. No symptom again, blood pressure is still stable, and went up to a maximum dose of 10 milligram. And within 1 month, he's improved to class 2. There's a drop in the NT-proBNP from more than 3,000 to less than 2,000. And the only change that we did was the use of vericiguat, all right? So, and he's still currently doing very well 1 year on, no readmission since then. So that was patient number 1, that we do a lot in Singapore, the use of vericiguat in those patients who have failed GMT. So second scenario that we do a lot in Singapore is those patients who has risk for hypotension, a very problematic group for those patients with heart failure. This group of patients with hypotension, they are high risk of future cardiac event, but yet at the same time, the option we have for them is actually quite limited. among the 4 pillars, besides SGLT2 inhibitor, the rest of the agent does cause a bit of hypotension. So in the Victoria trial, there was minimal impact on the blood pressure. At the end of the study, as you see here, the blood pressure difference between the placebo group and the group on vericiguat was almost identical. And this was achieved regardless of the age of the patient. Even in vulnerable groups such as those above 75 years old or with a starting blood pressure of less than 110, or those patients taking concomitant ARNI, you can see that the impact on the blood pressure was not that significant. So second case study that we had here, we have a 72-year-old Indian gentleman, which we see quite a fair bit Indian heart failure patients in Singapore as well. Again, admitted last year for decompensated heart failure. Like the first patient, this patient was quite sick. He was class 3, very high NT-proBNP of more than 7,000. But what is problematic in this patient is he has a very borderline blood pressure, usually about high 90s to the maximum 100. As you can see here, he was already on ARNI, he was already on the SGLT2 inhibitor, dapagliflozin, and also on 50% target dose of bisoprolol. We did try previously in the previous admission to increase the beta blocker, but when we tried to do that, he got postural hypotension symptom, so we couldn't do that. MRA was not added because every time we try that, he get hyperkalemia as well. So very limited choice we have to optimize this patient. So again, based on the Victoria trial, we were quite, we felt quite reassured to start him on a small dose of vericiguat, and that's what we did. Started with 2.5 milligram, we will up titrate 2 weeks later with 5 milligram. We did try to go up 10 milligram, but he did have a little bit of postural hypotension symptom with 10 milligram. That's why we back off to 5 milligram. And at 5 milligram, he was doing very well. There was an improvement in the class status. There's a drop in the NT-proBNP. Yes, there was a slight drop in the blood pressure from about 100 to about 97, 98. But this drop was not clinically significant. He had no symptom of postural hypotension or syncope with it. And again, just by adding this molecule, this patient is fairly doing quite well now. There's no further readmission since April last year. The last case scenario that we do a lot for our patients in Singapore is that of patient with renal impairment. Again, just like those patients with hypotension, patient with renal impairment, in combination with heart failure, this group of patients tend to do worse. They have a higher risk of mortality, higher risk of readmission. And again, certain medication that we use for heart failure, such as the MRA and the ARNI or the ACE inhibitor, can be a bit problematic in some of these patients with very advanced renal impairment. In Victoria trial, fortunately, we do have some evidence for the use of this agent in those patients with severe renal impairment. 10% of the patients that's recruited in the Victoria trial had an eGFR of less than 30 mL per minute. In fact, the lowest eGFR that we can go down to in the trial that we can recruit was up to 15 mL per minute. And the result from the trial showed that at the end of the study, there was no difference in the eGFR or the creatinine with the use of vericiguat when compared to placebo. You can see here it's almost identical. Importantly, there was also no clinically relevant impact on the sodium or the potassium level over the course of the study. You can see that sodium level and potassium level was almost identical as well. And this is very important, especially for potassium. Some of the heart failure medications, like the RAS inhibitor, may have an impact on the potassium level, causing hyperkalemia and may prevent the up titration or the usage of such therapy in heart failure patients. So my last case study is this 71-year-old Asian lady who also had HFrEF. Again, came in last year for heart failure that's decompensated. She was recompensated with intravenous diuretic, and I saw her first time in the inpatient. Her main problem, unlike the previous 2 patients, is she had an eGFR of only 19. So we were very limited what we can give her. MRA couldn't be started. She was previously already on empagliflozin 10 milligram, so we continued that. The ARNI dose was very low, but because of the low eGFR, we were really very reluctant to increase the risk, the dose of ARNI. So my second question to everybody is, would you continue the same treatment for her? Anyone here will stop MPA? Anyone here will reduce or stop the ANI? Or would you consider Versigua? Or lastly, will you add hydrazine nitrate? Alright, so some may stop empagliflozin and some you may actually add Versigua. So what we did was, we did not start empagliflozin. I think it's still important to continue empagliflozin. Quite comfortable even if the EGFR dropped below 20 with the use of empagliflozin. But what we did for this lady was, we started her on Versigua during inpatient and continued to up titrate in the outpatient setting. And within a month, we were able to get her up to the maximum dose of 10 milligram again. As you can see here, with the introduction of Versigua, there was an improvement in functional class, there was a drop in anti-BNP, and there was no impact on the EGFR. Started at 19 and still remained 19, just like what we saw from the Victoria trial. So to sum up, key takeaway, despite DDMT, risk of heart failure hospitalization and cardiac death still remains very high. Hospitalization for heart failure or worsening heart failure is associated with a higher risk of subsequent readmission, increased mortality, and obviously increased cost for the patient and for the hospital as well. The Victoria trial has shown us that Versigua as a new agent can be used to reduce the event rate for patients, and is very safe to use in patients with hypotension and also patients with severe renal impairment. Thank you for your attention.
Thank you very much, gentlemen. Chairman, ladies and gentlemen, great pleasure to be here in Ahmedabad. And I'll be talking about the management of heart failure following on from David Sims' presentation, where he presented still the ongoing burden of disability in heart failure. But I think we also need to make sure that we are utilising all the equipment we have for improving patients, that survey after survey have shown that often we fall short. Here are my declarations at the bottom there. So first of all, there have been many advances in heart failure, and these are all positive trials that have reduced mortality and morbidity in heart failure, but largely in heart failure with reduced ejection fraction. So it is the area of medicine where we have the most separately proven treatments that have hit this big milestone of all parts of medicine. But heart failure is not a single condition, and we recently published a universal definition of heart failure that really just cemented what the world was coming to, is the idea that heart failure really has three separate syndromes based around a very simple measure, ejection fraction. 3 or possibly 4. At one end we have the type that's been so well studied and treated, that's heart failure with reduced ejection fractions, with ejection fractions up to or equal to 40%. On the right we have preserved ejection, that's 50% and above. There is a little group in the middle of mildly reduced that are probably more like HFrEF than they are HFpEF. But importantly, there's another interesting group, heart failure with improved ejection fraction, where a patient had HFrEF, but because of treatment they've now improved. The limited evidence we have for that group is that we do need to maintain long-term treatment unless they've got some rare conditions that are reversible. But the real problem we have is that we have failed in the half of heart failure with preserved ejection fraction. There is a lower mortality in HFpEF, but the difference is relatively small. It's somewhat covered by the fact that these patients tend to be older with more comorbidities, so the mortality may be similar, but there's more non-cardiovascular mortality in HFpEF compared to HFrEF. But these patients are very symptomatic, and if you look at limitations on daily activities and quality of life, HFpEF patients are actually more limited than HFrEF patients. So there is still a huge unmet need for managing these patients. And until very recently, we really haven't had effective therapies. Here we look at treatments, and you look down the left-hand, ACE inhibitors, ARBs, beta blockers, SGLT2 inhibitors, MRAs, ARNI, others, vericiguats there, that have been studied and proven in HFrEF. But look on the right, and until very recently we had nothing. There were a couple of trials that were on the borderline. I'll go through the Paragon trial of ARNI and TopCat for spironolactone. There was one trial that I ran with Philip Poole Wilson called Seniors that straddled both groups, but it wasn't powered to look at the HFpEF separately. But the good news is we have had further improvements. If we look now, and I had the honour to serve on 2 most recent European guidelines, and there were big changes between 2016 and 2021, largely driven by that the pace of new innovation was accelerating. We did go through a period of about 10 to 15 years following the heady days of ACE inhibitors, beta blockers, MRAs, where we really didn't get as many advances. Then with the onset of sacubitril, valsartan, ARNI, and more recently the SGLT2 inhibitors, and then new experimental treatments that are coming into practice like vericiguat, omecamtiv mecarbil, as well as devices, we're in another very exciting period in the evaluation of heart failure. So we consider what changed from 2016 to 2021. That's largely we have highlighted the need to move quickly. On the left is the central algorithm from the 2016 guidelines, and are put in traffic lights because on this algorithm, which was a linear algorithm, it suggested you should start drugs one at a time and up-titrate and then review. The result of that, if there's any delay in treatment or difficulty seeing patients or reluctance to up-titrate, you actually don't get down. So that even the 3rd or 4th line drug gets very little uptake. On the right, the most recent guidelines, the foundational 4 treatments are put up at the top. There is no preference to which order to start. Instead of being a route map of how you commence these agents, it tells you the destination. You need to get all 4 drug classes on board in as many of your patients with HFrEF as possible. And you should take into account individual patient profiling and your knowledge of the patient, their physiology, their parameters, in a personalised approach to accelerate it in the safest way you can do that. So what's the evidence? Why the change? Well, first of all, the big change, the first for about 15 years, was the introduction of sacubitril valsartan in the Paradigm trial. It was the largest HFrEF trial there'd been to date, and it was the first that instead of evaluating a new treatment was added against placebo, it actually took the standard of care, which was the ACE inhibitor enalapril, and tried a new drug against the established treatment. Despite having a higher hurdle to overcome, because it had to be superior to standard of care, not just up against placebo, but against the active treatment, it was therefore surprising there was a 20% reduction in the now fairly regular composite endpoint of cardiovascular mortality and heart failure hospitalization, over and above that of enalapril. We've truncated the significance. It was actually p less than 0.00001, so it was highly significant and clinically very important, and that has led to a revolution. But still the uptake of ARNI has been too slow in most countries. But we had further information that came out from that initial study, first of all, about when we can start. In a smaller trial, a Pioneer study, which looked at biomarkers, particularly change in N-terminal proBNP, it showed that when you initiated sacubitril valsartan compared to enalapril in a patient recently hospitalized for decompensated heart failure, rather like the patients in Victoria, you see a greater reduction in N-terminal proBNP with the use of sacubitril valsartan. And although this trial wasn't large enough to be an outcome trial, there was actually a significant benefit seen on the cumulative probability of CV death or heart failure hospitalization as early as 8 weeks, and then the open label continuation where everyone got sacubitril valsartan, that improvement in survival was maintained. So there was, and it wasn't, we can't say it's definitive proof because it wasn't powered to look at this endpoint, but it was very heartening that that same composite endpoint was significantly superior with sacubitril valsartan when the drug was initiated during a hospital admission for acute decompensated heart failure. There was an interesting sub-analysis that some of these patients had a first ever episode of heart failure on the left compared to those with known chronic heart failure and episode of deterioration, and you see that both groups showed that same benefit. So this also showed that sacubitril valsartan could be started during a hospital admission for a patient that's never been on heart failure medication before. And that's a very important point because the guidelines up until very recently had been hesitant to recommend that because the paradigm study had been a replacement of long-term ACE or ARB with sacubitril. This is showing that ab initio initiation is also superior than starting with an ACE inhibitor, which has the advantage, of course, of also accelerating the ascertainment of ultimate destination treatment. Then we see the continued benefit there, primary recurrent endpoint analysis showing that we still got even greater benefit. And now we're looking at the Paragon trial now. This is the trial of HFpEF, so ejection fractions above 40%. And what you saw there, it's not technically a positive trial. The p-value 0.06, and we all know the p.05 is the classical sign of a positive trial. But we are realizing that an obsession with a p-value is not appropriate, and even the statisticians in the FDA are now recommending we look at the totality of evidence. So when you do that, and you look at the two components of the primary endpoint for Paragon, which of course was sacubitril/valsartan, this time compared to valsartan in HFpEF, we do see that same borderline reduction in heart failure hospitalization, but a neutral effect on cardiovascular mortality. But when we talk about consistency or cumulative evidence, when you look at the primary analysis by different statistical techniques, if you take the investigator-reported events themselves, not done by the case review committee, when you do different statistical tests, in about half of them it becomes significant. So it really was at the borderline of being a positive trial. Furthermore, when you look at other endpoints, such as improvements in the NYHA class, that was significantly improved. When you look at quality of life assessed by the Kansas City Cardiomyopathy Questionnaire, you see that the responder analysis showed a significant improvement. When you look at protection from renal deterioration, we get a positive outcome, but we don't for mortality. So I think most experts would now conclude sacubitril/valsartan is effective, as we see the FDA came to that conclusion, over a range of ejection fractions, including HFpEF, but noting that there is an effect of greater benefit with slightly lower ejection fraction. This is shown here by an over-analysis of Paradigm and Paragon put together, and you see there when you combine the two, the line is below 1, which means a beneficial effect, significant for most of the ejection fraction range. You see there right up to ejection fractions of 60 or 65%. There is a gender difference, and women seem to benefit to even higher ejection fractions than men, but we get consistent benefits there across there for other composite endpoints. We could also do a putative placebo analysis because these trials were against an active agent. If they were up against placebo, you see you get even greater effects for a number of different endpoints, right up to ejection fractions of 65, 70%. Of course, another new exciting field was the development of the SGLT2 inhibitors. You've heard so much about. Two landmark trials, DAPA-HF and EMPEROR-Reduced, showed benefits in HFrEF. You see there, comparing the two, they both showed a 25% reduction in the composite endpoint, CV death or heart failure hospitalization, both a 30% reduction in heart failure hospitalization. Only the DAPA-HF, dapagliflozin, showed a reduction in mortality in these two trials. Adverse events were really very encouraging. There were fewer serious adverse events on the SGLT2 inhibitors, very little difference between the two agents. The only one that's clinically common are genital infections, which can be managed with patient education and topical treatment. But SGLT2 inhibitors are more than just heart failure drugs. They affect the kidney, they affect metabolism, they have a number of benefits. And in particular, this study, DAPA-CKD, showed a reduction in the composite of CV mortality and end-stage renal events when given to renal patients without heart failure. So for the first time, we have a heart failure drug that's actually actively also a kidney drug, which is beneficial. We have this analysis now of two trials, recent trials in HFpEF, DELIVER and Emperor Preserve. Very similar results you see there, the same composite primary outcome, 20% reduction, very similar trend to an improvement in cardiovascular death, a big effect on heart failure hospitalization. And on the overview, when stratified by ejection fraction, you see very little difference. The liver, the dapagliflozin, slightly better at higher ejection fractions, but overall these two drugs are very effective. So that the most recent American guidelines now recommend SGLT2 inhibitors as a class 2A recommendation in HFpEF, and that was, of course, before DELIVER. We now honestly believe that this will be a class 1 recommendation. So in conclusion, there have been major changes to drug therapies with many options, 4 of which have been shown at the highest level of evidence. But the guidelines are not the end of the story. We actually have to make it happen. The drug that works is the drug that's taken by a patient. Speed and ease of use of recommendations are critical, and particularly we need to concentrate on the 2 more recent treatments, sacubitril, valsartan and SGLT2 inhibitors, to make sure we are using it in the vast majority of our patients. We cannot take years to get these drugs implemented. Patient profiling and awareness of comorbidities can offer you solutions to bring the art of medicine back to your practice. Look at the patient, say, you will need these 4 drug classes. I will work with you to make sure I protect you as quickly as possible. And we need to work with the whole of the heart team, including other disciplines, patients and their carers, to achieve that. This is new technology. This is how many years it took to get 50 million users of airlines, ATM machines, Twitter, 2 years. It took Pokemon Go just 19 days. Let's make guidelines as quick as Pokemon Go. Thank you.
So this is a 61-year-old gentleman, hypertensive, with a significant angina. And as you see, this is a totally occluded right coronary artery. It's faintly collateralized from the left system. When we do these cases, we use both arms. From the left arm, we inject to see the collaterals to the right. If it's a left occlusion, we use the left arm to inject, the right to see the left. We usually use the right arm for the primary intervention of that artery. And we went with specialized catheters. We have been able to cross the wire. It's a chronic occlusion. And then the balloon did not expand. Can you see this? The balloon is not expanding. It's like a dumbbell shaped. We tried different balloons. Balloons broke. The artery opened up very nicely, but there's a very critical lesion. So we went ahead and used rotablator. It's a very old technology, almost 30 years old. We have been using it at CIMS Hospital from day 1, and in India also for last 20 years. It's a high rotational atherectomy at 175,000 revolution per minute, diamond coated burr. Despite that, the balloon did not open. So then eventually we decided to go with the new technology. So why did this artery not open? Very simply, very calcified. So when you have a calcified lesion, you have a risk of balloon bursting, you have a risk of stent not being delivered, and even if you deliver the stent doesn't expand. So it's an area, calcified arteries in percutaneous intervention, which has always been a problem. And the coronary calcium also increases mortality and endpoint, especially if you don't do adequate dilatation. So new technology, which Dr. Vipul Kapoor also explained yesterday in the afternoon session, is lithotripsy for cardiac application. Now I'll ask you, how many of you are aware of lithotripsy for kidneys? Raise your hands. And how many of you are aware of lithotripsy for heart? Good, because I did ask that question last year and there were only 3 hands raised. So it's now getting, but I did say 50% not raising. So lithotripsy, a very simple technology of sound waves, has entered the coronary arteries using a shockwave coronary IVL system. Again, a very simple system which delivers the shock waves through a catheter. And the mechanism of action, which you saw yesterday, I show it again
3 kilovolts
to revise.
Of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. When the waves impact the calcium at nearly 50 atmospheres, the vessel becomes more compliant.
So we decided to use a special, it's called the mother-child catheter. It's also called as deep implanting catheters. These are various companies making the specialized catheters, which is a catheter within a catheter. And using that, we were able to transfer or advance the IVL balloon and use the IVL technology. And the artery did open up. I'm also proud to tell you we did the first 3 radial approach IVL cases in India exactly 2 years ago at the beginning of COVID. And subsequently in Western India, in Gujarat, our group, collectively all of us, have done the highest IVL cases. So as you see here, this is a very calcified artery. We were able to open up very nicely. And the stent apposition took place. So to come to conclusion, take home message, conventional tools in calcium, the balloon has problems. You need to use high pressure balloons. Balloons may still not be able to open the arteries. Atherectomy, like we used here, still has problems. You need dedicated wire. Sometimes there is thrombosis, distal embolization, and potential to cut the wire or create dissection. So intravascular lithotripsy is here to stay. We are using it almost on a weekly basis at our hospital. Again, when you refer your cases for intervention, like I mentioned yesterday and Dr. Satya Gupta also mentioned, make sure that facility does have IVUS, OCT, FFR, and expertise to use both rotational atherectomy as well as capacity as well as ability to use intravascular lithotripsy. So I end my case here, short and sweet. Thank you very much, everybody. Thanks.
So my case is slightly different, unique. 79-year-old male, very elderly, very fragile, sick patient. He was diabetic, hypertensive, having dyslipidemia. In 2008, I had done his PTC of mid-LAD with drug-eluting stent, and he was asymptomatic since then. He was regularly following, but because of COVID, he could not come for 2 years in 1920 and 21. So he was at some faraway place. In September 2021, he presented with ACS. Actually, he did not follow even local physician also because he was elderly. COVID was very, prevalent, and he was scared to even go out of his home. So he presented with ACS, acute left ventricular failure, pulmonary edema, low output state, almost cardiogenic shock-like situation that led to acute kidney injury also. Creatine went to 1.8, EGFR was 38 at that time, and significantly raised troponin and NT-proBNP was noticed by treating physician because he had to be ultimately hospitalized. And he noticed that there is severely calcific aortic stenosis with low flow, low gradient aortic stenosis. There is severe MR, severe pulmonary hypertension. His predicted RV systolic pressure was 75, a systolic BP of around 80. So almost systemic PA pressure. And he was in pulmonary edema. Ejection fraction was 25%. So he stabilized with IV diuretic, dobutamine, little bit of NORAD touch even. And ultimately he improved over next 3-4 days, and he was transferred here where we stabilized and we did his coronary angiography because he had come with SCS. Aortic stenosis was also there, but presentation was acute coronary syndrome, and that led to LVF. Aortic stenosis aggravated all the issues, and his troponin was clearly very high. NT-proBNP can be high because of LV dysfunction, but troponin was very high, suggesting that there is coronary issue. So as expected, he had critical 90% stenosis in circumflex, so even there was papillary muscle ischemia causing severe MR apart from aortic stenosis itself and overall coronary ischemia. So 90% lesion in left circ and even 80-90% lesion in LAD also. So our old stent was in the mid LAD, so that was patterned, but new lesion was there. So both stents were, both arteries were fixed with angioplasty in the same sitting, and 2 drug-eluting stents were put. Patient actually stabilized very rapidly. Creatinine reduced from 1.8 to 1.3. Echo revealed that severe MR reduced to grade 2 now. RV systolic pressure, that is PA pressure, reduced from 75 to 55. Ejection fraction 25 to 45, so it improved immediately. And this aortic gradient, there was low flow, low gradient. Now EF has improved, so there is more forward stroke volume and cardiac output, so gradient increase as expected from 40 to 60. And he was discharged after 4 days with advice to come for transcatheter aortic wall implant after 6 weeks. He was too high risk a case for aortic wall replacement surgically. And I explained pros and cons of surgical versus transcatheter aortic wall implant, and he agreed for non-surgical methodology because the risk was very high. So clinically after 6 weeks, he comes after 6 weeks, still further workup for aortic wall implant is pending. So he is clinically better now. No angina, no orthopnea. He is now in class 2. He is moving in the home. Creatinine is now 1. So it came back to normal, normalized. eGFR, which was 38, has come to 77 now. So it was good for us. Ejection fraction improved, almost normalized, 55%. No RWMN now. Mild MR only. RVSP, which was initially systemic pressure, is now 55. Aortic gradient has increased as expected, 82 by 52. Aortic wall area 0.5. STS score, that is a scoring system for surgical risk, which was 8. Anything is 8 and above is a very high risk surgical risk. So ultimately, in high surgical risk patient, TAVI, transcatheter aortic wall implant, is always preferable to surgery. So CT aortogram is the basic thing by which we decide whether he is capable, he is suitable candidate for TAVI or no. So just before doing CT angio and other findings, just to explain that there are 2 types of transcatheter heart valve available in India and all over the world. One is balloon expandable, which is Sapien, and my valve, which is manufactured in India, in Vapi. Most of the time, because of cost issue, we use this. Both are almost identical. Sapien is a US FDA approved valve, and another is self-expanding Metronic valve, Evolute R, that is this one. This valve is mounted on the balloon, so you go from femoral artery, cross the aortic valve, initially predilate the calcified aortic valve, and then balloon mounted valve is there. You inflate balloon, and that valve, which has a metal frame, it just stays there and calcium holds it. There is always 5 to 10% over expansion, so valve does not get embolized with the heartbeat, and this bioprosthetic valve stays there. In self-expanding valve is actually in the catheter, and as the catheter has sheath, and as you unsheath the valve gets expanded or valve opens up and it stays like this. So again, calcium holds the valve, and again it is also a biological valve, and it is a supraannular valve. So it gives slightly better area than balloon expandable valve, and that has now trials have shown that it is more durable also. So CT aortogram is the first step before you can plant TAVI, and you have to check right from entire aorta, including neck vessels and the descending aorta, and even femoral artery, because entry is through femoral artery. That catheter itself is almost 14 French to 16 French, so artery has to be around at least 5 to 5.5 millimeter femoral artery. So our patient had adequate femoral artery. You can see that this is a cross section 3D CT of the valve. Valve is actually bicuspid. This raphe or commissure is totally fused. So commissure between right and left coronary cusp is fused. So it's a bicuspid aortic valve with this wide thing is all calcium. We have some measurements. These are all technical things. Aortic annulus was 21. So ultimately, according to the chart, he was fitting for the 26 millimeter self-expanding evolute R valve. So we prepared that, and this is the actual angiogram. We had already put stents, so stents were patent, which was done 6 weeks back. So this is a basic aortogram. This technically it was a very difficult case, elderly man, highly calcified valve, and this is what we call horizontal aorta. If you see, this is very horizontal aorta. So technically it becomes very difficult. We cross the aortic valve. We have to do pre-balloon dilatation. That is 80 millimeter balloon is put, and then this is the evolute valve which is in the sheath. This is the valve which is going across the aortic valve, native aortic valve. So transcatheter heart valve, we are just positioning it. It should not be too low, otherwise it can lead to CHB. If it is too high, it is not effective. So you have to have optimum 3 millimeter depth across the aortic annulus. So that is what we are doing, trying to do. As soon as you unseat the valve opens up like this, and ultimately valve stays there. And this is the final aortogram. There is no aortic regradation, and the patient had a very good, no gradient also. And as you know, 5% patient may develop conduction defect and even CHB and may need permanent pacemaker also. But in our patient, luckily, you see the signs of even anteroseptal ischemia and infarct even, that everything disappeared later on post-PCI TAVI. ECG was normal, no conduction defect, no left bundle branch block. So immediately patient improved significantly. Post-TAVI echo showed mean gradient of 6, which is insignificant, trivial paravalvular leak, mild MR, RVSP, which was initially 80, has now become 40, normal is 30. Discharge after 4 days, follow-up at 1 year. Asymptomatic, living normal life, fully active again, is now 80 years of age. And if you see literature, now 5-year follow-up is available. If you put, compared to surgical aortic valve, transcatheter aortic valve gives you less mean gradient compared to surgery and better valve area compared to surgery. And as far as balloon expandable versus surgical, balloon expandable versus self-expanding valve is concerned, self-expanding valve being a supraannular valve gives you better valve area and has longer durability also. So in conclusion, last slide, elderly, sick, diabetic patient who had presented with acute coronary syndrome, acute severe MR, pulmonary edema, acute kidney injury associated with severe calcific aortic stenosis, with low flow, low gradient status, with severe pulmonary hypertension, where PA pressure was almost systemic, and had severe LV dysfunction, with ejection fraction of 25, STS score more than 8, meticulous planning of sequential PCI, followed by TAVI. You cannot do even, first step is aortogram. You cannot do aortogram in the situation when patient is in this condition. So you do sequence PCI first, stabilize the patient, cold after that, kidney is now better, heart is better, and then you do TAVI, and ultimately that led to, we could save his life. So even in hopeless situation, this was hopeless situation, when physician referred the patient to us, he told that he may die on the way also. It's a 3-hour journey, 4-hour journey. Whether he will be able to reach, I'm not sure, but I did my best. I could not do further, so you take care. And he could reach here and we could save him. So never give up even in hopeless situation. And now our center is approved for the TAVI program as a solo implanter. Otherwise you need proctor, but now we are doing TAVI. We are the highest, CIMS is the center where we have done highest in Gujarat. Almost 28 TAVIs are done, 29 actually. We did one last week also. So this is that. Thank you.
Again, before I go to the cases, I'll have 2 slides to give you some idea about how to select anti-ischemic therapy in seniors. Now we all know that as the age increases, variety of cardiovascular risk factors increase in prevalence. So somebody who is 75 has more chance of having hypertension, diabetes, dyslipidemia as compared to somebody who is young. So as the age increases, there is more and more chance of using multiple antiplatelets and anticoagulant agents. That's very clear. But we also know that as the age increases, risk of bleeding also increases. So when you use antiplatelet agents, dual antiplatelet agents, or for that matter, warfarin or newer oral anticoagulation agents, in senior citizen who is more than 70 years, 65 years, you are creating a state where there is risk of bleeding is very high. And we also know that once a patient bleeds, either ICH or major GI bleed, which leads admission, which leads surgery, which leads to PCVs, it's a disastrous situation. So when you write a medicine, it's very important to understand what is the ischemic versus bleeding risk. And based on that, you need to tailor the treatment for a senior citizen. I discussed this slide before a few days. So there are certain criteria which is called as HBR, high bleeding risk. Before starting of this conference, I thought throughout these 3 days in this conference, I need to give a clear message to all the physicians that in your practice, now you are start thinking on HBR, high bleeding risk patients. Who are they? They are the people who are more than 70 years of age, hemoglobin less than 11, platelet count less than 1 lakh, past history of major bleed, past history of GI bleed, past history of intracranial hemorrhage, those who are having severe liver disease, severe kidney disease, EGFR less than 30, those who are having active cancers. So if you look to your right side, age more than 75, EGFR between 30 to 60, HB between 11 to 13, use of NSAID, underweight. Believe me, out of 10 patients you see in your practice who are more than 70 years, they will have at least 2 points from this. And that's why by and large, anybody and everybody you see in your practice who is more than 70 years is generally a high bleeding risk candidate. And that's why you should be very, very careful. So with this brief understanding, keep your voting pads ready. Let's go to a clinical case which was a genuine case. And I will ask you a question and seek your point. What kind of treatment will you select? So she is a lady, 70 years, BMI is 28 kg, so not underweight, hypertensive on treatment, no diabetes, no tobacco, no past history of atherosclerotic cardiovascular disease, no past history of major bleed or acidity. So whenever you see a senior citizen, you need to look for all this history. Is there a past history of major bleed? Is there a past history of acidity? Is there a history of NSAID use? What is the EGFR? What is the platelet count? What is the hemoglobin? So this is all important. So this lady has EGFR of 58, platelet 2.5 lakh, HB 11 gram, lipids is reasonably okay, 150 is total cholesterol, 45 HDL, 70 LDL. So she wants to reduce her severe risk. She has come to you, doctor, reduce my severe risk. And your choice is start a small dose of aspirin, 75 milligram, start 75 milligram aspirin with PPI, start 75 milligram clopidogrel, start 10 milligram rosuvastatin, or no need to do anything. Your time starts now. So most of you believe a small dose of rosuvastatin is good. So let's see what is the answer. Now there are 3 points. Number one, this is a case of primary prevention, a 70-year lady who is a borderline high risk of bleeding. Now we all know that, and I have taught on the day one, that aspirin, at least in people who are 70 years or above, there is no role as far as primary prevention is concerned, because that's where penalty is more than the benefit. So aspirin is out. Second point is rosuvastatin. Yes, anybody and everybody who has cardiovascular risk of more than 7.5 or 10% for next 10 years will get benefit by rosuvastatin. But having said that, now that ASCVD risk calculator is based in US, we are Indians, we may or may not take that, but one point is look to the LDL cholesterol of this lady, which is 70. So somebody who is 70 years, well-controlled hypertensive, LDL cholesterol is 70, the decision to give statin is good, but it should be a shared decision. That's where you talk to the patient that your cholesterol is fine, your blood pressure is well controlled, you seem to be reasonably good. But based on age predominantly, your risk of MI, stroke and CV death in next 10 years is higher. So there is a medicine which can reduce that risk. If you want to take that, you take that. So I personally believe to such a patient, I will not compel her or will force her to take statin, but will make an explanation that statin will help you if you can take. Let's go to second case. A gentleman, 75 years, past history of inferior myocardial infarction, ejection fraction 40%. He didn't undergo angiography, has been on optimum medical management. You don't know the coronary anatomy. EGFR is 45 ml, has history of acidity, no past history of major bleed, platelet count is borderline, 1.1 lakh, HB is again 10 low, on aspirin 150 milligram daily. So he is a case already established atherosclerotic cardiovascular disease. Before 3 years he had an event. After that he has been fine. No cardiovascular event. What is your choice? A, continue the same dose of aspirin. reduce the dose of aspirin to 75, reduce aspirin to 75 and add PPI, stop aspirin, start clopidogrel, or give dual antiplatelet treatment, which is my favorite. So your time starts now. So majority believes either COD. I think that is reasonably good. So everybody has almost taken it right except for the E. So let me explain you. This is a case of secondary prevention for cardiovascular disease, already MI. So you need one antiplatelet. There is no question unless there is massive bleeding going on. So patient needs one thing. So what is the dose of aspirin if you have to give? 75 milligram. And somebody who has got high bleeding risk, say he has past history of acidity, platelet count is borderline, hemoglobin is low. So aspirin better combined with PPI. Or if you want to make it little safer in the same tune, even clopidogrel can be okay. So either aspirin 75 with PPI or clopidogrel has to be there. Taking off all the antiplatelets is not advisable because patient has definite evidence of past history of SES. So going to third clinical scenario, male 73 years, hypertension, controlled, diabetes on oral antidiabetic drugs, no tobacco, eGFR is 50, no past history of major bleed, platelet 1.5, hemoglobin 11.6. Now patient has got entry-wall non-ST-elevation myocardial infarction, troponin is 5 times upper limit of normal. He wants OMT, optimized medical treatment, and is not ready for undergoing angiography. So patient has come to you and you have to start anticoagulation. You have already loaded antiplatelet, you are willing to give anticoagulation. So what is your choice? IV infusion of unfractionated heparin guided by a PTT, the gold standard. Subcutaneous unfractionated heparin, that is simple heparin 5000 sub-Q TID. Enoxaparin, that is Clexane-like drugs. Dalteparin, that is Fragmin-like drugs. Or subcutaneous fondaparinux. Your time starts now. So most of you have taken C or E, a good point. So let me give 2 points. Number one, anybody and everybody who has come to you with non-ST elevation myocardial infarction and wants medical management, the safest anticoagulation approach is subcutaneous fondaparinux once a day, unless your creatinine clearance is too low, less than 20-25. If a patient is undergoing invasive strategy, that's where unfractionated heparin or enoxaparin is good. So if you convince a patient for invasive strategy and patient is ready to be shifted to a cath lab facility hospital, or you are already in a cath lab facility hospital, then go for unfractionated heparin. But if patient is not ready for further going on cath lab, then fondaparinux is good. And let me take you to the last case. A female 74 years, 56 kg body weight, hypertension, no diabetes, no tobacco, eGFR is again 50, no past history of major bleed, platelet count is 2.45, hemoglobin 10.6. So again see, these all are bunch of people who are on borderline bleeding risk. So patient is presented to you with STEMI, enteral myocardial infarction. The idea is drip and ship. What is drip and ship? Pharmaco-invasive treatment. Patient has landed to a hospital which is not having cath lab. And you know that first medical contact to PCI, that time if it is going to be more than 120 minutes, you have to offer thrombolysis. So patient has been in a peripheral center, going to a cath lab center is going to take 3, 4, 5 hours. So that's why we decided to give a thrombolytic therapy and then subsequently shift the patient to PCI capable hospital. So your choice, read carefully, routine dose streptokinase, load aspirin, load clopidogrel. Half dose streptokinase, load aspirin, do not load clopidogrel. Routine dose tinactaplase, load aspirin, load clopidogrel. Half dose tinactaplase, load aspirin, do not load clopidogrel. So understand the options very well and then your time starts now. So a good point. C and D is good, but I'm happy to see that. So number one, any senior citizen who has got high bleeding risk, tinactaplase has to be the choice. That is number 1 point. Tinactaplase has to be in half dose, mind well. So you have to adjust the dose of tinactaplase with the body weight, and then with that body weight, whatever it is, whatever dose you are calculating, you have to make it to the half, because that is something which is very important. You can load aspirin, but do not load clopidogrel. So any senior citizen with high bleeding risk, half dose of tinactaplase, clopidogrel start with a maintenance dose, aspirin 150 to 325, and then go ahead. Thank you very much for your kind attention.
This is a 20-year-old guy having chest pain and the skin lesion. Now the patient basically came to me before 7 years. At that time the age of the patient was 21 years. There was complaint of mild chest pain. Echo was done outside, which showed some mild mitral stenosis, mild moderate MR, some aortic stenosis, and AR also. Patient already had a skin lesion, okay, on the extension surface of the elbow and knee area at the age of 2.5 years. Okay, that was already documented. At that time, the pediatrician recommended blood test and found to have a high lipid level. There is a strong family history. Father is having undergone angioplasty at the young age. Mother also is having dyslipidemia on treatment. Grandmother, maternal uncle also had a very high lipid levels. Now this was the 2000 pediatrician. When the pediatrician saw that patient, he has also documented that that's a lesion on the extensor surface of the arm, and he suggested the echo also was done at that time, which was absolutely normal. And this was the 2001 LDL report, and as you can see, the LDL at that time was 806. Okay, so this is a very, very high LDL. And this is what patient when came to me was having. As you can see very nicely, there is on the extension surface, there is a swelling. That is what we classically call as a tendon xanthoma. Not only in the, but also in the knee area, there is a very classic tendon xanthoma, elbow area, and also in the foot. So there are multiple places the typical tendon xanthomas were seen. And every time, at that time when patient came, that blood pressure, I mean the LDL level was, as you can see, it was 818. And if you look at the triglyceride level, that is almost normal. Okay, so it is a typically LDL which was very high. This was the follow-up report where also consistently the patient was having a very high LDL level. The ECG at that time was absolutely normal. Echo, which was done in 2015 when the patient came, there was also some mild valvular heart disease. Can we have the voting pad? What this patient could be having? It's a rheumatic heart disease with subcutaneous nodule, heterozygous familial dyslipidemia, homozygous familial dyslipidemia, polygenic familial dyslipidemia, or familial combined dyslipidemia. Wow, that's great. So most of the people, 50% think that it's a homozygous family. Let us discuss about this entity. Basically, whenever we talk of the familial dyslipidemia, it is an autosomal dominant disorder with LDL clearance. Okay, so LDL is not getting cleared from the blood by the LDL receptor which are there on the liver cells. That is one. It is basically present since birth, and it is diet resistance. No role of diet in this patient. And when there is a homozygous variety, it is very rare, and LDL level has to be more than 500 to 1000. That is typically what we see. And the incidence is 1 in 250,000 patients. So this is what is happening. The LDL and the blood which is circulating VLDL, it is converted into IDL and into LDL. And LDL is taken back by the liver cell, by the LDL receptor. So if there is any abnormality of the liver cell receptor, it will not be reabsorbed. And that is the reason they are going to have a very high LDL level. And this is what the familial thing will be there. Mother and father both will be having one gene abnormal, and when the both are combined in one of the child of the four, definitely he is going to have a homozygous variety, and their LDL level is going to be very high. So LDL level will be high, xanthomas will be seen, parents will be having a dyslipidemia, and cardiovascular signs will be seen. So as I have told, it may be whenever there is a single gene abnormality, it is what we call as a heterozygous familial dyslipidemia. When the two identical, both the genes are abnormal, it is what we call as a homozygous familial. And sometimes there may not be any receptor, okay, LDL receptor null, that is where we have a very high level, and the patient usually have a cardiovascular disease in childhood. So typically when you come across a child with the LDL level more than 155 or more than 400, you have to think if it is more than 400, homozygous variety. An adult, whenever you see that LDL is very high, okay, say more than 190, it is likely to have heterozygous. If it is more than 500, you have to think that there is a strong family history. Along with strong family history, then it is a heterozygous familial. So what are the physical findings normally we see? There is going to be a cutaneous xanthoma, tendon xanthoma, xanthelasma, heart cardiac murmur will be said, especially the aortic outflow murmur, arterial bruise will be seen because there is a deposition, and tendinitis and polyarthritis also is commonly seen. Now, how to identify this patient? You have to pick up those patients in the childhood. As you can see, our patient was taken by a pediatrician who has found out that the level is very high. So if you don't get this report done at childhood, you cannot pick up those patients. And there is a very standard Dutch criteria for diagnosis of this disease, and there are certain parameters. It is available online, and especially if you have a genetic or the DNA which confirms this, then it is confirmed diagnosis of this thing. Now previously also we had talked that there is something like a lipid level or years which we are exposed with a high lipid level. If the person is in homozygote, likelihood of coronary disease may be at the age of 12 or 15 years, okay. If it is heterozygote, when one LI is abnormal, LDL is say 190 to 500, then classically they have coronary disease at the age of 35. Of course, other risk factors may contribute, add or decrease, but we have to think that younger patient can have this disease. So this patient was coming for regular follow-up, patient was put on rosuvastatin and ezetimibe, and LDL level used to be very high. Now what are the options for this patient? And if you look at the echocardiography, it showed some valvular involvement because of the deposition of cholesterol on the valve itself. So we decided to go for the genetic study as we thought that this is a very classic, and this was a genetic study which was done and which clearly tells that it is a LDL receptor abnormality, it is an homozygote variety, and it is autosomal dominant, and it is pathognomic for this the presentation and this disease. So this is what was got. Now what to do in this group of patients? We have to start the therapy very early, and it is proved that if you start therapy very early, then all-cause mortality and cardiovascular mortality is significantly better if you start the treatment early. What are the options for us? So we have to give statin, ezetimibe. We have to understand that it may have a very limited role. PCSK9 inhibitor also can be used in this patient, but going to have a very limited role. There are very specific therapy for this group of patients, that is, we will just discuss. So one of the good options for this patient is we have to do an LDL apheresis. That means it's something like a plasmapheresis when blood is replaced every 15 days. So we have to remove all the blood, we have to filter with the heavy particles will be removed, and this has proved to be a very effective way of reducing LDL in this group of patients. And it has also been found that if you do LDL and cut down the LDL level, then definitely cardiovascular outcome can be better. It almost 40 or 50% reduction in cardiovascular outcome can be seen. There are certain specific molecule for this kind of which is not available. I will not discuss much about this, but primarily it is going to be a mechanical removal of the LDL particle with LDL apheresis. That is the main option therapy available at this patient. So patient was advised to undergo lipoprotein LDL apheresis, but because of some or the other reason he did not agree, and patient was put on continuously on statin. But continuously it was not responding, okay, because it is, we'll just explain why it was not responding. Before 2 years, patient started having a chest pain on exertion and breathlessness since last 15 days. And this was the ECG at that time. As you can see, there are significant assay changes at that time. And echo was done. Previously, ejection fraction was normal. Now it is severe airway dysfunction, or moderate airway dysfunction, EF of 40, and severe MR, which has worsened compared to the previous. And this was the angiography which was done. It clearly showed a very significant long lesions in the proximal arteries, as you can see. This is the another one. This is the RCA. As you can see, there is a very tight lesion here in the proximal aspect. So I performed the angioplasty in this patient. I had to put a very long stent in RCA, a long stent in LED across left main. Patient was stabilized, coming for the follow-up, no angina, no breathlessness, ECG is almost normal, ejection fraction is improved from 40 to 55%. So in summary, our patient started with some valvular abnormalities, but having a tendon xanthoma, LDL was very high, family history is strongly positive. As you can see, there is severe premature atherosclerosis which was found. Angioplasty has to be performed at a very younger age. Mitral and aortic involvement also was seen, and genetic study also confirmed that this patient had a homozygote variety. So now the answer in this question, I will not just voting pad, but definitely it is homozygote familial dysarthria. Summarizing the case, as I told, it starts with the birth, okay. It is diet resistance, as you can see here, very rare, 1 in 250,000 patients. LDL is going to be very high, and as I have told, it is an autosomal disorder with LDL clearance abnormality, not the LDL production or nothing else, okay. And that is the reason it may happen that statin or ezetimibe, or even for that matter PCSK9 inhibitor, may not be effective because it is not a primary problem. LDL receptor abnormality, we have to target them differently. Once, as I have told, by the plasmapheresis where you remove, or there are certain specific therapy which are available which can be useful in this subset of patient. As you can see, the reaction in LDL with a standard therapy like ezetimibe, statin, benzoic acid will be in the range of 0 to 40%. As our patient had no response to this standard therapy, of course, patient is right now taking, but there was no therapy. And LDL level, whenever is very high, not controlled with this therapy, then apheresis is the only option. As you can see here, we can give other therapies, but we have to think that homozygote variety is LDL clearance abnormality, and for that a specific therapy is required. So identification by pediatrician or a family physician or physician is very, very important. Screening should be done whenever you suspect a high-risk patient. Early diagnosis is the key, and we have to start the treatment very early if you want to get a good outcome in this patient, and refer to the patient to the specialist center who is handling this kind of patient very nicely. Thank you very much.
We will be discussing a case where we do angioplasty without dye or very limited dye. Basically, we know that coronary angiography is the gold standard as far as the diagnosis of CAD is concerned, but it has got its limitations because it is basically a two-dimensional method, and it does give good information as far as the severity of the lesion is concerned. But sometimes what happens is there will be overestimation or underestimation of the lesion severity with this method. Number two, it does not give information regarding the plaque and its composition. And suppose there are ruptures or dissections within the vessels, you can sometimes miss it. And positive remodeling of the outer vessel wall is the problem, and that leads to underestimation of the lesion severity many times. And for this reason, we have to take, views in multiple projections, perpendicular to each other to exactly identify the severity of the lesion. But by doing this also, we may sometimes underestimate or overestimate the severity of the lesion. And that's why we have got these imaging methods. We have got two imaging methods. One is IVUS and another one is OCT, and this has been discussed in detail yesterday also. And this intravascular ultrasound is the method in which we insert the IVUS catheter, which has got a tiny sonographic probe at its tip, and we can get the image of the coronary artery from inside the vessel. And with this, not only we can exactly know the severity of the lesion, length of the lesion, but at the same time we can have measurement of lesion characteristics. It also allows determination of plaque and vessel morphology to assist in clinical decision making, as we will be discussing. It enables optimal stent implantation. So, proper expansion and apposition of the stent can be made sure with this method, and it is particularly useful in complex lesion subsets like left main lesions, diffuse disease, in-stent restenosis, and calcified lesion. In patients who has got restenosis and thrombosis, you get a better assessment, and the one more important use of this method is it is useful in contrast reduction, as we will be discussing in this case. And because of this method, it improves both short-term and long-term clinical outcome. So IVUS has basically two, this quantitative size measurement is possible, and vessel morphology can be seen with this method. So this is how IVUS looks like. This is the IVUS. You can see this is the healthy vessel, this is the catheter, and this is the vessel, and this is the healthy vessel, and this is the vessel having fibrotic plaque, you can see here. So this can be very well identified with this method, and like this you can identify calcium, you can identify thrombus and all lesion characteristic with this method. Now coming to the point that this IVUS guidance helps to minimize the use of iodine contrast in percutaneous coronary intervention, and this was the paper published which showed that angiographic guided the percutaneous intervention, the total contrast volume was in the range of 71.4 plus minus 3.59, while IVUS guided intervention had very minimal contrast, 22.9 plus minus 12.5 with very significant p-value. And this was the publication Zero Contrast IVUS publication in European Heart Journal, where this imaging and physiology guided percutaneous intervention without contrast administration in advanced renal failure, because those patients who has got CKD or raised creatinine, if you give dye, then their creatinine becomes more bad. So in that case, this IVAS is very, very useful. And this is the example, one case that we did, 77-year-old male, he had got effort angina since 6 months, he was hypertensive, diabetes, and he was having CKD. He was referred for angiography, and 3 vessel, disease was there in angiography with high syntax score, and patient refused for coronary angiogram. But the strategy was roadmap with previous angiography, and 2 wires were used in RCA, as you can see, and IVAS assessment was done for this PLV ostium, and the strategy was, it was decided whether it was provisional versus 2 stent strategy should be used, and that was decided with the use of IVAS. So first IVAS was done to know the lesion length and to know where to land the stent, to know the healthy area where we can land the stent. And you can see this is how it is done, and the healthy spot was identified, and the stent size and length was determined. So to tackle the lesion, we are not using dye. So you can see this. So 2 wires are placed. First, we dilate with semi-compliant balloon 2.5, then non-compliant balloon 3 mm, and then 3.5 non-compliant balloon for more proximal part. And this balloon size was determined with the IVAS images. Then the 2.25 by 28 dash was placed at the bifurcation, and 3.5 by 38 days was done with overlap. And then post dilatation was done. Until everything is done, we have not used dye. And then re-IVAS was done, whether our stent placement was okay or not. And it was seen that there was no dissection, and there was, you can see there is slight under expansion after initial post dilatation at the bifurcation area and proximal right coronary artery. So further post dilatation was done with 3.75 non-compliant balloon, and this final stent deposition was done. And the angiography was used only in the final shot. So it's a ultra low contrast, and there was a good angiographic result. Perforation was excluded, right? And the result was good. So learning points are, IVAS helps to size the vessel, length of the lesion is determined, you can identify the landing zones, you can optimize the stent placement, and you can also do bifurcation planning, right? And this biplane method and guide extensions can be used, and this contrast is used only for the final shot to exclude perforation, to exclude distal embolization, and for any surprises if it is there. So in conclusion, this chronic kidney disease and acute kidney injuries remains the frequent complications of contrast media exposure during coronary angiography and intervention, and therefore patients with advanced CKD are at high risk of this contrast-induced AKI exposing to significant burden of morbidity and mortality. And the novel and creative procedural strategies to minimize risk of this is decreasing the contrast volume. And with this zero ultra low contrast volume, you do PCI by using is IVAS imaging and also diluted contrast media and metallic rod mapping with guide wires. And radial as default access route to decrease the risk of bleeding and embolization of atheromatous debris into renal arteries. And you can use hemodynamic support in high risk setting, and also remote ischemic pre and post conditioning. Thank you very much.
This was a patient who was 90-year-old. He is alive now. He is 90-year-old. He is a diabetic. He was hypertensive for the past 20 years. Non-smoker, and he was living a very healthy life. He underwent health checkup 10 years ago, just for routine health checkup. And TMT turned out to be positive, but he was asymptomatic. And that point of time he underwent angiography, which showed the triple vessel disease. But he was advised bypass surgery mostly. But he did not undergo bypass surgery or any form of PCI because of there was no symptom, and he was absolutely fine. And he was on regular treatment since then. And presently what happened, he started developing dyspnea on exertion and the effort angina. Initially it was a class 1 and class 2 for the past 2-3 years. And then recently he has worsening of the angina and it became class 2 to class 3 for the past 2-3 months. Now the patient was very active before 2-3 months and then he started having symptoms. Even he was not able to do his routine activities. He is a very owner of very famous restaurant in Ahmedabad. So like he was very socially gathering person, mingling person, and then all his activities were restricted. So he started having like depression. His son used to come to me, "Sir, Papa ke liye kuch karo aap. He is not feeling well. He can't sit at home." So, and symptoms were too much. And symptoms were not improved even with the aggressive medical treatment for the past 2-3 months. Investigations, hemoglobin was 9.4. I thought there may be some loss of blood, but when I could review the previous report, his hemoglobin was always around 9-10 for past so many years. So probably he was having like thalassemia minor. Serum creatinine was 1.49 and potassium was 5.3, and all other reports were almost normal. And the previous ECG was also normal, but the current ECG, what it was showing, gross STD changes in the anterior leads. So that means there was significant ischemia going on. Echocardiography was again, it was normal. There was mild inferior or anterior hypokinesia. Aortic gradient was like on the normal range. Some little bit atherosclerosis or sclerodegenerative valve. This is the picture of his 10 years ago angiography. You can see everywhere there is a blockage. RCA was 80% from the ostium. There was plaque in left main. There was significant lesion in LAD. LAD there was not significant lesion, but circumflex there was significant lesion. So that's why he was asymptomatic for quite a few years, but subsequently now he is symptomatic. And this is the latest angiography which I did. You can see there is a complete occlusion of the right coronary artery, left main plaque, LAD disease, circumflex disease, diffuse disease. And if you see the angiography, the RCA is absolutely 100% occluded. And there are a lot of calcium. Those who understand the angiography, I think they can understand how much is the calcium and what is the like disease burden. And if you see carefully, there is a discrete lesion in LAD here on this point, and here in the left main, distal left main, there is a tight critical lesion, and right coronary was absolutely occluded with full of calcium. So I think there was no possibility of doing anything for the right coronary artery at this point of time. And after seeing this angiography, this time also we advise whether to go for a bypass surgery. But because of the like age related concern, the family were not willing to undergo sending to bypass surgery. So they asked me whether we can do any angioplasty for this patient. I suggested because doing angioplasty in such a calcific artery is very difficult. We may not able to give a good result also. And getting an optimal result with the angioplasty is always challenging in patient with heavily calcium. And aggressive medical treatment we were already giving and he was not improving. So most important factor for intervention in the old age is the patient's own willingness. Like this patient was willing to have his normal life. So we were also happy that okay, we have to do something for this patient. So positive attitude of patient is very important if patient want to undergo intervention or any kind of the therapy. And again, not only patient but family willingness is also very important. Because sometimes patient will say, sir, मेरे को problem है, but family will say, अब चलने दो sir, अभी तो दवाई पे 90 की age हो गई है, अभी क्या करेंगे? So like both sides you have to be prepared. Family also should be ready and the patient also should be willing to undergo some intervention. So most family, why they are worried? Because they have fear of कि इस age में अगर कुछ करवाएंगे तो कुछ और complications नहीं हो सकते. So mostly they are worried about the iatrogenic or something complication related to the procedure. So we have to discuss this thing in detail and then only we can reach on the conclusion. So what are the challenging by doing angioplasty in heavily calcific lesion is always challenging because you may not cross the lesion. If at all you cross the lesion, sometime balloon may not go, stent may not go, or if you use the rota ablation, there may be perforation of the vessels. And if you put a stent also, there may be some under expansion and subsequently there is a stent thrombosis risk. So doing angioplasty in the calcific lesion is very, very like difficult thing and cumbersome. And because when you do the rota, there may be some occlusion of the collateral vessel. you will realize that before 10 or 15 years ago, even the patient with single vessel disease with some calcific artery, they used to undergo bypass surgery, not with the angioplasty, because angioplasty may not be possible those days with the heavily calcific vessels. So this patient, what I could thought is a IVL, intravascular lithotripsy, which Dr. Keyur Parikh also has presented one case in the morning. And Dr. Vipul Kapoor also showed video yesterday. So I think this patient is appropriate for doing a intravascular lithotripsy. I will not show this video because already the video has been shown by Dr. Keyur Parikh. But it's a very good tool to remove or to just debulk the artery. You can see here, there is a lot of calcium here. And along with there is a critical stenosis, we pass the wire LED, so we pass the wire in the diagonal to protect the diagonal. Then first we did the balloon dilation with a small balloon, and then we passed the IVL catheter. We given the 10 pulse of IVL for 10 seconds, and subsequently the LED lesion was crushed and that was expanded very well. But there was heavy calcium in the left main. So it took more pulse to open up the left main, and here you can see still after the IVL there is a lot of calcium and this artery is now expanding. But after repeating the pulse, IVL pulse, I think this vessel has opened very well, the calcium is cracked now. And after doing the balloon dilatation of the left main and LED, we put a stent in the LED and the left main, and the final result was very good. Even for putting a stent, we have to use the guiding catheter because there was a lot of calcium. And finally, we could do a very good angioplasty. You can see there is a good result. Left main expansion is good, LED expansion is good, and the patient was become asymptomatic on the table. So patients really become very happy after the procedure, and he was so happy that second day morning, I think we could discharge the patient because he didn't want to stay in the hospital. So there was excellent uniform expansion of the stent, no compromise in the distal flow, no risk for perforation like in the rota ablation, and by doing the IVL there is easy to pass a stent in the distal vessel also, and patient was very happy and asymptomatic. He went home next day, and after this follow-up ECG, which was absolutely normal, all the ST depression gone, and the patient was absolutely asymptomatic. And this is the 1 month follow-up. Patient was happy. He started going to again to his restaurant, and he is doing a very healthy life. So the take-home message from this case is, age should not be limitation for the treatment of the elderly patient. Any elderly patients come to a week, we say, nahi yaar, abhi to age hogi, so that is not a good. Because if patient want to live, patient is having symptom, you have to focus on the symptom, not on the age. So you discuss the patient, all the pros and cons, and give the best available solution. Should aim for the symptom relief rather than the complete revascularization, fancy, lengthy and complicated procedure. So make it very simple. Do a angioplasty of the culprit vessel. Do a angioplasty of most critical vessels, and patient will be fine. He will at least relieve from the symptom. So for all the elderly patient, old patient, we should discuss all the available options with their pros and cons in a positive way so that patient can be prepared for the procedure. So IVL is a good and safe option for severely calcific vessel. Thank you so much.
I'll be presenting a case of coronary stent infection. It was a rather complicated case of coronary stent infection. So we had a gentleman who was 45 years of age and presented to us. He was a diabetic and a hypertensive patient. He presented to us with a history of on and off episodes of fever for the last 1 or few months. This patient had also history of discharging sinus from the sternal wound region. He was a diagnosed case of coronary artery disease, and in the last 6 years he underwent multiple interventions in some other hospitals. So he was first diagnosed coronary artery disease in 2016, and PCI and stenting to the left anterior descending artery was done. 3 days later the patient had chest pain for which he was again taken for intervention, and COBA to left anterior descending artery was done. But the patient developed fever 1 week later, and repeat coronary angiography after 1 month. The patient was found to have a lesion and instant stenosis, for which he was surgically managed, and he underwent coronary artery bypass grafting in the same year. 5 years later, he developed sternal wound sinus, and he was initially managed with antibiotics, but the symptoms didn't relieve, and he was finally taken for sternal wile removal at some another hospital. And during his further stay for over 1.5 years, he was there were interventions which include sternal wire removal, vac dressings and primary closures, and with multiple courses of antibiotics. So in 2022, the cultures showed staph cocci, but in repeat cultures, he was found to have Pseudomonas. And this was the time when he presented to our hospital, and he was diagnosed as a case of coronary stent infection. His blood panel was normal, but his CRP was raised as expected. We did the echocardiography, and he was found to have ejection fraction of 25% with the anterior and apex and interventricular akinesia. We also did the angiography, which showed proximal LAD occlusion, but the left internal mammary artery to LAD, it was patent. But the stent was lying in very close proximity to the anastomotic region. These are the angiographic images. Then we later on took the patient for CT scan, in which we injected non-ionic radio-opaque substance from the sternal sinus. We injected that substance from the sinus, and then we do the imaging. And it was found to have the sinus on tracking. It was going posteriorly and laterally up to the LAD region, and we can see the very granulomatous tissue over there. From that region, it was going posteriorly further and laterally to the main pulmonary artery, and it was entering into the one of the lobar branches. So clinically, we also appreciated the presence of contrast into the one of the lobar bronchus. So this was the image that we retrieved from the imaging, and it was clearly depicting presence of coronary stent infection, which was anteriorly communicating with the sternal region and posteriorly going into one of the lobar branches of the tracheobronchial tree. Then we prepped the patient for surgery, and as we gone through the surgery, we ensured peripheral cannulation. We took hold of peripheral vessels, and we did SVC percutaneous cannulation. This was when the sternum was opened. It was densely adhered. This is a picture how it looks like when we opened the sternum. We decided to go for central cannulation. We secured the aortic cannulation, aortic cannula and IVC cannula for drainage of the lower part of the body. Then we dissected the region as it was injected with methylene blue prior to the surgery, and we took out the stent and secured the proximal portion of the LAD, and we closed that with the help of Teflon felt as well as Prolene sutures, and also plicated the posterior region. Because the left internal mammary artery was not able to be salvaged, then we placed one graft onto the distal LAD, one saphenous vein graft. This is normal heartbeat, but this is on a video on a higher speed, so it seems that the patient is not having a regular heartbeat. So this was the final picture. We secured the infected region and we placed one vein graft. After the closure of each and everything, when we debrided the sternal region, we removed whole of the necrotic tissue. These are the pictures. This was the stent which was removed, and we sent this for culture. All the other cultures were negative, but the stent which was sent for culture, it revealed Pseudomonas, and we gave the antibiotics as per the sensitivity. As the patient was having a AFB stain positive elsewhere and multiple tracts were encountered during the dissection of the infected region, we decided and we suspected the atypical mycobacteria to be as a co-pathogen, and we decided to put the patient on minocycline 100 mg twice BD and azithromycin 500 once daily and linezolid 600 mg once daily. So because of the atypical mycobacteria, we decided to continue the antibiotic therapy for a period of 6 weeks. In the follow-up, the patient was doing well and echocardiography showed improved results, and no sinus or sepsis or sternal wound region dehiscence or sternal wound sinuses were noted. Just before ending last few slides on coronary stent infection, the first case of coronary stent infection was published in 1993 by Leroy in France, and we have seen rising cases of coronary stent infections in last few years, maybe because of you can say aggressive interventions or because of aggressive or better diagnostic modalities and increasing load of coronary artery disease. Currently, we have 126 million cases of coronary artery disease globally. Pathophysiology, this we know, it is an inflammatory process and occurs because of progressive arterial destruction and leading to hemorrhage, which can further get infected and can present as a coronary sinus infection. Then staph is the most common culprit organism associated with this pathology, and nearly 2/3 of the patients, they have true or pseudoaneurysm, and it can be alone or in combination with the in-stent restenosis. And 1/3 of the patients usually have vessel occlusion, which requires revascularization and removal of the infected portion of the stent. However, very few cases of coronary perforation and cameral fistulas are also reported. Duration of antibiotics in these cases are usually 6 to 8 weeks in case of acute infections. And if there is mycobacteria or atypical mycobacteria is encountered, the treatment can be as long as 6 to 12 months. So diagnosis, or you can say the high risk factors which can predispose for patients for CSI, they are placement of a patient is having a coronary stent implantation, and within the 4 weeks he is not having any other symptom or not any other cause detectable for bacteremia or persistent leukocytosis or fever. So they can be strongly suspected for CSI. And patients which tend to have multiple repeat procedures performed during stent infection, they are probably they can be more at risk for developing CSI. Role for prophylactic antibiotics is definitely in patients with immune deficiencies in which the difficult procedures are encountered and in which multiple repunctures and stenting of the areas. For example, also patients having hemodialysis catheters are there, and stenting of surgically difficult to reach areas or vessels, and the patient with known colonization of any organism, so they tend to benefit from antibiotics. Take home message is, yes, definitely CSI is a spurious complication of PSC, although it is very rare and it should not be directly correlated with stenting. Sometimes we usually get patients from some other regions. So whenever you get a patient for CSI, always look for your infrastructure and your resources, whether your labs are adequately sterile or whether there is any breach in the sterility or in the safety method. Then rapid institution of antibiotic therapy is the mainstay of treatment, followed by surgical drainage, which is necessary, and we have seen in quite a good number of cases that there is a lot of pus and pus flakes present around the pericardial region. Sometimes because it is a nasty and it is a long-standing infection, despite optimal therapy, CSI can have a bad prognosis and it carries mortality as well as morbidity. And most important, as we always believe, multimodality approach with optimum stabilization prior to surgery is best. Taking the patient in the best shape to the surgery always give you better results. We at CIMS, we have so far encountered 4 cases of right-sided coronary artery CSI and 8 cases of stent infection in the LAD. We did MRI and angiography in almost all the patients, and these 2 investigations remain the diagnostic approach. We are very proud to say that we have achieved complete revascularization in all the patients, and the hospital stay remained for average of 8 to 23 days. The longest stay was for 23 days in one patient, in which was presented to us in a cardiogenic shock. And in 5 cases, we were not able to get any of the cultures from any of the tissue, any stent tissue or from the peripheral. So this was not just a few cases which were a positive outcome. It was expression of, you can say, potential and a team potential. Commitment, as we always say, commitment, perseverance, dedication, communication, decision making, and the most important, as we believe, team effort, which includes cardiac surgeons, cardiologists, infectious disease specialists, radiologists, nephro team, OT, ICU teams, intensivists. All these will lead to a good success and better outcome for the patient. So this is our complete team and this is our surgical team. Thank you. That's all from my side. Thank you very much.
Everybody to focus on was thrombosuction, aspiration. Recently there have been a few negative trials that routine aspiration may not be necessary and in fact may be harmful. But certain justified cases, judicious cases, right, there is no other option but to thrombosuck, right? And that is why this particular case presentation is very, very important, and I believe, there are a lot of take-home messages with this case. So the clinical details are as follows. This patient was a 56-year-old gentleman, hypertensive, diabetic, tobacco chewer. He had an acute inferior wall STMI, non-thrombolized because of late presentation, and status post bypass 2001. So as you can see, this was an 21-year-old bypass patient. So you can imagine the status of the grafts, okay, because 21 years, 2 decades is a very long time. Most of the grafts get degenerated, and that is where Lima stands out. But other grafts, particularly the radial, if they have been taken, or the venous grafts in particular, they simply degenerate like anything, right? So therefore you can imagine that he becomes a high-risk patient. All CABG patients are high-risk, but such a long duration of CABG definitely becomes a high-risk subset of patient. So post PCI, this patient also underwent a post PCI to his native LCX in 2013 and 2022. 13 was somewhere else and 22 was done at our center. This patient at that point of time, when it was done in March 2022, had patent Lima to LED graft and patent LRA to RCA. So you can imagine that the circumflex was non-grafted vessel. There were only two grafts, one to the LED, one to the circumflex. Lima graft was patent and RCA graft was patent in March 2022. And this patient came in just at our election time. This was, on 5th of December, right? Like when we were voting. And this patient was very interesting. He was somehow involved in that election and he didn't get admitted with an inferior MI. It was a 3-day-old MI, ongoing pain, and he didn't get admitted. That I'll come back after the voting is done. So I mean, hats off to, Desh Bhakti. But that's okay. But this patient, I mean, if he had survived, good that he survived, he was able to vote and he also could come for a plasty to me. So, but not everybody is so lucky. So the thing was that ejection fraction was still good, and with this clinical detail on the third day, like when he came back after voting, these were his angiographical views. Okay, so I will show you the angiogram of the circumflex first. So this is the native circumflex. You could see that this was the stent which was put earlier. This was the original stent, and the other one which was put in March 2022 was somewhere below. So these circumflex stents look fine, right? They are patent, well flowing, and this was not the cause of his problem. There is some degree of, in-stent restenosis in the proximal part of the stent, but this was there. I confirmed with the old angiogram was there even in March 2022. So obviously this particular vessel did not require anything. The important thing to note here is the LED is totally occluded from the ostium. There is no LED coming from here. So this is the view, apicaudal view, wherein you see the left system. There is no, LED because the Lima graft is patent. So the native LED is occluded. The circ is doing fine. Let us look at RCA. As I told you, RCA was also grafted. So RCA is also occluded. You can see the clips. Can you appreciate the clips here? So this is, this is the radial artery clips. So surgeons normally when they graft vessels, when they put a venous graft, they do not put clips. But when they put arterial grafts, whether it's the Lima or the radial artery, they always put clips which can tell you the track of the graft. Okay, so this is the LRA graft. As you can see there, if you track this, it comes from here. So the LRA is coming from here. So if the RCA is occluded, which was the native vessel, the graft, what about the graft? The patient had an inferior MI. So if the circ is fine, there has to be something wrong with this graft. So that's the clinical sense and common sense. So let us look at LRA. Now look at LRA. So can you see this LRA? Radial artery. Left radial artery is totally occluded. And if you look at this red tailing, this is typically suggestive of thrombus. So this is full of muck, full of thrombus, full of anything that you can imagine, apart from, atheroma. So this is all the radial artery graft is left with. And so this is the cause of the problem, that radial artery graft to the RCA has occluded. And if you look at Lima, this is Lima. So you can see I could do it from the ulnar. Interestingly, I did it from the ulnar. The radial, because of the two procedures, ulnar radial was not available. So I did it from the ulnar artery, being very careful. I knew that, I could not compromise the ulnar now. So the Lima graft is patent. Okay. So the inference from the angiography was that I had to do something to the radial artery graft because this patient had inferior wall MI. Okay, so then what do I do? So as I told you, now if I don't do thrombosuction here, what is the role of thrombosuction? You could see that there is full of thrombus here. If I don't do thrombosuction, these grafts tend to have lot of problems, because if I do ballooning here, in our normal case, everything is going to go down. It is just going to clog the microcirculation, and this patient definitely is going to have slow flow, no reflow, and the patient will be in a mess. So therefore, this was an absolute perfect case wherein you need to do thrombosuction. So you could see that this is the thrombosuction catheter. Can you see the dot here? So this is thrombosuction, and by which we just aspirate whatever thrombus that we can aspirate. Okay, so you could see the first view. So I did it a couple of times, or rather 3-4 times. Try and aspirate as much as possible. Be very careful that you don't inject while the thrombosuction catheter is there, because again you are nullifying the benefit of thrombosuction. Everything will again go back into the system, right? So that is very, very important. And lo and behold, look at this moment when I did thrombosuction. Look at the artery. Can you see the artery now, which was looking so small in the earlier view? You could see that it has opened up beautifully without the use of a balloon. And you could see that the culprit lesion is somewhere here, right? And this was entirely occluded with thrombus and the graft was not seen. Now you could see the entire graft flowing, and now I can very easily put in a stent and come out. But these are the cases wherein you require, not very commonly imaging is done. And so with this case, I did imaging also to show you what exactly went wrong. Look at the etiology, what stent I will put, what size, and look at the thrombus. Can you appreciate the thrombus here? Sometimes it becomes very easy to say angiographically, what about the specimen? Look at this, what we aspirated. You could see a serpiginous thrombus, which we appreciated. Look at this, even bigger, right? And this becomes so convincing to explain to the patient also that this is what we aspirated. This was there in your artery, right? And if you continue to smoke and tobacco and, consume all those things, this is what is going to happen even in the future. So, it becomes very, very reassuring for us as well as for the patient to understand what has gone wrong. So we didn't end with this, we did imaging to this patient. So this is a typical, OCT run. So this is called as optical coherence tomography. Now these are beautiful images of the graft. Now remember, this is an arterial graft. So you will have the typical structure of an artery. And you know how an artery and a vein is made up of. So artery has media, which is not there with the vein. So a typical structure of the artery will be seen. And with this we decided what stent, because remember again, if I oversize the stent, again the patient will have no reflow or slow flow. So I have to be very precise in the size of the stent and at what pressure I need to go. And this was typically shown to me by OCT. So this is OCT, and I will stop at the point where there is something interesting. This is the lesion now which is coming. Just concentrate here. See the tightest portion? Can you see this portion here? So longitudinal view, this is where the lesion was, and this artery is full of thrombus here. And I would find out the cause of the block also. I will show you here when it comes back. These images will never be seen with angiography. This is OCT, a three-dimensional image looking inside the arterial wall. You could appreciate all the layers of the artery, intima, media, adventitia, the clot, the lipid plaque. So it is very typically a lipid plaque full of lipids, and you have to be very careful when you are inflating stents here, because if you don't do that, you are likely to have slow flow and no reflow. This is where a plaque rupture actually happened in this patient. So the cause of the problem here was plaque rupture. Plaque rupture is not commonly seen. It is not an angiographical diagnosis. It can only be seen by imaging. And that too, OCT is the most sensitive technique to actually show you a plaque rupture. So this patient had a plaque rupture, which you can see somewhere here. This is the plaque which has ruptured here, leading to thrombus accumulation. This is thrombus here. This is thrombus which has accumulated in the arterial wall and which has occluded the artery. And with this, I can actually show you, still images where you can appreciate it better. See this ruptured plaque. Can you see the two layers coming in, one above and one below? So that is a ruptured plaque, and with that the thrombus has accumulated. This is the tightest portion of the lesion. What I could appreciate, not only the etiology of the problem, but I could also appreciate the vessel diameter. So I precisely know 2 is 4. So I know what size of the stent to put and what length, because I can measure the length of the healthy artery from year to year, and with that I decided to put in a stent, and we put a 3 × 38. So exactly there, no ballooning required, directly took in the stent, inflated it at the nominal pressures because I know I don't want to go very high, and with that finally we did a post ballooning also, so that gentle ballooning, so that the stent gets totally apposed to the vessel wall. And with that so this was the final result. Look at the artery now. No slow flow, no reflow, absolutely TIMI3 flow, great blush, and the entire RCA is now filling up like it was a pristinely grafted artery in the very beginning. And this was the OCT which was done after the stenting. Now look at the modality, look at the stent grafts. You can look at the stent here. You can see all the struts very cleanly seen here. All of the struts are absolutely opposed to the arterial wall. Look at this. So this technique tells me whether I need to do something more to the stent, whether it has opposed well, whether it is under expanded, whether there is any edge dissection, because if you over expand there can be dissection also. So everything is seen very clearly, both in the longitudinal view and you could see the axial view also, and you could clearly cross-sectional view, and you could see the stent struts, beautifully seen stent struts, which can be seen only with this modality. So this case shows us so many things, right? It is a great case for learning, for looking at all modalities and what not to do in a post-bypass angioplasty, right? So well expanded and well opposed stent, excellent expansion and no other problems. So take home messages: Post-bypass ACS patients are very high-risk subsets, and we know that, as I said, lot of muck involved here. There is a tendency to have complications, particularly when you don't have devices down below. So be very gentle, and low pressure balloons, and always imaging, if available, is always a go-to modality. And last but not the least, the focus of my topic, you need to do it to believe it. So thrombosuction, here if there is thrombus, aspirate it, and you could actually see the difference. No ballooning required, no complications, patient goes home the next day. Thank you.
So is a clinical case, medical case. So patient had actually was a farmer, 68-year-old, living in some peripheral taluka level. He presented with gradually progressive dyspnea since 3 years. It was initially class 2 and then it became class 3 also. It is now class 3 actually. There was no history of associated angina, cough, syncope, paroxysmal nocturnal dyspnea or edema pit. He was non-diabetic, non-smoker, no adverse family history of ischemic heart disease. So he had history of appendicectomy before 20 years and surgery for bilateral carpal tunnel syndrome before 4 years. His initial evaluation was done at peripheral level, at district level. So when he was seen by a physician, he was in sinus rhythm. BP used to be around 140, 150 by 85, 90. JP was normal, no edema leg. He had fourth heart sound. Chest was clear, no liver enlargement. And biochemistry and lipids were normal. So some investigations were done. ECG was practically unremarkable. This was his X-ray chest. Nothing much. Echo was done. It was normal LV size. IVS and post-level thickness was borderline, 12 mm. So it was actually near LVH. And he had stage 1 diastolic dysfunction. EF was 60%. So initially, physician thought that it is a mild hypertension, what we call now heart failure with preserved ejection fraction. So he has a dyspnea class 2. He has LVH, diastolic dysfunction, and is contributed to mild hypertension, although BP was around 140 to 150 by 85, 90, but he had LVH. So, but he was treated in that case with hydrochlorothiazide at 12.5, spironolactone 25, and telmisartan 80 mg per day. Over next 3 years, symptoms worsened actually. BP, which was around 140 range, now is remaining on lower side, under 1080. So drug doses had to be reduced actually. So hydrochlorothiazide was stopped, telmisartan was reduced to 40. And echo showed, in between one echo was more echo were done, and echo showed LVH, dilated LARA, moderate MR, moderate TR, pulmonary artery hypertension now, and diagnosed to have now idiopathic restrictive cardiomyopathy. So at present status on first visit to CIMS, he is in class 3 dyspnea, he has history of PND, he has edema pit, he has dry cough, dizziness, tingling and numbness in the hands and feet. His pulse is 75, regular sinus rhythm. BP on lying down was 115 by 70, on standing it was 90 by 55, which was explaining his dizziness. JVP was raised, prominent V wave, bilateral mild edema pit. He had S3 gallop, soft systolic murmur at apex, bilateral basal collapse, liver was enlarged. His routine hematology and biochemistry did not show any significant thing. Renal function was normal, HbA1c was normal, liver function was normal. This was his ECG, this was his X-ray. So patient who had a 68-year-old male, farmer, gradually progressive dyspnea over last 3 years. Initially borderline hypertension, borderline LVH was seen, and that has progressed also. And he is now class 3 for dyspnea, now frank heart failure also. So this is his ECG, this is X-ray. Anybody, any resident, doctor, MD resident, want to describe something or want to suggest anything? Pardon? hyperinflation. Thyroid was normal, I told biochemistry is normal. Pericardial effusion, we'll do echo. So echo will be, next slide is echo only. So pericardial effusion is not there. What are X-ray findings? Let us discuss. Lung markings are seen right up to the periphery. But more important is, what is there? You see upper lobe vein. See, whenever you see X-ray, in X-ray chest, I used to take lecture on X-ray chest in GIC. Upper lobe, upper part of the X-ray vascularity is always half of the lower part of the chest. So basis should be having double vascularity compared to apex. Here it is almost reverse. You see upper lobe veins on both sides, those things which are going up. These are all veins. That suggests that patient has significant pulmonary venous hypertension. And if somebody has pulmonary venous hypertension, naturally he will complain of dyspnea. Dyspnea and exhaustion is a sign of pulmonary venous hypertension. And if you take X-ray chest, even on first X-ray actually pulmonary veins were prominent. So at that time also it was missed. But now it is very clearly seen. These are all pulmonary venous hypertension. If you want to describe further this X-ray, there is right atrial enlargement. Whenever this right atrial border occupies more than 3 rib space, intercalated space, half is here, one is here, one is here, half is here. So when 3 intercalated spaces are occupied by a right border, that means it is right atrial enlargement. Now you see, where is pulmonary bay? Normally this is pulmonary bay should be there and this border should be concave. Here it is convex. So it suggests that there is left atrial enlargement from X-ray chest. And you see cardiomegaly. Now whether it is outward or outward and downward. Looks like both. It's outward also and downward also. So there is biventricular enlargement also. So this X-ray shows pulmonary venous hypertension. It shows right atrial enlargement, LA enlargement and biventricular enlargement. So this much finding is there on this X-ray. Not very clear, but actually some curly bee line like things were also there. But in any case, what about ECG? So somebody told low voltage, especially here. Here also it is around 10. So this is okay. So low voltage is there. Sinus rhythm is still preserved. What you want? Anything more? Have you suggestion for any other tests? So one is echo. So echo should be there. Yeah. Then anything, any blood test also? Thyroid is done. Thyroid is normal. NT-proBNP is 1. Good, very good. Anything? So even troponin was done. That was raised, and NT-proBNP was markedly raised. So as you all suggested echo, so this is echo. Flex view, short axis view, and 4-chamber view. What are echo findings? Pardon? Cardiac amyloidosis. So there is, echo findings. What are echo findings? Good. So there is hypertrophy of RV, LV is hypertrophied, RV is also hypertrophied. Intratracheal septum is also slightly thickened. Even leaflets are slightly thickened. There is minimal pericardial effusion, maybe thin rim. And echo characteristics, myocardial texture is hyperrefractile, as he pointed out. There are various, so that slightly favors some kind of infiltrative disease also. Even it can be hyperkinetic in HCM also, hypertrophic cardiomyopathy also. There also, if it is a concentric LVH, then everything will be thick, and HCM can affect RV also. So somebody had already put diagnosis. lastly when he came to CIMS, he came with the diagnosis of restrictive cardiomyopathy because he had signs of restrictive heart disease. So ECG favored that, echo favored that, XHS favored that, and echo also is favoring same. Then restrictive heart disease means, I think we may overshoot, but let me discuss further. So normal LVRV size, filling pressure is high, so LA and RA are high, so there is MR and TR in spite of relatively preserved ejection fraction of LV and RV, so there is restrictive cardiomyopathy. So that was diagnosis put. So how to approach it to the patient with restrictive cardiomyopathy? So patient comes with heart failure with preserved ejection fraction. So what should be the diagnostic approach? So you should try to see, yes, ejection fraction and LV increased wall thickness or normal or minimally increased wall thickness. So when you have got increased wall thickness, which our patient has, it can be hypertensive heart disease, uncontrolled hypertension for many years. But here it was actually hypertension and there was no severe hypertension in past. So I think this diagnosis is out. He can have infiltrative restrictive cardiomyopathy, that remains yes, because there was hyperrefractile texture also and wall thickness was there. Hypertrophic cardiomyopathy is less likely because previously also otherwise before 3 years LV was looking good and this much rapid progression cannot occur in hypertrophic cardiomyopathy. And usually they present slightly early in life. If it was HCM, he should have come in 30s, 40s, 50s years of age. He is now 68. There is no family history. There is no arrhythmia also. So, and in hypertrophic cardiomyopathy with this kind of LVH, ECG shows very large QRS complexes, deep T wave inversion, STP changes, pseudo-infarct pattern and all that. So ECG was also not favoring. Clinical profile was not favoring HCM. If we think about high output state, that also can cause restrictive cardiomyopathy or restrictive pattern, but that is not there. Idiopathic restrictive cardiomyopathy was diagnosis which was put. It is still there, but in that case, this much wall thickness is usually not there. Constrictive pericarditis is also less likely because pericardium was normal here. So, if you think about infiltrative cardiomyopathy and restrictive cardiomyopathy, these are the two likely possibilities. Here, as somebody suggested, amyloidosis is the first diagnosis. Glycogen storage disease and Fabry's disease also can present with this kind of echo picture, but they come in early childhood. And they are also familial. So, this is also out. In restrictive cardiomyopathy of this kind, with not too much of wall thickness, but some wall thickness, endomyocardial fibrosis is another differential diagnosis, but then epices are actually filled. RV and LV epices are filled, which was not there. Apex were clear. Radiation heart disease also can present like this, but this patient has no history of radiation. Iron overload also can cause hemochromatosis, but that is also not there. There is no history of iron infusion or anything. So idiopathic restrictive cardiomyopathy was diagnosed, but it is less likely in this case because in idiopathic restrictive cardiomyopathy, wall thickness is not this much, and usually rapid progression like this also doesn't occur in 3 years. It is there, and usually wall thickness is just borderline. So, as you rightly pointed out, amyloidosis was suspected, but before that, you should try to do, if you get a strain pattern, you should try to see this LV strain. So, longitudinal strain is done. So, this is typical longitudinal strain pattern. Today morning, Dr. Milind Desai told that this is typical of amyloidosis, what we call cherry on top. Apex is having normal strain, while basis and mid and basal part has less strain. So, red is normal, this is reduced strain. So, cherry on top appearance on this cut section. So, that is typical of amyloidosis. And if you take tissue Doppler velocity, in constrictive pericarditis, it is more than 8. Here, everything is less than 5. So, if you take S wave, E wave, and E prime and A prime, everything is less than 5. So, 5 sign with apical sparing, this is typical of amyloidosis. So, this patient's clinical diagnosis at this stage after echocardiography is amyloidosis. Now, what is amyloidosis? I'll take 2 more minutes. It's a rare disease, but it is very, one has to diagnose because mortality is very high if it is If it is like plasma cell dyscrasia, survival is just 6 months. If it is wild type amyloidosis, patient lives for 4-5 years. So unless you diagnose and treat them, patient will not survive. So what is it? It is a protein misfolding disorder. There is normal protein like this. It actually just misfolds, and then it gets aggregated and it forms fiber like this. This fiber is insoluble and notably resistant to any kind of proteolysis. So it is notorious, and it gets deposited in the heart, kidney, liver, GI tract, lung, peripheral nerves, and any soft tissue. And usually this is either produced by bone marrow or it is produced by liver. When it is produced by bone marrow, it is caused by plasma cell proliferation. So there are abnormal clones of plasma cells which generate this kind of abnormal protein. They get misfolded and form filament, and then they get deposited in the various organs. So this is known as light chain amyloidosis, or what we call AL amyloidosis. Or it can be produced in liver. So liver produces this tetramer that breaks into dimers and then into monomers, and then they again get misfolded and they form amyloid fibril, and then they get deposited in the heart. So when they affect heart, it causes amyloidosis, what we call transthyretin amyloidosis. So this comes from the liver, AL comes, light chain comes from the bone marrow. Now you have to diagnose, because treatment is totally different. So what is the diagnostic approach? Our patient had amyloidosis, that is proven, but it is whether it's AL or ATTR. So how to approach? You do echo, you do MRI also. I will show you the next slide, CMR. So that is the first step. Once it is there, second step is to go for electrophoresis. So you have to do serum and urine protein electrophoresis with immunofixation method. Not routine, but immunofixation. And look for serum-free light chain assay. It is easily possible. Any laboratory can do this. And now if it is present, he goes to, then diagnosis is confirmed. It is AL amyloidosis, and he goes to hemato-oncologist. And then it will be treated like that. Now if hematological workup is normal, then he should go for cardiac scintigraphy, pyrophosphate nuclear scan. And if you see grade 3 uptake there, it diagnoses ATTR amyloidosis, which can be either mutant variety or wild type variety. You should try to do genetic testing and identify, because if it is hereditary or mutant type, then you have to screen family members also. So this is the MRI finding. Patient's wall thickness is there, but there is a lot of late gadolinium enhancement. These all white strips are late gadolinium enhancement of ventricle, atria, interatrial septum. So this is clearly positive MRI. So what we did, how to differentiate between two? Go for step 1 is do light chain assay and do serum immunofixation electrophoresis. Serum and urine both. If it is positive, then go for bone marrow biopsy, PET biopsy or rod biopsy to see whether other tissues are affected or no. If it is negative, then go for nuclear scan, technetium pyrophosphate scan. And if it is positive, then go for genetic testing, because if it is hereditary or mutant variety, you have to look the disease in the family members also. So what happened in our patient? Our patients, this was normal. Light chain were normal, immunofixation electrophoresis was normal. So this was not needed. So I went for technetium pyrophosphate scan. So this was the scan. Pyrophosphate scan was clearly positive. It is this pyrophosphate goes wherever bone is there, or calcium is there, not bone even, calcium. So this was clearly positive. So grade 3 myocardial uptake, more than even ribs and spine. So it is grade 3. Heart to contralateral lung ratio of this activity was more than 1.8. Clearly contralateral lung has very minimal uptake. Here it is clearly more. So once ratio is more than 1.8 at 1 hour, it is positive. So, and even on SPECT scan, it is clearly showing that it is in the myocardium, not in the LV cavity. If it is LV cavity, then you have injected and blood is circulating everywhere. So, cavity positivity is not to be counted. It has to be in the myocardium. So, this proved that it is pyrophosphate scan is grade 3 positive. So this patient has clear-cut transthyretin TTR type of cardiomyopathy. And then genetic testing. So this was positive, genetic testing was done, that was negative. So final diagnosis was a TTR type of wild type amyloidosis. What is treatment? Up till now, no treatment was available. Recently, since last 6 months, Pfizer has introduced tafamidis in India also. That is the only molecule. Now, theoretically, actually, there are 3 types of treatment available. One is TTR silencer. So these are small interfering RNA. They go to bone marrow and liver and they modify the gene and they modify RNA and they prevent the formation of amyloid itself also. So that is the best thing. Future will be there for this actually. At present, they are all investigationals. We have got TTR stabilizer. So whatever deposited is deposited, but you can prevent future further generation of amyloid from the liver. So this is the treatment. Okay. You give this tafamidis, at least further progression of the disease can be slowed down or curtailed, and patient can be better. So it is a selective stabilizer of TTR. New TTR will not be formed, new deposition will not be there. Whatever is there will remain. So tafamidis 61 milligram orally was started. After 3 months, patients functionally partly improved. 6-minute walk distance improved from 150 to 190. No further admission was required for heart failure. NT-proBNP reduced from 750 to 750 from 2500, and diuretic could be stopped also. Of course, ECG will remain same, echo findings will remain same. And last slide, what are the warning signs? See, usually this is the diagnosis which usually we don't keep in mind, and we may miss it for 3, 4, 5 years. That is all over the world, it is like this. So if you see any patient who has heart failure with reserved ejection fraction, especially in 60s or beyond 60, or if you see any patient with aortic stenosis who is elderly coming at old age, all this calcific aortic stenosis, they can have amyloidosis also. If patient is previously hypertensive but now has become hypotensive or normotensive, then suspect amyloidosis. If patient has sensory involvement or autonomic dysfunction, our patient had both. So that was a sign, peripheral neuropathy. Yet postural hypertension, autonomic neuropathy was there. Proteinuria can be there, skin bruising, bilateral carpal tunnel syndrome. See, I gave past history. 4 years back, he had bilateral carpal tunnel syndrome surgery. So that was also another clinical clue. He had signs of peripheral neuropathy, that was another clue. He had postural hypertension, that was third clue. Even clinically, by history only, it was there. But we don't keep in mind, because eyes cannot see what mind does not remember. We know it, but we had forgotten. We had studied this in our medicine, but we have forgotten. And of course, there is subendocardial or transmural LG. There is reduced longitudinal strain is there. Reduced with apical sparing, which was also seen in our case. Decreased QRS voltage to mass ratio. There is LVH on echo and very tiny complex on ECG. Of course, this is not seen in everybody. It is seen in around 50% of patients. But once it is there, it is very classic. No other infiltrative cardiomyopathy has this kind of ECG and echo non-correlation. Pseudo-QAV in ECG, which can be there in many cardiomyopathy. AV conduction disease can be there, various kind of heart block or even six sinus syndrome like thing, this can be there. And possible family history in a mutant or genetic type of ATTR cardiomyopathy. Last 2 slides. Diagnosis many times missed. So for this, to bring awareness, actually Pfizer has come out with the initiative all over India, and they have considered Marengo CIMS as the first center of excellence for amyloidosis in India. After that, they certified around 10 more centers all over India. So what we do is, we have got some certain protocol. Those who are referred to us like with this kind of patient, restrictive cardiomyopathy, all these tests can cost around 40,000 rupees. Nuclear scan up to genetic testing and immunofixation and all that. We do all this free of charge. Of course, that is reimbursed by Pfizer. And tafamidis is the treatment. What is the cost of tafamidis? Anybody knows? 1 year course is 1.2 crore rupees. So even nobody can afford, right? Unless patient is some company executive and he gets reimbursement. So Pfizer helps there also. There's on a compassionate basis, they give this drug also free of charge. Around all over India, some 7-8 patients are receiving this. We have requested government of India that this is a rare disease. So for rare disease, there is some health fund by central government. I mean, discussion is going on. Someday they may approve also, like Mayodna. For rare disease, government of India may approve also this cost. By this, at least you can prolong the patient's life, and at least whatever life is there, quality of life can improve. So if you get any kind of this suspicion patient, just send to me or send to CIMS, any of us, and we can do at least workup and prove the diagnosis. Suppose it is AL amyloidosis. We, after this, in last 6 months, we picked up 4 patients, but all 4 had AL amyloidosis, except this, and then they went to hemato-oncologist. So ultimately, they could also be saved. Thank you.
Just I am going to discuss with how to deal with the hypertension with the heart failure. 63-year-old, history of medical history, 1 year of the PTCA, RCA, history of the hypertensive, 12 year, ejection fraction 62%, NYH class 2. On examination, blood pressure is 138/84. She is little bit obese, 34. BMI, she is euvolemic, sinus rhythm 72. And currently, she is on the medication of ramipril 10 mg with the beta blocker, with the aspirin 75/81 mg, with the diuretic 48 mg, and rosuvastatin 40 mg. And on the right side, on the potassium is a little bit higher side, 5.1 millimoles. The ejection eGFR is 42 ml per minute, and pro-BNP is higher, 1850. And what will be guidelines of the national, international guidelines? Because of the heart failure, ejection fraction is preserved. Should we add spironolactone, DAPA, amlodipine, lanoxine, and whatever the arnin will be going to replacement or this is open discussions. What will be A, B, C, D? I am going to this particular. The underuse of this particular mineralocorticoid receptor antagonist in myocardial infarction complicated with heart failure. These are some of the 2 clinical trials of the Epic and Paradise MI in the 2001 with the combination with the seculopin, with the valsartan, with the remdesivir. Is a 42% of the patient treat with the mineralocorticoid receptor agonist, and ultimately this is the underuse of the last 20 years almost. The implementation of this MRA has been suboptimal use because we increase the physicians' awareness, novel potassium binding, and novel this particular the MI. The new requirement of the heart rate and heart failure, how to preserve the ejection fractions of this particular in patient with the preserve the ejection fractions. SGLT inhibitor can be benefit of the recurrent heart failure hospitalization as well as all-cause mortality, cardiovascular mortality in selected patients with the heart failure with preserved with the mineralocorticoid receptor may be considered the decrease the hospitalization who are having the low ejection fractions of the lower end of the spectrum is a class 2B with the BR, and in selected patient with the preserve the heart failure, arnin may be considered decrease the hospitalization, in particular who are having the low ejection fractions. Treatment of the preserve the cardiac of this particular, these are top active study are showing up this particular, the objective determine the treatment with the spironolactone can produce the clinical reduction of the possible endpoint of the cardiovascular mortality and about the cardiac arrest, recurrent hospitalization. Inclusion criteria were symptomatically heart failure, age more than 50, ejection fractions more than 45 with the hospitalization with the management, and pro-BNP more than 100 and less than 360, and major exclusion criteria. You can see that was not a placebo with the, some of the patients were put on the spironolactone with the placebo. Ultimately, in patient with the preserve the heart failure, spironolactone did not significant reduction of the heart failure. These are a summarize of the spironolactone with the this particular the top cat study are showing are there. The international guidelines, I am going to talk with this particular, she is pre-diabetic, HbA1c is 6.7, and she is obese, BMI is 34, and what about the SGLT inhibitor is a DAPA, is a considered as a 4 pillar of the heart failure with the preserve the ejection fraction. You can see if the heart failure is a good, ejection fraction is a good, is a DAPA according to all the national international guidelines, American Heart Association, with the European Heart Association, with the EMPA and DAPA is a very good, in particular these are significant. So potential mechanism of the improve the heart failure outcome of the SGLT inhibitor of this particular preserve the heart failure because of this SGLT inhibitor. Beauty of this molecule, not only it is a hypoglycemic agent, it is going to decrease the HbA1c, is a tune of the 0.8 to 0.9%. It can reduce the LV mass, it can reduce the epicardial fat. You can see of these preload, afterload, and ultimately patient is a lender, and 33% of the recurrent hospitalization because of the heart failure, all cause mortality can be reduced up to the 23% of the improvement of the clinical outcome and symptoms of the quality of the life with the preserve the heart failure once we are putting this particular the SGLT inhibitor. You can see of the after this particular second is a ARNI, reduce the BP is a particular, these are some of the mechanisms. I am not going to detailing of the already last 2 days we are going to discuss of this beautiful molecules of this particular, these are joint session of the Saudi Arab Association are going to say of do we the RCT data in the ARNI in the heart failure, moderate ejection fractions with the preserve. These are some of the data. It is very fantastic molecule. It can use in particular the heart failure with the preserve ejection fraction and with a moderate heart failure. So question of the considers how to deal with this. Suppose we are going to add this particular ARNI, ACE inhibitor, ARB, mineralocorticosteroid. What hypotension is a big issue in particular. Once we are going to treat with the heart failure of the. So hypotension is one of the very side effect of the heart failure treatment. Hypotension was noted side effect of the tune of the 6 to 8%. What rarely is now is a 1 to 3% as a serious adverse, and we have to withdraw the drugs. Lower blood pressure with the lower prognosis is a more common seen in the systolic heart failure of the hypotension, particularly orthostatic hypertension. I am seeing of this particular diabetic patient, already long term of the diabetic, they are having the autonomic dysfunction, they are having the autonomic orthostatic hypertension is big issue in particular. So why does low blood pressure is particular heart failure of the in patient with the impaired the LV function, systolic blood pressure and narrow pulse, because stroke volume are going to decrease and peripheral vascular resistance are going to increase. These are some of the issue of the cardiac predictor, treatment predictor, or other comorbid conditions just like diabetic and CKD, and treatment predictor with the guarded directed medical treatment and diuretics of this particular. So which drugs cause the BP lowering of the ARNI? Definitely moderate to large, but less obvious we can make of the dosage of the ACE inhibitor. ARB is a first line of treatment of the heart failure, but moderate hypotension can be. Beta blocker is a bisoprolol is a very good, or this particular is one of the pillars of the heart failure. MRA is a mineralocorticoid receptor agonist, spiroelectron, epidural is a minimum hypotension. SGLT inhibitor is a very fantastic. Patient is pre-diabetic, obese, and minimum to almost is a none. And hydrazine and other moderation low. Ivabrine is no effect of the loop diuretics. Some of the minimum to it depend upon the dose of the. So why must we overcome these problems of how to deal with this particular most severe heart failure patient get largest benefit from this particular GDMT. Patient with the low baseline blood pressure similar to the large reduction of risk, large blood drop don't appear to hamper the benefit from the drugs, and most GDM seems to the drugs just like beta clover. So decision tree from the management of the how these are how make of the step 1, step 2, step 3, step 2. Once we are going to treat with the patient with the hypertension, with the heart failure, or having the hypotension, how to deal with this particular hypotension of the step 1, step 2, step 3, step 4 of this particular. So these are a clinical pills. A small amount of all 4 pillars of the class is better than the large amount of the ones. keep the MRA SGLT meter on the cause, little BP effect of this effect, significant benefit, low diuretic of the empirical with the ARM, try again. These are a point. Kidney function, most of the we are seeing of the heart failure and most of the diabetic patients, they are coming with this particular CKD grade 1, 2, 3, 4, what about most of these are some of all the diabetic, pre-diabetic, what about we should calculate the eGFR of this particular, you can see of the clinical importance of the renal function of the heart failure, who are having the renal function, they are more prone to the heart failure. These are some of the clinical CKD of the comorbid condition, hypertension, diabetes, and ACVD of this particular. The expected slope of the eGFR of the heart failure, you can see heart failure is going to start with acute events, and what about the RAS and 1 ml and 2.3 and 5 ml of this particular. So these are a DAPA. She was a ideal candidate of this particular because pro-BNP is high, which preserve the ejection fractions of the tune of the 62, and these are studies are showing medical science is a clinical basis, and these are two clinical trials are showing of the DAPA CKD is a first treatment patient with the CKD with or without diabetic. I'm not talking with the patient with and without diabetic, with the improve the cardiorenal outcome, with the reduce the motility of the heart failure can be reduced of the tune of the 44%. All cause motility can be reduced of the 29% of this. You can see of the benefit of this particular the EMPA and DAPA of this particular. So major factor associated with the hyperkalemia. Most of the we are treat of the heart failure with some of the medicine. Hyperkalemia is a bigger issue because of the patient is already underlying the CKD of the ACE inhibitor, ARB, mineralocorticoid, the spironolactone, direct renin inhibitor, potassium beta blocker, digital mannitol, heparin, mannitol, cyclosporin, other these are some of the common medicines. They are going to precipitate the hyperkalemia of this particular. How to deal with the hyperkalemia? Suppose if potassium is more than 5 millimoles, I think we should not start with this particular the MRA, and questions of this particular MRA can be start with the low cost, and 5.5 MRA can be reduced up to the 50%, and ACE inhibitor the more than 6 ACE inhibitor, ARB, any combinations of this particular anin we should be avoid if the potassium is more than 6 millimoles of this particular. The summarize of this particular rethinking of the hyperkalemia to optimize of the RAS inhibitor therapy of this particular. So SGLT meter is a very powerful heart failure in particular who are having the preserve the ejection fraction. Either the patient is diabetic or non-diabetic. Already study has shown in the DAPA CKD, most patients with the heart failure, whether outpatient, inpatient, SGLT inhibitor is heart failure. Type 1 is out of this particular because of the chance of the ketoacidosis, and cautionary except the eGFR is less than 20, if the serum creatinine is more than 5, I think we should not go to this particular molecules, and risk of the genital infection and some of the local UTI can be occur, but that can be counseling by some of the patient. Risk of the decay, euglycemic decay, if the patient is on the insulin, secretogenesis, just like sulfonylurea. We should decrease the dose of the insulin. We should decrease the dose of the secretogenesis sulfonylurea to prevent the euglycemic ketoacidosis. Just like new paragraphs of the SGLT inhibitor, it is not only the anti-diabetic drug, not only going to decrease the HbA1c to the 0.7 to 0.8, it is a cardiovascular renal protections, and ultimately who are going to heart is going to victim, and it can reduce the heart failure. My key message of this particular by the case, single dose, either EMPA 10 or DAPA 10, no need of the dose adjustment, clinical benefit independent of the diabetic, it can be non-diabetic, diabetic, it can be given the grade 3 CKD. If the eGFR is less than 30, we can give same dose, same pill, single pill, 10 milligram, of the few side effect of this particular, because it does not work on the glucose dependent. Chance of the hypoglycemia is very less, and benefit of the heart failure preserve the ejection fraction of so definitely we should go with this particular this molecule of the DAPA 5 or 10 milligram with this particular reason of the underuse of the, I'm not going to detailing because of the practice consider of the use of SGLT inhibitor is A, B, C, D, E, F. A for we have to patient screening, educate, assessment. B stand for the assessment of the important variable, revise and background therapy, avoid the dehydrations of the divided because of the India is a tropical country and most we are seeing of the particular in summer and old and who are having the low diabetic, the chance of the dehydrations can be occur once we are putting of the SGLT inhibitor. Transit discontinue with some of the prior to any surgery because of the chance of the euglycemic ketoacidosis can be occur of the genital infection, but that can be counseling by this particular the what will be ideal of the heart failure of the initiation. 1 pills 1 day, no dose adjust, MPI or DAPA, we can start with a 10 milligram after breakfast. Substitute improve the survival, prevent the hospitalizations of the tune of 41%. All cause mortality can be reduced up to the 23%. Meaningful improvement quality of the life and function and benefit appear rapid within a day and few weeks because of the onset of action is very fast, exception is well tolerated and does not reduce the blood pressures and thus do the minimum no adverse kidney effect the CKD grade 3 or grade 4 if the eGFR is near to 20 and this molecule EMPA and DAPA can be given and it is affordable and accessible and charge is only 7 or 10 rupees of the per day of this particular. This case is going to and passage is 134 euvolemic. We should reduce the dose of furosemide and we should add this particular DPT-4 inhibitor. Already this slide has been seen in our previous speaker. Thank you for hearing me. These are a small
जीना है हमें जो स्वस्थ जीवन, रखना है हमें शुगर को कंट्रोल। जीना है हमें जो स्वस्थ जीवन, रखना है हमें शुगर को कंट्रोल। खाने से पहले 100 से 125, 150 के अंदर, खाने के बाद हो। जीना है हमें जो स्वस्थ जीवन, रखना है हमें शुगर को कंट्रोल। सुनो हमसे शुगर गर है।
Meanwhile, any question is there?
संभलना कैसा मेरी कसम, सुनो हमसे।
Only 10 slides and less than 10 minutes. First is a question. What is diabetes remission? Achieving A1C less than 6.5 without any medications. Second is with metformin alone. Third option A and B both. And last A1C of less than 6.5 with any drugs or insulin. I think no one is there for voting. The correct answer is all first three answers are correct. ADA recommends without any medications remission and some other body recommends with metformin alone. Second question is diabetes remission possible? Answer is obviously yes in selected cases. This is our case details. 34-year young male, known case of type 2 DM recently detected since last 2 years. On metformin 1 gram and glimepiride 2 milligram per day. Dyslipidemia since last 2 years. And obesity since last 2 years. Routine young male doing IT work. Patient's vitals are height is 5 foot 5 inch, weight 89 kg, so BMI is 31.5, falling in obesity class 1. Waist circumference is 40 inch. Patient's blood pressure is 139/84, so patient can have fall in criteria of hypertension, stage 1. Lab findings are there, A1C is 8.3, fasting 166, postprandial 235, total cholesterol 230, and LDL is 115. Acanthosis was present on examination. What modification we do with patient? there is a three type of modification. First is the diet modifications. When patient visited our clinic, patient was taking around 65 to 68% of carbohydrates, 8% of protein, 20 to 25% of fat, and 1% of dietary fiber. This is calculated of total calories per day. What change we did? We did gradually decrease in carbohydrate content of patient's diet at 3 months, 6 months, 9 months, and 12 months. Gradually we taper down patient's carb portion to around 50 to 52% from 65%. Then second major change we did was protein, increase in protein content. Patient was taking only 8% of protein content. We gradually increased to 18 to 20% at a 12-month interval. And fat, patient was already taking many junk food. Patient was already having around 20% of fat content in diet. So we did not modify it much. Then last change we did in diet was increase in dietary fiber from around 1% to 5 to 6%. In exercise, patient was having sedentary lifestyle, only going from home to office and office to home. And then we introduced gradually exercise from 5,000 steps per day to stretching exercises, aerobic exercises, and resistance exercises. At our first visit, patient was taking metformin 1 gram and glimepiride 2 milligram. Gradually, we decreased glimepiride after adding dapagliflozin 10 milligram on first visit of patient, because first A1C was 8.9. So patient diabetes was uncontrolled with existing medications. So we have to add on third medication. So dapagliflozin was added. Gradually, patient's diet, exercise, medicine all worked. And what results we achieved? Results at 12 months, patient's weight was 89 kg at first visit. At a period of 1 year, patient's weight decreased to 75 kg, around 14 kg weight loss. We can say 10 to 15% of body weight. Waist circumference was decreased from 40 each to 32 each. HbA1c was reduced from 8.9 to 6.4. Patient's blood pressure was also reduced from 130 to 138. Patient was systolic blood pressure, it decreased to around 130. Total cholesterol reduced from 220 to 176. LDL decreased from 115 to 90. And as patient SGPT, patient may having stage 1 NFLD. So SGPT was also reduced from 54 to 38 after weight loss of 14 kg. So in our case, what results we achieved was through diet, exercise, and medications, all three combined results. This was our case details. Now, what is current situation in our India? India is currently around 33% obesity rate is there in urban population, and in rural population around 20% obesity rate. This is the latest data of National Family Health Survey 4 and 5. Another urban study was done, which shows 73% of urban populations are overweight, and almost half of them are obese, means almost 50% of urban population is obese right now. This is current evidences to support our research, to support our work. Only the last 3 slides. Diabetes UK also recognizes diabetes remission. In their study, in first year, diabetes remission achieve rate was 45% of total participants, and at the end of second year, 70% were in remission stage out of what achieved diabetes remission in first year. So all our remission rate was 36% in diabetes UK study. This is another study which also describes that weight loss of 15 kg or more can land patient in diabetes remission stage. Here diabetes remission success rate was around 46% of total participants in study group, and only 4% of participants in control group. And this is our latest and our Indian study. Results are published just before 3 months on October 2022. It was a much larger study performed on 18,000 participants containing all states of India. It is conducted through ICMR India combined study. Here what our diet is important, it takes into the stage. If we decrease carbohydrate from around 70 to 65% to around 50%. Second is we increase protein from around 5-10% to 20%, and increase in dietary fiber. If we just modify patient's diet only, then we can have reversal ratio of around 70 to 80%. Was the remission ratio in these newly diagnosed diabetes patients with impaired glucose tolerance, and also old diabetes patient. So this study shows that only diet changes can have a much more impact on diabetes remission of patient. So take-home message is only two things are diabetes remission is possible, yes, definitely possible, and we should recognize obesity as an independent disease. Many prescription we don't see obesity as a diagnosis or as a part of disease.
So it's a case which came to us a few months back and was really an eye opener. So I think I should make it in front of you people. So there was a 53 years old male patient who was living in Rapar, Kutch, who presented with complaints of high grade fever for 3 days. There was a history of chest pain and breathlessness grade 3 for last 2 days. And there is no history of coughing, burning urination, headache, vomiting, muscle or joint pain. So if you see Kutch nowadays is a center of COVID. So new onset COVID are usually, most of them are coming from Kutch because of Run Festival or what. So our first suspicion was COVID. When we took a detailed history, what he told was that he had a recent history of myocardial infarction before 20 days. He was thrombolized in the hometown with streptokinase. He was kept in hospital for observation for 3 days. After that, he was shifted for coronary angiography, which showed a double vessel disease. He has undergone stage plasty of RCA and circ. He was discharged with TIMI2 flow with mildly LV dysfunction with LV ejection infection of 45% and trivial MR. So this is a classic case of myocardial infarction coming to the physicians practicing in peripheral or rural area. Everything went normal till that date. Then after 15 days of angioplasty, he started developing high-grade fever. There was a mild thrombophlebitis at the site of the procedure, for which he is applying local ointment and he was taking cefadroxil. The fever did not respond to the medicines at his hometown for 2 to 3 days. So he thought that something is fishy, let me go to a higher center. When he came to us, his physical findings were he had a high-grade fever of 104, he had a tachycardia and hypotension, oxygen saturation on room air was 94, respiratory system showed bilateral infrascapular crepitations, CVS examination was normal apart from tachycardia and pericardial rub, per abdomen was soft with no organomegaly, CNS examination was normal. His blood reports came like this. He had a leukocytosis with neutrophilic predominance. Platelet counts were 5,45,000. Sugar was normal. Liver function was normal except SGPT was 110. Procalcitonin was strong positive. Blood CS was negative till 48 hours. His C-reactive protein was 150. QBC for MP and Vidal were negative. Urine routine micro was showing 1 plus albumin. Apart from that, it was normal and COVID was normal. So from the reports, it was likely that he was suffering from a bacterial infection. His ECG showed ST depression in infralateral leads and the STs were down as compared to ECGs at his hometown. His chest X-ray was showing mild pulmonary congestion with borderline cardiomegaly. His 2D echo showed again infrabasal hypokinesia with thin rim of pericardial effusion. Nothing changed as compared to his previous echo. And his USG abdomen did not reveal any abnormality except mild splenomegaly. Now after admission, he was empirically started with cefoperazone sulbactam considering a bacterial infection. He was started with supportive medications like paracetamol and all. Antiplatelets were loaded once again. Even with treatment, his general condition kept on worsening. He continued to have a high-grade fever with persistent tachycardia and his look was toxic. On third day of admission, he had a sudden onset of hypotension with desaturation. His ECG showed ST elevation in inferior leads. 2D echo showed inferior hypokinesia with preserved wall thickness. There was a new onset of loculated pericardial effusion with thick internal septation, which was not there before 2 to 3 days. He was subjected to coronary angiography considering ST elevations. There was an aneurysmal dilatation of stented segment of right coronary artery. Pericardiosynthesis was done. It showed thick pus. After removal of pus, there was a mild improvement in symptoms. The fluid was sent for culture. During his angiography, he was also subjected to thrombus aspiration and POBA was done. He was then referred to cardiothoracic surgeon in view of two things. One, there was a pericardial effusion, and second, there was an aneurysmal dilatation of previously null segment. So the surgeon took him for the surgery, and what he found out was amazing. That there was a purulent fluid in pericardium with pus originating from right coronary artery from the stented site. The stent eventually was extracted, the aneurysm was excised, and the vessel was grafted. With removal of pus, patient gradually improved. The pus was sent for a culture. It was, as expected, MRSA, and he was subjected to ticoplanin for 14 days, and eventually he came out. So these type of patients are very, very common for people practicing in rural area or those who are practicing in urban area with a good availability of cath lab. That previously they used to be only on medical management. There was no availability of cath labs in peripheral area. So they were just subjected to medical management. Now, because of wide global and free availability of cath labs due to government plans, there are almost all districts of Gujarat have now cath labs functioning. So there are now more number of cases being performed in India as compared to those who were 10 years back. And there are now lapses in aseptic precautions in cath labs. And this stent-related infections are becoming more and more frequent. So whenever we used to practice in past, people of fever, we usually, with chest pain and breathlessness, the first thing which came to our mind was pneumonia. Nowadays, we should also keep cardiac things, cardiac infections there in our mind. And you really need to have an ultra-aggressive approach to deal with these kind of patients. And even after ultra-aggressive approach by cardiologists and cardiothoracic surgeons, we are still seeing very high mortality and morbidity in this type of patients. Thank you.